we'll get started. Thank you for coming today, and thank you for people coming online as well. So we'll get the TGG MAuth Study Day started. If you don't know who I am, my name is Constance. I'm the outgoing TGG chair. And we will have Robert, who is the incoming chair, coming a bit later as well. So just there is going to be a link available afterwards for you to be able to re-watch the whole day. There's one bit that won't be recorded, but we'll let you know beforehand which bit that is. But please don't take any photos of the slides as we're going through. If you're in the room, please keep your phones on silent. And the virtual delegates, you guys will have the option of writing a message, but if you wish to appear or put your hand up or speak at all, just let us know and we can give you the opportunity to put your camera on and speak. This is the first time we're ever doing a hybrid meeting, so if you have any technical issues, if you lose connection, just do as you usually do, sign out, sign back in, and you should be fine. If we have any bigger issues and we lose connection or whatever, the backup plan is that the study day will be recorded, so you should be all fine. You will possibly hear the buzzer going off in the background. That's just the buzzer for people coming in. Apologies, we can't change the sound of that, so you will just hear the buzzer going off. There's no fire alarm scheduled today, so if you hear an alarm, leave the building through the door that you came in, and I think we congregate at the bookies across the road. If you want to go in, that's all fine as well. What else to say? Toilets, you should know, in the corner or outside. There's hot and cold drinks available. Please go and help yourselves. And there will be lunch as well in the other room, in the David DeBias room. And we also have our sponsors too. We've got Jude from DB Dental, Sarah from Medenta, and Debbie from TOC. So please go and visit them as well. They might have some freebies as well. And then it's just speaking to the people who are presenting their clinical pearls. You should have all been given a separate link to be able to present in this meeting. If you haven't been given the link, please email us or message us and we'll chase that up for you. So without further ado, I'd like to introduce our first speaker, John Scaly. So he is a consultant and clinical lead at Royal Stoke Hospital, and he's also the vice chair of MAuth Edinburgh and also on the specialty advisory board as well. So I'd like to welcome John. So I'll help you get your presentation up.
Very good morning, world. Very good morning, room. It's a pleasure to be here on behalf of the Royal College. I feel like I'm at a police interview this morning, sat behind here. Somebody's just about to press record. I prefer to be walking up and down, so I'll try and stay a bit animated in front of the camera. If we've got questions as we go along, I'm happy to answer them. So, pleasure to be here on behalf of the Royal College to talk a bit about the Edinburgh MAuth and particularly the recent changes. So, what am I going to cover? Well, we're going to talk a bit about the structure of the exam, what to expect as a candidate, particularly for those of you in the first and second year, starts to get the collywobbles going a little bit and starts to get a bit of worry in the background. I hope we can reassure to find more information, and that's usually through the college website. So I'll give you a couple of areas that you can go to get some of this info that I'll present today. What are my personal expectations? Well, they're based on being an MAuth examiner now for 19 years and a postgraduate trainer for 19 years. So I've got a reasonable bit of experience in the background here now. And they're not, are you a gold medal candidate? That is not what this exam is about. Yes, we'd love everybody to do really well, but it's not about perfection, it's about safety. So are you a safe practitioner? And if you saw my cousin's kids, would I be happy that you would present a sensible plan that would leave them better off at the end and that you would communicate that well to the patient and the parent? So it's basic orthodontics that is safe and secure for your patients. Are you contemporary in your clinical knowledge? If you're going to treat everything with removable appliances and tip the teeth and have no idea about the other options, you're not going to be safe in the modern world. And can you provide that informed consent and communicate professionally and sensibly and nicely with your patients? You know, we want to be nice to our patients, and if you want to be successful, you want them coming back to see you. So how's the exam structured? Well, it's there to assess a candidate's core knowledge. Can we move the screen on the left from me? Okay. And that's the level expected of a specialist practitioner. This isn't consultant level, this is a specialist practitioner level. So particularly focuses on more routine cases. So you won't expect very highly complex interdisciplinary work, including orthognathic. But have no doubt, passing this exam means you've achieved something. It isn't a low level. Being safe and secure is not a low level. Amazing.
I'm just going to see whether I can close that for you. Can you not?
We'll just see if we can clear this out of the way so the screen's a bit more visible. That should be fine. Perfect. And this demonstrates a high level of expertise in both planning and carrying out treatment. And it's important for that safety aspect. Now, the first part, I heard somebody in the room saying, I'm doing the written exam next Monday. Is the written exam now? Previously, you only had to sit the written exam if you didn't have a written component to your master's. Now, to make sure that everybody coming through has a high level of knowledge, everybody sitting the Edinburgh exam now must pass the written. You cannot pass MAuth without the written exam being sat first. And that's based on the learning outcomes from the specialty curriculum and goes over everything on that curriculum. So it's really important you look at the breadth of things on the curriculum because all sorts can come up. And then there's the clinical exam. And there's been lots of talk about the recent changes, but those changes have simplified the exam now. The Part B component on the clinical side is very much based on your clinical acumen in terms of treatment planning and the longitudinal management of your care, and then testing your communication skills. So there's sort of 3 sections in that second part. So the written paper is now an exam of 4 hours. It used to be 3 hours, and the candidate feedback was it was too short a time and people felt pressed for time. And this isn't an exam about trying to do things as quickly as possible, it's to get your knowledge. And therefore we felt at the college to give you more time to answer the same amount of questions puts you under less pressure. We want to take that pressure away. So you'll have an exam of 4 hours with 2 papers. They are both taken on the same day in an exam centre. Now, at the moment, it depends on the number of candidates coming through, but they're run all over the world consecutively on the same day. The next one is available both in Edinburgh and Birmingham. For anybody who wants to go up from London, it's quite an easy journey up into the centre of Birmingham to the office there. There's a 30-minute comfort break in between papers to allow you to sort of gather your thoughts and prepare for the next section. Meach has 90 short best answer questions, and they are marked by a computer, so it's really important that you fill in your form accurately. Single best answer questions are available online to have a look at, and it's really important that you practice because they're a very specific way of managing your knowledge, and it's the best answer for that particular scenario that's given to you. And I do ask that you go and look at the website to look at some of the examples. Marks are not deducted. In the old days, when I sat fellowship back in the mid-90s, if you put the wrong answer down, you had a mark taken away. So, if you don't know, certainly put the guess down or your best guesstimate. But our general feeling is that the level of knowledge that's required is usually covered very well by the 3-year training programs in the UK. Failure is very rare for those trainees within the UK that sit at the appropriate time and have that base of knowledge. So let's talk about the clinical part of the exam. This is the part that often puts the fear among candidates. And this is looking at the 2 components. The first component is the diagnostic and mechanics cases. And we're going to focus a bit on mechanics on the next lecture that we do. I'm going to do a prepared mechanics scenario with Constance and put her through her paces. And this is definitely the part of the exam that everybody finds more stressful, because it's time limited. You've got a very short time to overview a case and get your information together. And therefore, we recognise that as examiners, we're not here to put you through the mill. We're here to relax you and get the best out of you. So don't worry about being stressed. That's part of sitting any exam. And this is set in 2 lots of 2 hours and they're split into 2 sessions. Now, because you will all see the same case, which means it's fair, nobody has a different case to look at. It's really important that if you're early in the day, you are often corralled. So you bring work with you that you can sit and look at while you're waiting in the college. because you're not allowed to have your phones and you're not allowed to go into the wide world. So it's important to check where you are on the day and bring sufficient information along that you can sit and carry on with some work, or bring your headphones so that you can chill out back there. The diagnostic session has 4 unseen cases, and the case history is about diagnostic records. These are the sort of things you have for every single one of your own cases. They are the sort of things that you will be doing and practicing with your clinicians. And if you're not, as you get to your 3rd year, you must start asking for practice on these sections. And then the mechanics section relates to 4 unseen cases on mechanics, and they have more clinical information. We'll look at that in a moment. You get 15 minutes with the case. So you get a decent amount of time to look at the records. You usually have time to go back and check your radiographs, check your information, and get it written down logically. You're allowed to take pen and paper in, and you're allowed to make as many notes as you like, but the examiners will keep those notes when you leave the room, so they can't be passed on to other people. So don't, if we're trying to drag that information back off you, that's just, again, for security and safety of the information coming through. Now, with the changes to the exam and the introduction of the mechanics, this is a slide I've taken from Toby Gilgrass, who's been sort of key in developing the mechanics exam up at the college. And I want you to look along the left-hand side here. We go all the way from the assessment of a patient down through to retention, and that's our normal treatment progress. And removing the cases, the worry was that we were losing that longitudinal care aspect. That's a really important part of managing your patient, not just getting the right treatment plan, but making that treatment plan work. And increasingly, we were seeing at the college fairly simple cases treated quite nicely, but not really showing a range of mechanics. And we felt that overall, and through pressure from the dean, it was better to move towards the mechanics section where everybody got the same questions. Of treatment. So if you think about the diagnostic cases, normally in the exam you'll have 2 examiners, and you'll get 50% of the time with each of the examiner. And the first part of that sort of 7.5 minutes is talking about the assessment, the radiographs, what did you find, building a problem list, and starting to think about your anchorage and your plan. And that often was leaking into the second stage with the second examiner, because there's a lot of information to pull together in those cases. So what you will find is within the diagnostic cases, you will cover everything in green and red quite clearly and in depth. And then as we were moving into treatment progression, depending on your treatment plan, often we would not get into the detail of the mechanics. We start to touch on that. We start to get an idea of whether you've got a workable plan. And depending on the candidate, you may push through into the purple areas in more depth. What the mechanics cases are to take over from that section at that part, the red part. So essentially this second section with the mechanics cases, you will have more clinical information about a case partway in treatment. And therefore the plan's already been made, and you will start to move into the mechanics, the anchorage evaluation, how you might change that. And therefore it becomes a continuum. It's just like the diagnostic case, but into that second section. And although you will briefly talk about the assessment and give a summary, the focus will be in this second section. So we will cover all those bases quite nicely within the 2 sets. In terms of diagnostic exam, it's the 4 cases. We have a large case bank and they're rotated regularly. Each case is put onto full A4 size, and you will not have study models. We now just give you digital printouts so that you've got accurate buccal segment relationships. So there will be no sort of, we used to have candidates shaking and rattling the models together like a pair of castanets. You don't need to do that these days. We all have a copy, and normally we'll open at the page and we will discuss the elements of that as we go along. If you have a pen and paper and you want to draw anything out to describe anything, that's fine as well. Just ask us, you'll have pen and paper ready. But it's much easier, I think, managing the cases this way. And what we're looking at is a potential successful plan. It's not the plan necessarily that I would produce. So just because I look at a case and think, well, I wouldn't do it that way, that's not how it's marked. For each of those cases, a panel of examiners has got together and listed every potential case option, all the anchorage issues that should be picked up, all the diagnostic issues that should be picked up. So there is very much a generic framework for each of those cases, And as long as your treatment plan and your anchorage management is safe, and it's on that list, it's incredibly rare that it isn't, then that would be acceptable. We don't drive our own treatment plans. Not about the gold standard. So you'll have 15 minutes, followed by the 15-minute Viva, and normally the bell rings halfway through. So it'll ring halfway through, you looking at the case, so you know you've got 7.5 minutes left, and halfway through to allow the examiner to pass on. And usually if you're at the end of one sentence, you'll move to the next sentence and then pass over to the examiner. We don't just stop rigid. We'll finish a line of questioning. We want the diagnostic features of the case. That should be bread and butter to you. You've all done new patient clinics. It's exactly what you do at the moment when you sit in front of your consultant and you present a case that you've just seen on the new patient clinic. And then we want to build a problem list. Look at the difficulties in that case. And I always suggest to candidates that they build that sequentially and they think logically about that. We often have problem lists that will come in like, there's a big overjet, and there's a skeletal pattern, and there's some crowding, and the patient's 15 and non-growing. What I'd like to see is pathology, because that rules everything down. Skeletal, that has the next greatest effect. Dental, soft tissue. And if you have that logically in your mind and take each of those and add one problem, two problems for each of those, logically you'll build a problem list very quickly, very succinctly, and very easily. So think about it logically in that way. And then we want to think about the treatment plan. We want to know why you've come to that treatment plan. If it's a nebulous case where 3 or 4 different options, we might say, well, did you think about any other options? And sometimes people go, oh yeah, well I had 2 or 3 and I picked this one. We'll often focus on the one that you think is your. We then press you for alternative options and we really want the nitty gritty. You've probably done pretty well already and sailed through that first section. And then if we have time, and particularly in the mechanics side, when we move on to that, I want to think about visit by visit. The amount of times somebody said, oh, yeah, I'd like to fit headgear to support anchorage in this case. And they can say, well, your upper molars are rotated like that. How easy do you think it's going to be to fit your headgear? And then people, okay, right, yeah, I'm probably going to have to derotate my molars first. Okay, how might you do that? So think logically about how you would set up your case. What brackets you're going to put on? Are you going to invert the brackets? Are you going to change their positions in any way to help facilitate the case? And again, that shows logical progression. It's pointless partway through treatment going, actually, I'm now going to reposition all my brackets to help my alignment, when actually you do that from the start. So try and think about your early setup of the case, because that helps it progress. I do have an alternative plan, but it's not always essential. Like I say, normally if we're pushing for an alternative plan, either we're not happy with your current plan, or you've done really well and already talked about your main plan already. So stick to first principles. Yeah. Skeletal, dental, soft tissue, AP, transverse, vertical. Go through each of those and think about how you might manage different aspects of it. Straight away, camouflage or growth modification. I put surgery in brackets. If you've got a case in front of you and it's a class 3 case and you go, oh, they're 14, I think I'd wait a year. What we're going to do, sit there for a year while we think about potential plan for this patient. The case in front of you is there for treatment planning. And it's okay to say, well, I'm worried that this patient might grow. I might start in the upper arch and I might review whether I start treating the lower arch 9 to 12 months in and monitor their growth and height. Generally, for these cases, you're working to best principles. We've got the best patient who's growing favorably and going to wear everything you throw at them. Okay, we might then throw into the mix, okay, well, what if the patient grows? What if they grow adversely? What might you have to do then? And if you said at the start, well, this is a borderline case, it may be considered for surgery, but I think it is manageable orthodontically. But if the patient grows unfavorably, there could be issues. That's fine. But we're here to talk about an orthodontic case. Surgery isn't generally part of the M-Orth exam. That's an ISFE thing. So think about an orthodontic camouflage plan almost certainly. But is it camouflage? Could you use growth modification in some way? Always start from your lower arch. Your lower arch is your template. So you look at the lower arch and decide, is it non-extraction or not? Why would you extract teeth in an arch? Changing inclination, dissolving crowding, deepening an overbite. There are lots of different reasons. And we want justification if you do want to take out teeth and why that particular tooth. once you've built your lower arch, you know how your upper arch is going to fit against it. If you're moving your lower canine distally in any way, shape, or form, that's going to change the anchorage balance between your upper and lower arch. Now, what would that relationship be? If I treated the lower arch only and then reviewed my upper canine, where is that now going to be? Does that make my anchorage more favorable? Does it move a class 3 case into class 1, for example? Or does it make a class 2 case worse because I'm retracting the canine and therefore my anchorage becomes maximum in the upper arch? So think carefully about where things are going to end up and then your anchorage balance. Do you need distal movement? A very common mistake is to look at a case with 4 extractions that's a full unit class 2, knowing that you're going to have to achieve class 1 at the end. But how are you going to do that without changing the position of your upper molar as well? Because either you need some mandibular movement forwards or you need further distalization in the upper arch. So think carefully about, do you need extra movement in a full unit class 2? So assume best cooperation. Yeah, we'll throw into the mix, okay, they haven't worn their headgear, what are you going to do now? But in general, we want you to think about the best plan for that patient should they wear everything that we give them. And top marks come from supporting your decisions with an evidence base. So it's about saying, oh, so-and-so mentioned use of this appliance, it was successful in, and it has, a twin block will produce about sort of 20-30% skeletal change, but this is a mild skeletal pattern. It needs a lot of dental alveolar tip, and I think that will be supported by papers by O'Brien, etc. So if you add in at the end of each sentence that you're talking about, the moderate crowding that I see here, it's moderate, as opposed, if you quote Profit, it's just adding somebody in at the end and a paper that will support your treatment planning and your diagnosis, and that will get you better marks. Practice these. Your senior registrars in particular, who will hate me for saying this, are the best people to go to. They've sat the exam, they know the sort of thing that's needed, they'll have lots of case material, and it's useful practice for them to get into examining as well. So, you can now it can be done virtually. It's a very easy thing to do virtually, and actually you'll get the same set of records that you would get at the college. It's all in A4 paper that you can turn over virtually, so there's no reason why you can't do these in the evening with people. So just pester them and plan ahead so that as a group you all get some experience doing them. You need to score 3 across all domains, and we'll look at the scoring system in a moment. But now that you can cross-compensate between the mechanics and the diagnostic cases, there are more cases to compensate across. And I think that's really important because everybody has a bad case. Everybody comes out and goes, God, that was awful. I didn't think my plan was going to work there. I thought the questioning was difficult. And you feel really down, and you've got to turn over the page and move to the next case. Chances are, even if you've got a low mark, a 1 or a 2, so I wouldn't put your head down if you think you've had a bad case, because spread over these 8 cases, there's a good chance of compensating with sensible plans. And it's never quite as bad as you think. You always think the worst of yourself. People who fail generally fail every case or multiples of cases. And examiners come out from their mark and go, oh, that was a bad session. I failed a couple of people and I feel quite bad about it. And then we come back and look at the marks at the end, and those candidates normally have failed multiple cases along. So we're fairly consistent in our marking. So we can talk a bit more about mechanics cases in a moment, but they're going to look pretty much like the diagnostic cases. And the information that you will get will be some start records, but also some mid-treatment records. And they may just be right at the start of treatment after some extractions. They could be 9-12 months in with things going wrong. And they'll have the basis of a plan given to you already. So somebody's made that decision. 2 examiners will mark you, but because of the longevity and the longitudinal nature of the discussion here, we don't want to split that up partway through. So 1 examiner will carry you all the way through talking about a treatment plan. We felt it'd be too disjointed to swap between examiners, but you will be marked by both examiners. Think of it as a transfer case. We've all seen transfer cases that walk in for the first time and you're like, right, where are we at? Where was this case? Have we got the start records? Where are they now? How much have they moved in their treatment plan? Was this treatment plan sensible? Is this going to be a problem trying to achieve the aims that clearly they wanted? Is it going wrong in some way, shape or form? Are the brackets in the right place? Have they got the right brackets on? What archwire sequence are they in? In the lower arch with a 6mm midline diastema in the lower arch. And finding out the questioning from that was quite difficult. How on earth do you spend 18 months in treatment and still in an 016 with a big diastema? And that patient had been booked regularly with a therapist every 6 weeks for 18 months, and they just retired and retired and retired after 2 extractions. So you're getting a feel for where the case is at, but straight away that case needed surgery, needed the diastema closing. So straight away you're building up the next sequence of care to take that patient to the end point. So are they making good progress? Does the plan look viable and is it working? What are the current mechanics? And how is anchorage being managed in all 3 planes? Yeah, when you're in the exam, the focus always seems to be AP, AP. Don't forget vertical and transverse, yeah, because these cases will have elements of all of these. What might the alternatives have been? Was the plan right? Could you have picked a different plan? Do you think your plan would be more workable than this? And this is okay. This isn't a consultant bringing their baby to show you, and you go, oh, ugly, isn't it? Yeah, this is a case where they have brought you information that is generic, and we want to look at all the potential options and whether that was the right option in this case. And what's the next sequence? Okay, if that's a plan, how are we going to make that plan work from here? And retention. Think about your retention for these cases, because you will definitely get a question on retention in the mechanics section. If you haven't thought about that and why, and with some evidence base, you miss out on a potential higher mark, as that marking fits with it. And this is part of our marking rubric. We can't show you all the details, but you're marked from 1 to 5, and this is how it will run. So you'll have the analysis of the current situation, the mechanics utilized, the anchorage challenges, mechanics to accomplish objectives, and retention. So you can see we're going to mark each of those sections 1 to 5, and each examiner will give that mark. So how are things progressing, do you think? Describe the mechanics that we've got going on at the moment. What do you think the anchorage challenges are in this case? And how might they change as things move on? Do you think it's worse now than it was at the start? And how might you progress this case? There's some teeth that need picking up. What brackets are you going to put on those? How are you going to pick up the teeth? Are you going to step back? Are you going to use piggyback mechanics? And how might you retain this case at the end? So if you think about a transfer case and think about those, you will already build yourself paragraphs to talk about to the examiners quite clearly in the 15 minutes that you'll have for these cases. And if we look at the scores, we've just put in scores of 2, 3, and 5 here. But if you're scoring 2, which essentially would be a fail score, you've got limited information about the current situation, you're limited explanations about the mechanics, you're missing key aspects of what's going on about the anchorage, and you really don't know where to go with this case or how to retain it. And that, for most candidates, is unlikely. But if you want to get everything at the end, then you've got all the features, you've given some evidence, you've got comprehensive explanation, it's detailed, and you've got a detailed appraisal, and you know about the potential alternatives in the case. So to get the higher scores, you've really got a comprehensive grasp of the case. But the score of 3, where you pass, is most features. The explanation and the impact of the current mechanics is pretty well known, and you've got the key aspects of the case. We're not asking for perfection, we're asking for safe appreciation of the case. If you want to look up one of these cases and have a bit of a practice, if you go onto the Royal College website, you'll have lots of different documents that you can upload and have a look at for yourself, and each part of the exam is available. If you highlight this one, Membership in Orthodontics Mechanics Records, you'll get a set of records. Now, don't look at these in too much detail. What I suggest you do is print them out and give them to somebody else to test you on it. Rather than you sit and look at this case in a lot of detail, you can go back and look at it later on, but I would give it and practice with that now. And you can see the sort of records that you will get. You'll get the standard sort of thing that you see on a short case diagnostic. You'll get the KEF and the trace KEF if there is one, and a bit of information about where the patient's currently up to and what appliances are in. We'll look at that in a moment. Now, the final component is the OSCEs. We're going to do a couple of those, Colin and I, for Constance later on. It's going to be put through her paces. But we used to just have one OSCE. And again, if you have one OSCE that goes badly, you could fail the whole exam. And we felt that was unfair. So we now have 4 OSCEs that you can compensate across. And they're 15 minutes assessment. and then you have 10 minutes with the patient. And we're looking at safe, sensible communication. And for each scenario, you'll be given clear instructions. It will tell you what's expected of you, what the patient's presenting, and what they would like to discuss. And then you just need to do what you do every day in front of your patients and chat to them in a friendly way with no jargon and explain what's going on and answer their questions truthfully. So it's 15 minutes overall. Get 5 minutes. It literally is a short paragraph. 10 minutes with the actor. The examiner themselves is just one examiner and they will stand back. They make no interjection at all. I think the only time we would step in is if you start threatening the patient, or we have had situations where we had one particular candidate who stepped in and started options for managing this. You are a disgrace to your family. You should wear your twinblock. So that sort of thing we might step in at, and that's incredibly rare. But in general, as long as you're conversing sensibly with the patient, we stand back and allow it to run. And even if you finish early and there are no further questions, you would be told, just wait until the bell goes. And normally if there's no further questions, you've probably covered all the bases by now. Again, if you want to have a look at an OSCE, there is an OSCE scenario available in the downloads here. And this is the sort of thing that you'll get, a sheet of A4, and it tells you very clearly what the exam is about. And then it gives you the scenario. So you'll normally have a short burst of information. You're seeing an adult patient for the first time. They've not seen their dentist for a number of years, and they're getting toothache. There's no braces on yet. But the dentist has previously proposed a plan without extractions and suggested the duration of treatment would be 6 months. You know, a typical thing that's going to come walking through your door in the next few years of you being a specialist. You know, well, I've seen the GDP down the road. He's doing 6 month smiles and he wants to treat this by just wanging all my teeth out of the bone. The patient's very crowded and you're unhappy with that approach. So it gives you your pathway in. So you've got to explain your treatment plan to the patient, and you must talk about fixed appliances and extractions and explain to them why. And the actors are well trained. They've been doing these scenarios for many years. They work really well. They understand what goes on with these scenarios quite well now. And we have a training session with them up front as well, so that they know the sort of questions to ask and buttons to press. Yeah, but my dentist said it would cost a lot less and be quicker if I didn't have teeth. How to approach this section? It's all about communication. It's what you do every day. Yeah, it's no different to you sitting down, greeting your patient in the chair. How are you? My name's so-and-so. How can I help you today? I understand that you've seen your dentist and discussed this. So introduce yourself, who you are, and what you're there. Don't do a full medical history. Can I just check you're fitting well? Let's move on. Body language, eye contact. Yeah, and friendly, but not over friendly. Stroking their hand and then started stroking their knee. And we were like, do we step in? That's not really appropriate behavior. This is professionalism as well. So be friendly, but please not over friendly with them. Listen. Yeah, one of the key skills about communication is listening to what they're asking. And if every time the patient goes to ask a question, you're talking over them, that won't go down well. And we ask the actor to mark you as well. So it's really important that they feel they've been listened to and that you answer their questions directly. And check that you understand. So from what I understand, you're asking about that, or you're concerned about that. Is that right? And get them to confirm that. Have I got it right? You're worried about the teeth being removed? Can I explain that in more detail? And it just clarifies, and it also gives you a little bit of thinking time if you need. So answer their questions. Please don't dodge around it. And although this isn't about the clinical information you give them, if all you're talking is rubbish to the patient, that is also going to be seen as unfavourable. And be empathetic if, you know, the patient's upset about something. So yeah, I can understand how you feel about that. Let's see if we can give you more information so that you feel happy about that and maybe give you some time to think about it. Avoid jargon. Pretend you have props. Props are great. Well, as we can see from your x-ray here, actually, this tooth here has got a really bad root. It's really short and damaged. And actually, if we start to try and line up the teeth here, there's a good chance this tooth could fall out. don't make all of it up, but use the information that's given to you in the scenario that you would have chair side. One of my own registrars from overseas, who's now a very successful orthodontist in Kuwait, had these fixed appliances on that I was treating, and well, his was all about oral hygiene, and he just happened to have in his pocket a toothbrush. Talk about things that you know every day and pretend things are there as well to use. And do you understand? Have I answered your questions? So, examiners want to pass you guys. Keep calm. Don't speak too quickly when you talk about, like, if you've got the cluster division, cluster speaker base, we can't hear you. So if we're asking you to slow down, just take a breath. If we want to get the information out of you, and sometimes, as the examiner who's listening and not examining, one examiner might say, well, they didn't mention the class 2. And I'll say, well, they did, but they were speaking so fast we couldn't hear it. And it's good to have 2 examiners, but slowing yourself down a little bit, you'll still get through all the information. Sometimes if you're not sure, repeat the question or repeat clarification, just like you would with a communication test. So you're asking me about the validity of taking out a lower incisor there. Is that right? Yes. Might get yourself a bit of time to think, but don't waste time. And do what you do. Try not to treat something clinically for the first time. So I've got a mild anterior open bite. I'd like to do 4 TADs, posterior intrusion, and extraction of 4 6s. You ever done that before? I've got no idea. No, I've never done that. Unless you've done something regularly, it's really difficult to talk fluently about that plan. Now, you may have a plan that you think would work, and somebody goes, well, that might be difficult. Can you think of something else? Well, you could use TADs. I don't have any experience in TADs, but I've seen cases where the TADs are put in on the palate with a TPA and produced posterior intrusive force, and that could potentially help. That's okay. Don't be afraid to ask for clarification. And if you don't know, just say so and move on. It's okay. If you say don't know to everything, there's a good chance you may not pass. But the odd question is absolutely fine. There's a few dates for your diary here. Like I say, 31st is the first of the papers, but the next paper, which will be held in Birmingham and Edinburgh in this country, is on the 18th of April this year. And it's nice to get that out of the way. It's a good way of building your revision plan before you sit the MAuth in the May. And then our May diet this year will be the 2nd to 5th of May. It's usually the first week of May each year. And we have a second diet in September between the 11th and the 14th. There will be a webinar that I know we've already got about 450 people signed up for next month. Myself, Colin and Toby Gilgrass will be going through the process of the exam with a few hints and tips again. And then we've got an online process course, which Colin's going to talk about in a moment. There's a bit of info there, but I'm going to move on because we're tight for time. You can come back to this later on for more information. So I'm now going to be joined by a high-level candidate. Welcome, Constance.
Okay. So, right. So
you're all on screen. Yeah.
We assume so. Neil, we all good?
If you see the buttons of PowerPoint, you can't see you two on camera. So you need to bring back the PowerPoint.
Bring back.
What you need to edit the PowerPoint.
We sort of need a bit of both.
Okay. Which case you can
If
now
I-
use screen.
Is that okay?
Is that okay? I think, yes.
Yep, you can see it.
So how we've run this course in the past is to give you a flavour of how a Viva might run. And particularly with the new mechanics case and the uncertainty of that, I thought it would be sensible to look at the mechanics one. So Constance has had a look at these records already, so we're not going to based on the rubric that I've just shown you, and we'll have a bit of a chat. Because we're tight for time, we'll have a look at where we are in the schedule. I've got a second case that you can have a look at. If not, it's available in your notes for you to have a look and think about and maybe show your own examiners. But we'll concentrate on this first case.
So we've got until about 10 o'clock, just after
Fine.
10.
So we will try and move
let's
it. We
see.
started a little bit late, but
Yeah.
let's move down.
If Colin doesn't mind if we run a little bit later as well.
So, for summary, this is a 13-year-old girl. She came in complaining about her gappy teeth. She's missing up a lateral incisor. So we've got a common clinical problem. This isn't a severe hypodontia case. It's a mild hypodontia case within the framework of the MAuth exam. There's an impacted upper left canine associated with it, which we know is quite common when lateral incisors are missed. A lateral cap wasn't taken. They think about whether that will be questioned or not. The plan developed was to close the upper arch space, taking out the upper right C, which was still retained, bringing in the impacted canine on the left-hand side and closing all the spaces. Now, the patient's been in treatment approximately 9 months, and they are currently in 1925 stainless steel upper and lower arch wires. Okay, there's your basis. So you've got the pictures there. So pretty much class 1. What would you say about her profile? She's a little bit retrusive. She's got a low smile line. That's a current occlusion. Let you have a look yourselves.
Really? Okay, no, it's either CS or not. Yeah, I think we're just going to have to do.
That's fine. That's fine.
Yeah.
That's the current arch forms. That's a start OPG. This is a current position in the upper and lower arches with the 1925 steels in place. Okay, so just like a short case, but with this extra bit of information showing where the patients are at. And often these cases will have a bit more about them. There's something to discuss. The point is giving you a very simple case where there's nothing to discuss about how you might progress. And the canine has come down. Now, you might just see here, just so you can see for clarity, that is the canine having just erupted into the palate on the left-hand side. Okay. Right. A very good morning.
Good morning.
So I believe you had a little look at this case. I wonder if you can just give me a quick summary of this case as a diagnostic and mechanics case.
So she is now a 14-year-old.
Yeah.
Class 1, skeletal 1, slightly bimaxillary retrusive.
Yeah.
Average vertical proportions. And she's complicated by an ectopic, unerupted upper left canine, which now you've pointed out actually has come through.
Yeah.
And she's currently in upper and lower fixed orthodontic appliances. It looks like she's in a rectangular stainless steel wires, up and lower. And I believe she's in space closure as well.
Space closure. Okay. So let's go from the start. Were there any particular concerns you had about the treatment plan? So let's think about the plan here was to close some space, wasn't it?
Yeah.
Okay.
So that is a valid option. However, I think that there's a lot of space to close because on the upper left 2-3 region, we've got quite almost 15 millimeters of space.
Okay.
That's a lot of space to close down in that area. Also, she's 13 years old. I would have imagined her canine would have come through by now. So
Okay.
that is delayed. So I'd have to think about, was there any reasons for that delay?
So in terms of the treatment plan and leaving the canine, because obviously they've not done anything with it at all,
Yeah.
do you think that was sensible? Would you have changed that aspect of it?
I guess I would want to know how long the other one had been through for. Because
Okay.
sometimes you do put appliances on, maybe move the teeth, say the upper left central, moving that across a bit, and that might encourage the upper left canine to come through. So I wouldn't want to leave it more than, say, 6 months
Okay.
for the teeth to come
So
down.
it's been 9 months, it's come through here, but we're on dodgy ground if we leave it too long in that case. Anything else you note from the start that you need to have a look at here?
With her, I wasn't sure about her lip, but she might.
So let's move straight on to these particular pictures. So you mentioned she was in 1925 steel, which was the information given to you. Do you notice anything unusual about the brackets in the upper arch here?
There is a bracket that's, I think, on the upper right 3. It
Yeah.
looks like it's not a normal upper right 3 bracket because the dot's kind of inverted.
Okay.
So that's a different bracket descriptioning.
What option do you think they've picked for that tooth and why?
So usually you would take a bracket that's got a -7 buccal root torque for a canine.
Yeah.
If you invert it, you get +7.
Okay.
So that's more similar to an incisor bracket, which is what you'd want for this tooth. You're mimicking it as a lateral
What would you
bracket.
use? What's your routine if you're discarding a
I-
canine as
I
well?
usually use that. You
Okay.
can. There are other alternatives. You can use a lateral bracket, but I find that those are quite small and they don't fit the contour of a canine so well.
Yeah.
Or you can use like a lower contralateral, lower premolar bracket as well.
What torque does that give you? Do you know?
17 or 12, something like that. Sorry, I don't know.
So what other mechanics are ongoing here? And there's something else about these brackets that might help mechanics. Have you noticed that?
So the premolar brackets look different. So
Yeah.
I think they may be involved in kind of reducing the anchorage in those areas.
If I told you that was a self-ligating bracket,
Okay.
does that make a difference to how these mechanics are working, and why do you think a self-ligating bracket might have been used?
Yes, so self-ligating usually has reduced friction
Okay.
because it's got its own mechanism to click in the wire. There's less friction from rather than using a normal lace or a steel leg. So that would really help, because in this case, we're trying to protract the buccal segments and close the space by moving everything forwards. So that will reduce the friction and let the teeth come forwards more. So that would help in this case.
There's a bit of an open bite going on at the moment. Does that worry you?
There is GIC blocks, or the blue glue,
Yeah.
on the 6s, so that's propped them open.
Okay. Why do you think that's there? What's the point of putting that on?
So she's skeletal 1 and she's quite well interdigitated.
Yeah.
So that could cause problems when you're trying to move the teeth, because the teeth are locked together.
Yeah.
So I assume that they've propped open the bite to help the teeth move more as well, so they're not locked in by the bites.
Okay. Now, you mentioned before about the size of the space to close. It's a big space to
Yes.
close, and therefore, where's our anchorage demands in this case, and what options do we have, do you think, for helping manage those anchorage demands?
So we are at risk of having less anterior anchorage, so we're at risk of turning her into class 3. Front. So here they have overtied the centrals and the lateral. At least that's one anchor unit.
Yeah.
And they've broken down the anchorage on the right hand side by using power chain, just to bring that one premolar forwards.
Okay, so trying to do tooth by tooth rather
Tooth
than
by
all
tooth,
together.
yeah.
Now, if you did want to try and, obviously that's less efficient, it's going to take
Yeah.
longer. How might you build some anterior anchorage in this case? What else could you do to improve your anterior anchorage?
So another simple thing is using class 3 elastics, so
Okay.
inter-arch elastics. So from the 6s to kind of the low anteriors to try and help bring those forwards.
Any disadvantages of elastics?
So 1 is compliance.
Yeah.
2 is also it's all on the back teeth, and it's also got an extrusive force as well, because you've got
Okay.
a kind of the vector.
Was the overbite a
Yeah.
problem in this case, do you think?
I can't remember. I think she was an average overbite at the start.
Yeah, so maybe that won't be a huge
So it
issue if
won't.
we go
Yeah.
back to there, but it's certainly something we need to be careful of. So that's one way, class 3 elastics.
Mhm.
Anything else we can do? Do you think that would be
So-
enough, class 3 elastics in
No,
this case?
it wouldn't be enough. I've heard of this before. I've not used it, but you can use protraction face masks.
Okay.
So you could put 2 little hooks on the wire,
Yeah.
and then run a protraction face mask to pull everything forward. So that will help to maintain the class 3 as well.
I've certainly seen it used. Do you think that's viable in a 14-year-old girl?
It
How many
depends
hours
on-
do you think she'd need to wear that?
At least 12 hours, like evening and nighttime wear. For a teenager, I think it depends on them.
Yeah.
And I think you'd have to tell them from the start if you're going to use it. I think to throw it in halfway through.
I think
might
throwing that
be a
in
bit-
halfway, you may lose your patience, certainly. Okay, let's think more contemporarily now. So we've got class 3 elastic.
Could use mini screws. or
Mini screws,
tags.
okay.
Yes.
Now, how are you going to place mini screws in this case to help you move the teeth? Do you know?
So there's different ways. There's direct and indirect ways.
Okay.
So one kind of indirect way I prefer is putting tads in the labial area between the 1 and the 3
Okay.
to there.
Where do you think you'd be able to put those in terms of being safe between the roots?
They'd have to be quite high, and they'd have
Okay.
to be kind of in between the 1 and 3, so quite
Yep.
high up. And then I could tie a ligature from the teeth on the wire to the tad. So
Okay.
that's indirect. So that's essentially
Are there any
holding my
potential
anterior.
detrimental effects of that?
Um,
What could happen?
So you can get a loss of irritation, because that's going to be so high up for the patient.
Yeah, I was thinking about
Um,
maybe unfavourable tooth movement that might occur with that.
so if you don't tie everything together, things can drift as well.
What if you
Um,
tied it really, really tight?
Oh, then if you tied it really tight, it could have an intrusive force.
It
as
might
well.
have an intrusive effect. Okay, but that might help hold anteriorly.
Yeah.
How about using them directly? Do you think that's an option in this case?
Yes, so you could use the tad, if you put it in the same place or somewhere similar, you could then run some sort of elastics from the 6 to that tad.
Okay.
The problem is though that it's so high up. Once again, if you're going from the 6 upwards, that's also a possible intrusive force too. So if you want the
Not so much in the trees. If you've got a full banded arch and you run a high tad to a low hook, what tends to happen to the occlusal plane?
so you could rotate it.
It can tip. So the force factor. Anywhere else that people are generally tending to put in tads a bit more frequently now? Use that?
There, another way is also in the lower 3, so you can run class 3 elastics that way.
Well,
but
not
then-
sure I'd want to do it that
yeah,
way.
neither. But I assume that you could put one in and then somehow reinforce indirect anchors, reinforce the anterior teeth so they don't move.
Yeah, you can put one in the second, third rugi and have a little T-bar up to there. Would give you really solid ankle. Now, if all that was failing and you start to go edge to edge, what other option do you have to change the treatment plan here?
So you could consider opening up the spaces. So if you think-
Difficult if you've already partially closed them. Anything else you could do with the lower arch?
So we could do some IPR in the lower.
Okay,
So if we think that we need to kind of tip them in,
if
a
that
little bit
wasn't
more,
enough.
Considering extractions if there wasn't enough space.
Let's think about the retention for this case. You've got quite a spaced case. Teeth have moved a long distance. How do you think you would best manage that?
So she started off with a midline diastema
Yeah.
with the low-hanging frenal attachment, which I don't think that's been treated 9 months in.
Yeah.
So you may wish to consider doing a frenectomy in order to help maintain that space closure. And then I'd probably put a bonded retainer between the upper centrals and then reinforce that with upper and lower vacuum form retainers indefinitely.
Okay. Would you extend the bonded retainer to the canines?
You could do, but I think you'd have higher risk of failure because of the shape of the palatal aspect between the 3 and the 1. So I think it's better to just reinforce wearing the removable retainer.
Pretty much our 15 minutes, guys. So it goes very quickly, doesn't it? Yeah. Well, you're sitting there going, or thinking, well, that's just like we do on clinic. That's just like looking at one of my colleagues' cases, or every time your own case comes in, you are evaluating your own case. Going to do next, and actually, most of you will bring your consultant over and go, this patient's a class 2 division 2 on a class 2 skeletal base. I've aligned the upper arch and put a twin block in. We're now in the stage where we're moving to transition. And I think I want to use a steep and deep biplane and move them onto the low fixed appliances as soon as possible. You're doing that every single time you get somebody over to have a look at your own cases. So this is no different to what you're doing already. And actually, you know, Constance is experienced compared to a second or third year reg coming through. She's got that additional experience. We've been through this case together, so we've covered all the bases well. That would have been a perfect mark, but actually she could have missed out on various different things there and still got a good enough mark to pass on that case.
And there were things. But you were saying actually to put it in the Rugi, and I've never done that before. So actually, when I was going through that with him, you told me about that. So I was trying to mimic that in that you don't necessarily need to know everything.
To put a tad in an easy place, as she discussed anteriorly, is all well and good. But to make it tight enough that it stops the teeth moving, you're going to have to put a lot of traction on the ligature. If it's loose, it's going to allow the teeth to move. If it's tight, you could get some intrusion, which I don't think would be a disaster. But she's already got a low smile line. You don't really want to intrude the teeth. And trying to use mechanics from the 2-3 region around the corner, that's difficult. Stretching an elastic, it tends to impinge on the gingivae. And as soon as you've got a high tad position and a low molar, you'll get tipping of the occlusal plane, which can be a real issue. So tads aren't the answer to everything. If you are going to say, I'll stick a tad in, at least be clear about where it might be placed and what the advantages and disadvantages of that. Anyone have any questions at home or in the audience at the back there?
Sorry about this case. So I'm thinking that would it be easier if, let's say, we instead of close the space, then we do 2 extractions on the lower, and then we close the space, or another way, then non-extraction lower, then open up the space and replace lateral?
Absolutely.
So can we just repeat the question
So,
as well?
if we look at her face, so the question was, what other options are there? Could we extract in the lower arch and close all the space? And therefore, your anchorage, if you get to a class 3 situation, you've got plenty of room in the lower arch to come back. I would go back to her face here and say, do you think that facial profile is a sort of facial profile you want to crash back 4 units? Ideally, in this case, what we want to do is keep the upper incisors forwards and protract the buccal segments. We want to keep the lip support. If we take the lowers out, we'll retract the lowers, and then we'll have a significant retraction in the upper arch. She'll be overclosed because she was already a bit gappy in the lower arch. You know, if you look at a lower arch spacing to start with, and we take out a couple of units down there, she's going to look very crashed back. So I think we'd have a real flattened face. Yes, it's an option. But if you gave me that option, I'd say, okay, well, let's go back to her records. Can you see why they may have picked a space opening? This is one of my cases. And I used the TAD TPA and I closed all the upper spaces, no problem at all. Because I know I've got that technique in my armory to use where I can reinforce my anchorage completely in the upper arch. The other option very clearly is to open space here. But then it becomes a posterior anchorage case rather than an anterior anchorage case, because you're moving 2 canines, and the one on the left is in the palate. So you've got to get the root out of that, and then you've got to distalize them a full unit without any loss of anchorage. So it then becomes a posterior anchorage case. And that's how the case would progress, depending on what we discussed. But I think although it's an option for taking in the lower arch, I'd want you to recognise the disadvantages of that treatment. That makes sense? Any other questions? Yeah.
With the unseen and the diagnostic cases, are we generally expected to finish to a class 1 size and class 1 canine?
You're aiming for that.
Even with...
Or a full unit class 2. I'm going to, it's like a mild class 3 case. I'm going to take out in the lower arch. I'm not in the upper. I'm going to go for a full unit class 2. Or I'm going to take a lower incisor and I'll be aiming for as much as I can class 1, but I'd do a Kesling setup to review what that final fit might be. But because of the discrepancy, bolt discrepancy with taking a lower incisor, often that class 1 fit may not be perfect. But whatever extraction pattern you tell me, I want to know the final mold. If you take out upper 4s and non-extraction in the lower and tell me you're going to get class 1 molars, I'll be thinking, really? So as long as your aims fit with your treatment plan, that's fine. It doesn't have to be perfection, but it has to match your treatment plan. Does that make sense?
All right, we have another question?
Yeah.
One more.
Just in case you ever receive a class case or a repaired class case, would they disclose that in a summary?
Would not have a cleft case. Cleft again is ISFE, so you won't have a cleft case coming in. You may have questions about the management of cleft, because as a specialist orthodontist, if you were referred a cleft case, you would need to know what pathway they would generally go through. But as a diagnostic case, you will not be given a cleft case. Cleft and orthognathic cases are not part of the diagnosis, but you would need to understand at what stages a cleft might be treated and the risks of having a cleft. That might come up in the written exam more so than you would get in the clinic.
And I think we have a question online as well.
We have 3 questions actually. The first one's in 2 parts. In the mechanics section, I have 2 questions. Can I challenge the former orthodontist's original plan / mechanics with fair justification?
Absolutely. Absolutely. That's what this is about. You could easily look at this case and go, you are mad. Trying to close that full unit of space is a really difficult anchorage proposition. Again, this happens to be my case, but the next case I will examine, I will have only seen in our examiners meeting and looked at as a group. So we look at them all beforehand. It's not my case to bring, and it's not my baby that you're going to offend me. If you think that that wasn't really a sensible plan, say so. To say, well, actually, I think carrying on down this route is really, really difficult. And I think if I'd have seen this case, I may well have looked at it. And that's exactly, I like the word that that person used, with justification. Don't just say, well, I don't want to do that.
Well, so some of the cases are specifically put in because they're going badly.
Yeah.
Or the treatment plan was ill-advised.
They're putting in to recognise the anchorage challenge maybe not have been met. And perhaps if you'd have started down a different route, because a retrospection is a brilliant thing, isn't it? We can all look at a case and go, wish I hadn't taken out there, or wish I'd taken out 4s rather than 5s. So absolutely, that's what these cases are for. Because your judgment in managing those cases, if they come to you part way through and understanding how cases change, it is all part of the mechanics of that.
And part two of the question from the same person is it okay to say that I've not used the presented mechanics before, and will they affect my mark?
No. And it's come out with a load of rubbish about it, I'd be quite worried. But you say, well, I've not seen it. I've been to lectures and seen these mechanics used. You know, for example, a lot of people haven't put TADS in, but I consider TADS you need to know about, just like you need to know about cleft. But for me, TADS are part of contemporary orthodontics. So even if you don't put them in, you should know that they could be used in certain areas and the risks and the benefits of putting them in. And I think that's absolutely fine to say, well, I think the mechanics you could use here, it's, you know, I've not done RME, I would like to have done it, but I think RME would be helpful in a case like this to do the expansion rather than a quad or rather than putting it on the arch wire like they tried to do. Absolutely fine.
Okay, and a question from another person. Would the priority be aligning the canine and getting your incisors in the correct position before fixing them with TADS and a T-bar, then to mesialize the buccal segments?
Yeah, of course. We could have spent another 10 minutes talking about how you're going to pick the canine up, or you're going to use a piggyback. It will depend. For me, the key of this case is managing the anchorage. Lining up that canine now it's partly through. It's quite easy to do. Just stick a button on it or a ballista. And you might want to start by saying, well, just before we talk about that, obviously I would line up the canine and I would drop back and pick that up with a piggyback arch wire. We talked briefly about using a ballista spring maybe to bring it down more vertically. And the fact that it's palatal and we want to leave the root palatal actually makes it easier if we are disguising it. Yeah, your vibra may not always go exactly the way you think, but you can drive that vibra as well by starting off going, well, firstly, I'd address that canine and bring it in. But for me, that's the easy part of this case, just bringing a tooth that's now erupted into the line of the arch. The difficulty in this case was closing the space with the current plan and understanding the anchorage.
And the final online question, would it be appropriate to say, if you start space closure and struggle, it would be best to leave a unit of space medial to upper 6 rather than extracting in the lower?
Yeah, I think that's also an option. You know, I've been to many a joint clinic, restorative clinic, where the plan was to close up all the spaces and you get part way through and the teeth are small, things aren't moving, the patient's grown and they're becoming a bit class 3. And you go back to the joint clinic and say, look, I know our plan was to close all the spaces here, but actually I'd rather leave a unit of space, and the best place to leave that is next to the 6 and not in the anterior region. What you don't want to do is leave a canine space. So I think that's a really, really good thing to say. Yeah, very good.
Okay, that's all the online questions.
Excellent.
Brilliant.
You'll overstay my welcome. I'll let go and take over.
Thank you.
Thanks all.
So next we have Colin. Colin is a happily retired consultant orthodontist. I believe you were at Countess of Chester Hospital, weren't you? He is also a lead examiner for EMOR Edinburgh and also on the SAB. So we're really happy for you to come and talk to us.
Good morning. So good morning all, and good morning to my live audience, and also good morning to those who are joining virtually. I think this is my 3rd or 4th time speaking at the TGG Study Day, and I'm always delighted to be asked. So you're all very welcome this morning, and it's lovely to be here. So the title for my presentation this morning is Anchorage Planning and Management. So I've come down from sunny Chester for a couple of days in London. I formerly was consultant orthodontist at the Countess of Chester, but now I spend my time mostly examining for the Royal College of Surgeons, the Liverpool Orthodontic Programme. So let's talk about anchorage management in terms of the M-Orth examination. And it's important not just to concentrate on AP anchorage. Remember, anchorage is in 3 planes of space: anteroposterior anchorage, vertical anchorage, and transverse. Now, I've got quite a short time slot this morning, so I'm just going to concentrate on AP and vertical anchorage. And I'm going to try and give you a flavour of what sort of level of knowledge regarding anchorage comes up in the M-Orth exam. So let's turn to AP anchorage first. And typically we'll be looking at class 2 correction and class 3 correction. So let's look at class 2 first, and I'm going to illustrate class 2 correction by showing you a case. This is Sarah presenting at 12 years of age. Sarah's presenting with an increased overjet. Facially, she's only mildly class 2 with fairly average skeletal proportions vertically. And if we look at intraorally, we can see an increased overjet, and the canines are half a unit class 2 on either side. The upper right second deciduous molar has just exfoliated, and the upper right second premolar is yet to erupt. So here are the arch forms. You can see the recent site where the second deciduous molar has exfoliated. And the overjet's increased to 12 millimeters, so we're 5A on the IOTM. Looking at the OPG, and this was taken at a slightly earlier phase than the clinical photographs, it confirms the presence of all developing teeth with the exception of third molars. So nothing too remarkable on the OPG. And looking cephalometrically, we've got a 5-degree A and B difference, so a moderate class 2 skeletal base. And looking at the inclinations of the teeth, the uppers are proclined at 120 degrees, the lowers are proclined at 94 degrees. Perhaps there's some class 2 compensation going on there for the underlying class 2 skeletal base, and the angle is fairly average at 26 degrees. Now, perhaps unsurprisingly, with a 12-year-old, 12 millimeter overjet, well-aligned upper and lower arches, our first a functional phase and a fixed phase. So absolutely bread and butter mechanics for a big class 2 division 1 malocclusion in this country. And we're going to manage Sarah's treatment with a modified Clark's twin block. So if we are going to talk about growth modification in the M-orth, what are the typical things that you will be asked by the examiner? Well, the examiner will want to know how twin blocks correct class 2 malocclusions. And they'd expect to discuss some evidence with you about that. How would you judge the timing of your intervention? What progress would you expect to see on a visit-by-visit basis? How you might reactivate the twin block appliance? How do you know that if you're planning 2-phase treatment, how do you know when you're at the end of the twin block phase, and how do you know when it's time to start your fixed appliances? What are your options for managing the transition? And what are the indications for extractions of teeth at the transition phase? So these are all sorts of things that you need to be confident discussing in the exam. Now, fortunately, with growth modification, it's one aspect of orthodontic treatment where we've got some very high level of evidence. There's been some very good studies carried out, and you should all be familiar with Kevin O'Brien's multi-center randomized controlled trial. And in terms of the mode of action of twin blocks, there's good evidence that most of the correction is due to dentoalveolar change, but some was due to favourable skeletal change. And the small change in the skeletal relationship may not be considered clinically significant. And a ballpark figure for correction of malocclusions or overjets with twin blocks is roughly 70% of the changes due to tipping of the teeth or dentoalveolar change, and around about 20 to 30% is likely to be skeletal change. In terms of timing of intervention, a lot of our cases having twin block therapy will have a pre-treatment CAF. And there's been a lot of interest in the scientific literature about using cervical vertebral maturation to judge the peak velocity of craniofacial growth. So being familiar with is really wise before the exam. And I'd know the papers that support it, but also some discussion about how reliable it is. and the classic paper was published by Frankie Bacchetti and McNamara in 2000. So be familiar with the various stages of cervical vertebral maturation and be able to quickly look at the lateral calf and make a judgment at what stage the patient's up to. So back to Sarah, and if we have a look at the lower border of her C2, it's concave, C3 is concave, and C4 is flat. So applying that to the staging process, we can see that she's at stage 3, which is just on the money in terms of being close to the peak craniofacial velocity of growth. So in terms of the cervical vertebral maturation, it's suggesting that she's very close to her maximal growth. So we fit the twin blocks for Sarah, and she's had the twin blocks for 1 visit now, and we're calling her back for review. We're beginning to see the suggestion of some lateral open bites forming. The overjet has reduced from 12 millimeters to 8 millimeters, which is quite a pleasing amount of progress for 4 weeks into treatment. One thing you will notice with your large overjets with twin blocks is the initial overjet reduction is very rapid because the patient's having to stretch a long way into their appliance. So the first half of the overjet reduction happens of reduction of overjet per visit start to slow down, and you have to work a little bit harder to get your second half of your overjet down. So in terms of the occlusal views here, we can see that the upper right second premolar is now erupted and lower right second permanent molar is just pushing in an appearance. So next visit, this is a second visit wearing the twin block. Lateral open bites are now well established and the overjet's reduced from 8 millimeters to 6 millimeters. So again, a nice improvement, but beginning to slow down. The canines are moving from half a unit class 2 to a third of unit class 2. So we're beginning to see some buccal segment correction. And the third visit, we're beginning to see a noticeable opening of the bite, lateral open bites, and the overjet is only decreased by 1 millimeter. Now, it may be that Sarah's sort of getting a little bit used to wearing the appliance, getting a little bit blasé, attaching less importance, a bit less keen. So it's really important if you notice that the overjet reduction slowing down, that you have a chat with the patient, encourage them. And so by the 4th visit, Sarah's back on track. She's been wearing a twin block a little bit more. Lateral open bites are really quite significant now, quite a significant degree of overbite opening, and the overjets reduced from 5 to 3 millimeters. We're not quite there yet. It's really important not to stop your twin block too quickly. We know there's an element of rebound with twin block when we make the transition. So it's nice to get an element of overcorrection in. So don't be in too much of a hurry to stop your twin block and get into your fixed. So we're going to carry on for 1 more visit. So we've had 5 months of twin block therapy now. Here's Sarah at the end of her treatment. Facially, she's still mildly class 2. There hasn't been a massive change in a facial profile. But you can see that we're nicely overcorrected now. And the hallmarks I'm looking for in terms of judging at the end of the twin block treatment, I want to see overcorrection of the incisors, corrected beyond class 1 towards an edge to edge. I want to see some lateral open bites, and I want to see overcorrection of the buccal segments past class 1 towards class 3. And these are the sorts of hallmarks I'm using to judge when I've done enough with the twin block and it's at the end of the twin block phase. So our AMB difference at the beginning of treatment was 5 degrees. And when we take our progress CAF at the end of the twin block phase, it's reduced to 3 degrees. So there's been a modest skeletal reaction to the twin block phase of treatment. In terms of the inclination of the teeth, the upper incisors started off at 120 degrees and they've uprighted to 112 degrees during the twin block phase, and the lower started off at 94 and they've proclined by a degree to 95 degrees. The angle has remained largely unchanged. So we need to make the transition between twin blocks and fixed appliances. And the transition is the most difficult phase of managing. And the last thing you want to happen is to have a large rebound in the overjet and lose some of the AP anchorage we've gained during the twin block phase. So the challenge with the transition is dealing with the lateral open bites. It's preventing the overjet reduction achieved with the twin block from relapsing. And it's also maintaining the patient interest and compliance. They've come to you complaining of a large overjet and sticky out teeth. You've dealt with that very efficiently in 5 months. Their teeth are no longer sticking out, but you've got to keep them on board so you can finish the case nicely with a fixed appliance. So what are your options for managing the transition phase? Well, you can consider the use of a steep and deep bite plane in low angle and average angle cases. The buccal segments to erupt into occlusion. You may want to actively encourage eruption of the buccal segments by selective trimming of the twin blocks. You may consider introducing headgear at this stage to hang on to your overjet. Class 2 elastics are useful, however, they're perhaps unsuitable to wear on the initial night eye arch wires and better suited when you've got the patient into at least an 018 round stainless steel. And finally, some operators modify their twin blocks so they can be worn simultaneously with the opening phases of the fixed appliance. The other thing you need to decide at the transition is whether there's an indication to extract teeth. And the common indications for extraction at the transition phase are significant crowding of the upper and lower arches, large centerline discrepancies that are in need of correction, excessive proclination of the lower incisors during the twin block phase, teeth of poor long-term prognosis that you want to get rid of, the need for balancing or compensating extractions for congenitally absent teeth. And finally, if you've got a patient who's only partially complied with the twin block, so you've had some anchorage improvement, but they've still got a resulting residual overjet at the transition. So these are the main indications for considering an extraction at the transition phase. So looking at Sarah series brackets, and she's being aligned with 014 night eye arch wires in the upper and lower arches with lace backs in all 4 quadrants. You can see the nice overcorrection we've achieved during the twin block phase, and really the fixed phase is all about detailing the occlusion and correcting the overcorrected position of the teeth that we've achieved during the twin block phase. So aligning the arches, and then you can see there's quite a bit of space to be closed up. We're using fixed appliances, but we've got clip over bite plane. So my strategy for transition in this case is using a steep and deep bite plane. This is a removable appliance with an inclined anterior bite plane. It's retained by ball clasps that you can see between the upper lateral incisors and upper canines. And it's got some flyover or plint clasps posteriorly that engage on top of the buccal tubes on the 6s. It's worn of an evening and overnight sleeping. It's not worn full time, and it just engages the lower incisors with this overlap of the inclined plane and keeps the overjet from relapsing. Now, we only need to have the steep and deep bite plane in whilst we're in night eye archwise. Once we get to upper and lower around 018 stainless steel archwires, then we can put some Kobayashi ligatures on the upper canine teeth and run some class 2 elastics, and the steep and deep bite plane at that stage becomes redundant and we can stop wearing it. So the steep and deep bite plane is just a transitional device to get you through the night eye stages of the fixed appliance. And once you're in stainless steel, you can run class 2 elastics. So we're up into upper and lower 018 stainless steel at this stage. We're running class 2 elastics, and we've got some power chain going anteriorly in the upper arch to close the midline diastema and adjust the center lines. Working through a stainless steel archwire sequence here will flatten the lower curve of Spey and deal with the lateral open bites. They shouldn't be something you're frightened of, seeing the lateral open bites. They will just treat out by going through a stainless steel archwire sequence. And here we are at the finish of treatment for Sarah. She's really happy with a smile. Facially, she's grown a little bit vertical. Effect. And the MBT prescription, the fixed appliances have really detailed that occlusion very, very nicely and produced a nice finish for her. And you can see that we've rebounded from our overcorrected edge-to-edge position of the incisors to a well-socked-in class 1. So in terms of pre-treatment progress, we're doing the 2-phase treatment to get from the big overjet and get that into an overcorrected position. And then the fixed appliances are going to just detail that for us and fit the buccal segments together, correct the center line, and detail the teeth positions. Then slowing down as the appliance becomes a little less active to our overcorrected position, and then settling with fixed. Okay, so a fairly standard class 2 correction, and the sorts of knowledge we'd expect relating to that sort of treatment plan for the M-Orth. Let's go on and have a little look at some class 3 AP anchorage. So I'm going to illustrate class 3 correction with my second case, which is Lucy. Lucy's presenting as a 15-year-old. She's unhappy about the crowding in her upper right quadrant and her back to front bite. And she's got a buccally prominent canine. Facially, she's not desperately severe class 3. She's got quite a straight profile and a fairly average Frankfurt mandibular plane angle. Looking intraorally, there's 2 salient features really, or a few salient features. There's a buccally excluded canine on this side. There's the reverse overjet anteriorly with no displacement. The 2 and the 4 are in contact on the right side, and there's a suggestion of a buccal bulge here. So we've got a vertically impacted canine. And in the lower left quadrant, we've just got 1 premolar here. The lower left second premolar is absent. Finally, there's a significant lower centerline shift. So here's the buccally arch with crowding of the lower incisors, big lower centerline shift, and the 5 is missing in the lower left quadrant. Looking at the lateral kef and tracing out the A and B difference, we've got 0° A and B difference, so a mild class 3. Looking at the inclination of the incisors, we've got upper incisors at 105 and lowers at 95 on an MM angle of 26 degrees. Here's the OPG. You can see that the impaction of the canine is quite straightforward. It's a vertical impaction, and nothing really more of note other than the lower left second premolar being absent. So we decided to treat Lucy by orthodontic. Excluded canine to be aligned. We've extracted the upper left four, and we're hoping that there will be spontaneous alignment of the upper left permanent canine. We're hoping that's going to erupt under its own steam, and we've extracted the lower right four to help us with that big centerline shift in the lower arch, but also to give us room to retrocline the lower labial segment to correct our class 3 incisor relationship. And because the lower left second premolar was already absent, we're not going to perform an extraction in the lower left quadrant. So we're aligning initially with 014 night eye arch wires. One thing that's helpful in the lower arch is to swap the lower canine brackets. Normally there's a mesial tip in the MBT prescription on the lower canines. And if you swap the lower right canine and put it on the left side and the left canine on the right side, then you get a distal tip in the lower canine brackets, and that will help you to correct your class 3. Additionally, we've got unilateral lace back in the lower right quadrant to help encourage the center line to the right side. So we've leveled into 018 round stainless steel arch wires at this stage. Using a piggyback to pick up the upper left canine now it's erupted sufficiently. Just dropping that down, now secondary alignment to get the canine aligned. Residual lower space, and I want to use that lower space to do 3 things. I want to correct the center line, I want to deepen the bite, and I want to correct from edge to edge to class 1. And just visit by visit over the final bit of space closure on a lower 1925, you can see the center line gradually correcting. The bite's deepening, and we're moving from class 3 towards class 1. So we're managing the lower space to correct our center line, to correct our incisor relationship. And because we've managed this case on an extraction basis, we're anticipating some overbite deepening. In terms of class 3 correction, you're much more likely to have a stable outcome if you finish your treatment with a positive overbite. So looking after your bracket positions during the bond up here, putting the bracket slightly more gingivally to get an extrusive effect on the incisors. And again, all of these factors are helping maintain a positive overbite during treatment. And there we at the end of Lucy's treatment, the overbites deepened nicely. Final inclinations are 116 degrees in the upper arch, so the upper incisors are proclined and the lower incisors have retroclined from 95 degrees to 91 degrees. Lucy's happy at the end of her treatment. She'd no longer got crowded canines and centerline shifts. Facially, she was mild class 3 at the beginning. Her facial profile hasn't deteriorated much during the course of treatment, and that's her final occlusion. Bonded retainer in the lower arch and upper and lower vacuum formed retainers worn nights only. So what are the MORPH discussion points for surrounding class 3 malocclusions? What sort of mechanics would we expect you to talk about in the exam? Well, the use of class 3 elastics, extraction patterns for class 3 treatment, often upper 5s, lower 4s, or perhaps all 4 5s. The technique of swapping the lower canine brackets over to tip the lower canines distally, lace backs in the lower arch only, protraction headgear, chin cup therapy, And there's a lot of interest in skeletal anchorage systems for class 3s now. De Klerk to skeletal anchorage systems, so be aware of the literature. And even if you haven't had a chance to correct a class 3 using skeletal anchorage, I think the examiners will expect you to know about it in theory. Quite a common topic for discussion with class 3s is the borderline situation. What to do with a patient who's just at the very cusp of being correctable by camouflage, but perhaps would have a little bit more growth coming. So borderline cases in class 3 is quite a common topic to discuss. There's a couple of useful papers that you should be aware of. There's Kerr's paper from 1992 discussing where the borderline is for class 3. There's also Burns's paper in the American Journal of Orthodontics, class 3 camouflage treatment, what are the limits? And they're two useful papers to know, giving advice about where the borderline is for class 3 camouflage. So looking briefly at the paper, the Kerr's paper, I can't spend much time with that because we've got quite a short slot, but basically it was a study of class 3 cases and whether they had surgery or orthodontics. It was a retrospective study. There was 40 subjects. They'd already been allocated either for having surgery or for successful orthodontic treatment. And really the researchers were looking retrospectively at the pre-treatment CAFs to see what features would dictate whether the patient went into a surgery group or an orthodontic camouflage group. And they found that there was 4 factors that were important in predicting whether the patient's got camouflage or surgery. That was the A and B difference. Once it became greater than -4 degrees, patients were much more likely to be allocated for surgery. The maxillary mandibular length ratios, once that exceeded 0.78, they were likely to be a candidate for surgery. The lower incisor inclination, once the incisors became retroclined by more than 83 degrees, they were more likely to be a surgical case. And finally, the hold away angle, once that exceeded 3.5 degrees, they were more likely to be in the surgical category. Okay, so we've dealt briefly with AP anchorage, showing you a class 2 and a class 3 situation. Let's now go on to vertical anchorage management. And I'm going to talk in this section about high and low angle cases and comparing and contrasting the types of mechanics that you'll be using to manage high and low angle cases. So I'm going to start off with a low angle case. This is Katie. Katie's presenting with a class 2 division 2 malocclusion on a low angle with a mild class 2 skeletal base. And you can see immediately that one of the main features and main challenges of this malocclusion is the very deep and complete overbite. Some crowding in the lower arch and less crowding in the upper arch. Now, your immediate reaction in the lower arch is there's quite a bit of crowding. Should I be extracting? And in a low angle case, you want to avoid extracting in the lower arch if at all possible. And I'll explain why in just a minute. That is a deep and challenging overbite. So what are the general features of a low angle case? Well, they tend to present with deep overbites. They tend to have reduced lower face heights. Lips are competent with strong muscular force. They tend to exhibit features of an anterior growth rotation during the time that you'll be treating the patient. They tend to have powerful muscles of mastication, and they tend to have good posterior anchorage. It's very difficult to protract the buccal segment teeth of your closing space. So what are our mechanics for low angle cases? Well, the main problem in treating these cases is dealing with the anterior growth rotation. And this makes reducing a deep overbite quite difficult. So mechanics are set up to produce extrusion of the molars. And this helps to counteract the anterior growth rotation. So why is it important to avoid extraction in the lower arch in low angle cases? Well, space closure is difficult due to good posterior anchorage. There's increased risk of retracting the lower incisors during space closure due to the good posterior anchorage. And this will result in deepening of an already deep overbite. So what techniques can we use in our mechanics? Well, we're leveling the curved display with early placements of stainless steel arch wires is very useful in these cases. Bonding the lower second molars early. We might choose to use a functional appliance in the younger age group. Full either fixed or removable bite planes. And we want to avoid extractions in the lower arch in low angle cases. Class 2 elastics are useful. They have an extrusive effect on the molar and they will help manage your overbite. Cervical pull headgear, if we're going to reinforce anchorage with headgear, then choose a cervical pull vector, and that will not only give you a distal force on your upper molar, it will also have an extrusive vector, which will help with your overbite. Customize your bracket positions on the canines and the incisors, place them a little bit more gingerly, and that will help to extrude your labial segments. Temporary anchorage devices can be placed anteriorly with elastics directly to the arch wire to elevate the buccal segments and reduce the overbite. And in the most severe and intractable overbites in adult patients, we may resort to orthognathic surgery. So this is an example of headgear in a low angle case. And you can see the extrusive vector of the cervical pull headgear. In terms of flat anterior bite planes, diagrammatically, they chock open the bite anteriorly, leading separation of the molars posteriorly. And because most of our patients of an orthodontic age are exhibiting some vertical growth, then the buccal segments will erupt. So the whole emphasis of the mechanics in these low angle cases is molar extrusion and overbite reduction. A nudger appliance is quite useful in deep bite, low angle cases with the class 2 element where you're distalizing the molars. They've got a flat anterior bite plane to help you with your overbite. They're retained with the south end clasp anteriorly and 2 Adams clasps on the premolars. And they've got these active finger springs made out of 016 stainless steel arch wires to help distalize the molars. And they're used in combination with cervical pull headgear. And the nudger appliance will give you 3 advantages. It will reduce your deep overbite. It helps with distal movement of the upper molars. It will also protect your lower fixed appliance from being bitten off by the bite. This is a detail of the 016 finger spring. It's usually activated by into the mesial contact point of the upper 6. So back to Kate. Kate's been treated with a lower fixed appliance, and you can see that the bracket positions have been modified in the lower labial segment to be placed more incisally, and we've chosen to go early into an 018 round stainless steel arch wire. She's been wearing a nudger appliance and cervical pull headgear in the upper arch, and you can see that the bite plane has been very effective at opening the deep bite. She's also had some distal movement with her cervical pull EOT, and you can see that the molars have been distalized quite significantly by a combination of the cervical pull headgear and the nudger appliance with the bite plane. The occlusal surface is worn, and you can see an imprint of the distal border of the URA intraorally. The other thing is the clinical effect of the nudger and the headgear. You can see good progress. So all of these factors are pointing to good compliance. So we're really happy with the bite opening, and we're happy to bond up the upper arch at this stage. The postgrad who's done the bond up for me in this case has made a bit of an error and bonded the upper incisors a little bit more gingerly than I would have liked in this case. But that's a minor error. She's managed the other aspects of the case beautifully, so we won't be too judgmental about that. But we've made our job with the overbite a little bit more tricky with the choice of bracket positions in the upper labial segment here. Okay, so we're into a 1925 arch wire in the lower now, round stainless steel in the upper, and running some asymmetric elastics for final correction of the centre lines. The vertical control has been beautiful in this case. The overbite is now really nicely managed, just doing some final space closure and centre line correction. And then into finishing, the buccal segments fits very nicely on the right side. On the left side, we've still got a little bit of vertical opening in the buccal segments, a little bit of arch wire coordination needed. So we've retained our 1925 arch wire in the upper arch. We're using a full dimension 1925 braided lower arch wire in the lower for vertical flexibility. And we're running some box elastics to some Kobayashi ligatures just to sock that occlusion in, and that happens really quickly, and then we're debonded. So just some typical mechanics for a low angle case of managing the vertical anchorage. Katie ends up happy with the result, a little bit class 2 still in the profile, but really nicely managed deep bite low angle case and a nice finish, and treated that crowding in the lower arch on a non-extraction basis to make our overbite management a whole lot easier. And there's the vertical control. Okay, so we're rapidly getting through my presentation. We're into the last section, which is features of high angle cases and high angle management. So high angle cases, they have a tendency towards an anterior open bite, tendency towards an increased face height. Lips tend to be incompetent and have a more weak muscular force. These cases tend to exhibit posterior growth rotations, less powerful muscles of mastication. And because of the geometry of the jaws, when the patients bite together, there's an anterior component of occlusal forces that help the buccal segments drift forward. There's less powerful muscles of mastication, and the less powerful force, these two factors result in less posterior anchorage in high angle cases. So looking diagrammatically, there's a tendency towards anterior open bite. There's a tendency towards increased face height. Lips tend to be incompetent. They tend to exhibit, sorry, this is a bit exaggerated. They tend to exhibit a posterior growth rotation during the time that you're treating them. There's this anterior component of occlusal force with less posterior anchorage and less powerful musculature. So this is a facial appearance of a class 2 high angle case. So there's a tendency towards anterior open. Posterior growth rotation, less powerful muscles of mastication, anterior component of occlusal forces. So how are we going to treat these high angle cases? What do your examiners in the MORPH expect you to discuss in terms of a high angle case? Well, it's important to recognise that high angle cases are difficult to treat. All things being equal, a similar malocclusion in a low angle case is going to be a lot easier to manage than a high angle case. And high angle cases are difficult for three main reasons. Firstly, they exhibit unfavourable growth. They've got lip incompetence, and the facial aesthetics tend to be trickier and more difficult to get and firstly, unfavourable growth. The underlying posterior growth rotation and molar extrusion during treatment tends to lead to a deterioration in the skeletal pattern, both in the AP and the vertical planes of space. So as you're treating the patient, they're likely to be rotating posteriorly, and that's going to cause the overjet and the overbite to be more challenging to manage during the 2 years that you'll be treating the patient. The second problem is lip incompetence, and lips are often incompetent at the start of treatment, and any posterior mandibular rotation due to either growth or molar extrusion as a result of your treatment mechanics will make the lip incompetence worse. Of the upper incisors being under control of the lower lip, and increasing lip incompetence therefore detracts from the prospect of stability of these cases. And the third problem in high angle cases is the facial aesthetics. Facial aesthetics are often poor due to a receding chin, and this may not be helped by camouflage treatment aimed at retracting the upper incisors. So what are the MORPH management points for high angle cases? Well, the mechanics are going to be aimed at controlling the vertical position of the molars and avoiding making the posterior rotation of the mandible worse. So we want to consider things like high pull headgear, avoiding a lot of use of class 2 elastics, avoiding flat anterior bite planes, more likely to extract in high angle cases to allow the molars to move medially, avoid maxillary expansion in cases with anterior open bite tendency, and maintain a curvus bay in the lower arch and a reverse curvus bay in the upper arch to avoid unwanted bite opening. The use of any bite plane, whether that be a flat anterior bite plane, molar capping on a URA, or a steep and deep bite plane, should be avoided. If bite planes are used in high angle cases, there's a danger that the second molars will be left free to erupt. And this will rapidly give rise to quite a significant and unwanted. Now, for me, one of the most exciting factors about the introductions in TADS in orthodontics is our ability to manage high angle cases much more effectively. So the introduction of TADS has made the management of vertical anchorage in high angle cases much, much more effective. And I'd like to finish off with a high angle case, Sarah, who's a 14-year-old with an anterior open bite. So here's Sarah. She doesn't like her upper labial segment crowding. If we look facially at her, she's got an upturned nose with quite a wide alar base, and you can see the elevated nasal tip here. And this is the sort of nose that may not go desperately well with maxillary surgery later on in adolescence because of the wide alar base and the fact that the nasal tip has already been elevated. The other thing is her anterior open bite is significant, but it's not the most severe anterior open bite. So if we had an orthodontic solution to that, that would be great because it would avoid the negative nasal effects of maxillary surgery. But also the magnitude of this anterior open bite is quite modest. So crowding in the upper arch, less crowding in the lower arch. The AMB difference is mild class 2 or mild to moderate class 2. It's tracing out at 5 degrees. Upper incisors are proclined at 115, lowers are at 90. The angle is increased to 30 degrees, reflecting the high angle of this case. And you can see, as in a lot of high angle open bite cases, there's two levels of occlusal plane in the upper arch. There's the level of the buccal segment as far forward as the first premolar, and there's the upper labial segment and the canines, which are at a different occlusal level. So dealing with the anterior open bite, we've got two choices. We can either extrude the incisors, which we know is potentially unstable, or we can try and intrude the buccal segment. Intruding the buccal segment will cause the molars to come out of occlusion and induce an auto-rotation of the mandible to close down the anterior open bite. And of those two choices, I'd much rather intrude the buccal segments rather than extrude the incisors, because the prospect of stability will be better. So John Scully's done some nice graphics of this, which I've kindly put into this talk with John's permission. The idea is that you sectionally level the posterior segment, place some TADs between the teeth, and then run some vertical traction down to the sectional arch wire, and that will intrude the upper buccal segment and induce an auto rotation of the mandible to close down the anterior open bite. Now, that looks great on a diagram, but in real life, what actually happens is a number of subtle movements. It's not just intrusion and auto-rotation alone. If you've got fixed appliances on, there will be some tipping back of the upper incisors that will deepen the bite. There'll also be some mild extrusion of the incisors and mesial movement of the molars forward, particularly in an extraction-based treatment plan. And it's the summation of all of these factors that will contribute to closing down your anterior open bite. So let's have a little look at Sarah's progress. We're using a self-ligating bracket system here, and I want to try and avoid extrusion of the upper labial segment. So I've chosen to section the arch wire into 3 sections, a labial section, 2 buccal segments. And I've used a modified transpalatal arch here because I want to use the transpalatal arch to produce the vertical intrusion. So we've leveled up into 1825 NiTi here. You can see no attempt has been made to extrude the upper labial segment during the leveling. Here's the arch wires leveled. We've still got a very respectable anterior open bite, so we haven't really diminished the anterior open bite here by extruding the incisor teeth. We're going to place some TADs, and the TADs were placed one either side between the 5 and the 6. And one either side between the 6 and 7 palatally. It's quite difficult to get to the posterior palate using a screwdriver, so using contrangle TAD placement instruments a lot kinder to the patient. So you can see that the handlebar extension on my transpalatal arch is useful for just hooking some power chain round, and I've chosen a vertical placement of the TAD to allow me room to intrude the transpalatal arch. So we start intruding on the palatal surface, and that will intrude until the transpalatal arch starts embedding into the mucosa. And at that stage, we need to take it off and just use some simpler mechanics to some buttons onto the molar and also onto the 7. It's important to control the vertical position in the 7. If you look carefully, you can see a step between the 6 and the 7 because we started intruding the 6 before the 7. It's important to intrude the 7 as well. And I'm also using a buccal TAD here. I'm just using some simple elastic chain around the upper buccal sectional to intrude the whole block of the teeth. So I'm intruding from the palatal and the buccal surface. So looking at the progress of this is pre-treatment before we place the TAD. This is beginning to intrude the sixes, and there's not been any auto rotation at this point because we haven't controlled the sevens. They're still in contact. But once we start intruding the sevens, you can see the auto rotation happening and the vertical anchorage control and the auto rotation. And that's the intrusion of the buccal segments and the auto rotation. And that's Sarah at the end of the treatment. She's been managed non-extraction. And we've got a good positive overbite at the end of our treatment. So TADs have been very, very useful in the arena of vertical anchorage for us. Okay, that takes me to the end of a very quick overview of AP and vertical anchorage and the concepts we're likely to be discussing with you in the M-Orth. Now, I realise that we're a little bit tight for time. I just briefly want to announce the M-Orth. It's going to take place virtually. So it's going to happen on Friday, the 3rd of March, 2023. It's a half-day online course. The course will run all day, so candidates will either be offered a morning or an afternoon slot. Now, the places are limited to 38 candidates, so the places are going to be preferentially available to candidates who've applied to sit the May diet of the M-Orth exam in Edinburgh. Each candidate will get 2 unseen diagnostic tests, 1 mechanics test. So one of the advantages of doing the process course is that you'll get practical experience of a mock viva on the new mechanics section, which I think will be quite valuable and quite an attractive thing for potential candidates for the Edinburgh M-Orth. You'll also have 2 communication scenarios. And candidates will be examined by experienced M-Orth examiners. It's not somebody who fancies having a go at examining or thinks they know what the exam's about. It's actual experienced M-Orth examiners, and I've already recruited them. I know who they are, and they're excellent. The process of applying for the course is that you need to make an expression of interest to Louise Marin at the Royal College of Surgeons of Edinburgh. Tell her that you're interested in registering for the course. That's her email address. And nearer the time, we'll contact you asking for payment, but you will only be contacted and offered a place in the course if you've registered to do the M-Orth. Okay, at Edinburgh, because we want to, because we've got a limited amount of places, we want to make the places available preferentially for potential M-Orth candidates in Edinburgh for May. If we don't fill the case, all the places, then perhaps there'll be some places available that deviate from that rule, but the main priority is going to be given to those people registering for the exam. So that brings me to the end of my presentation. I'd like to thank you very much for your attention. Thank you very much to the online audience as well. And the final message is, if you're sitting your M-Orth in May at either college, best of luck.
Thank you to Colin. In the interest of time, if people haven't noticed already, we are running extremely late. So apologies, we don't really have time for questions. Apologies, Colin.
Happy to take questions.
Happy, yes. So I'm going to give everyone a 5-minute break because our next speaker, Richard, is actually presenting online. So we'll have a few minutes just to set up. People here have a break too for 5 minutes. Just as the delegates online, I made changes to the sound halfway through Colin's lecture. So if you can give us some feedback on whether the sound is any better, that would be great. Also to the delegates virtual as well. Those who have decided to attend virtual last minute instead of face-to-face, can you please email Anne and let her know, because we need to know numbers for lunch. So that would be great, emailing. So we'll be back at about, say, 10:10. So we'll see you in 5 minutes' time. Okay, so Brilliant. Thanks for coming back, guys. So I'm now happy to introduce William. William. Sorry, I'm just like, I'm having a moment here. So Richard, sorry, Richard, you've got the William Hewson Gold Medal. I looked at your presentation. I have Richard here, who was a trainee at Newcastle. And he did very well in the exam last time, because he has now received patient today on advice on how to tackle MAuth. He's currently working in practice. His next patient is at 11:35, so we'll be swift. So thank you. Take us away, Richard.
Great, thank you, Constance. I was going to say, if you do want to call me William Houston from now on, that's fine. Like, I'll take it. I'm not sure I'm up for it, but yeah, I'll have that. I don't know if you can see me. Hopefully you can hear me okay, everyone.
Yes, we can see you as well.
Oh, great. Oh, I'm with you. You've got my forehead, by the way. Like that. How's that? Okay, so I'll try and be swift because I've got someone due in to come and see me. I'm hoping I'm talking to a room full of sort of UK STRs in like really nice, well-established training posts, and everything's going really well for you. Essentially, the odds of you passing your MAuth are really good. I would gamble on all of you passing the exam. You've all worked hard to get to the point where you are, and you just have to keep doing what you're doing, and you should be fine. In terms of the medal winning bit, that's definitely more like a bit of roulette. I think I was just kind of lucky. I was definitely not the cleverest or most academic in my year group. And I'm certain that 100% definitely did not do the most work. I know a lot of people who worked really, really, really hard. But I scored highest on the day. So I'm not sure how to say this. I could have easily not have been the medal winner, but I've thought of a few ways which I think might have sort of helped tip the balance, if that makes sense. To explain myself, I came into STR training a bit late. I graduated in 2010 and I worked in practice for a long time, which I thought was fine and I was enjoying it. But when I decided to specialise, that kind of coincided with me also starting a family. So I was spending my weekends kind of in soft play parks, you know, on the swings and stuff, watching Peppa Pig. And I found it really very difficult to get my work done. I certainly couldn't get anything done at the weekend. So I had to think about ways of getting stuff done during the working week so that I was free the weekend to enjoy this little chilling happy place that we might see. When I first started my training, I thought it was a disaster. I didn't think I was going to get through training. Nobody in my first year would have thought I would have passed MAuth, never mind come away with a medal. So I'm going to talk to you about some of the slightly weird ways that I had to adapt my work in order to get it done.
Sorry about that. That was me.
Oh, am I still going?
Yes, you're still going.
Great. So in terms of preparation, I tend to think of it in just sort of 3 steps. The build up to the exam, so that's anything from day 1 of your training onwards. During the actual week of the exams, whilst you're staying over in Edinburgh or London for the actual time during the exam. And then during the exam itself and your attitude and your understanding of what you're doing and what you're trying to achieve. So starting with the pre-stuff, you're going to get some standard textbooks. I think it's pretty reasonable to expect to read a load of books during the training. I think we probably all read the same things. And I said I felt quite overwhelmed during my training. There's a lot to get through. I did read these books pretty well cover to cover several times.
Richard?
Yes?
Is it possible to speak a little bit louder? Because I think some people are having issues hearing you.
Let me see. I can definitely shout at you. I might be able to turn up my microphone. Now, is that ridiculously loud or is that okay?
No, that seems a bit better. We'll try that.
Okay, that's you on full. I'll do a bit of shouting as well. These books I hope you all recognise. I definitely read them. I didn't take any notes on them. I didn't feel like I had time to both take notes and ever read them if I did take any notes. So I just concentrated on trying to get through all the material as the course went on. And you might notice the kind of order that I'm flicking through these, starting with some fairly simple stuff and building up to more clinical things, references towards the end of exams time. It's probably not normal for a lot of you. A lot of you will find comfort in taking lots of notes and having lots of folders. And I sat through this exact presentation last year with an excellent candidate who had them all labeled and cross-referenced and alphabetized, and she made her own contents page, and it all sounded amazing. But I don't think that's totally necessary. These books are in like the 6th, 7th, 8th editions. They're very well written. They've got contents pages. It's kind of all there for you. So do what you're used to doing, but for me, it wasn't a case that I needed to spend my whole weekend writing notes. What I did do instead, and this is going to sound a bit weird, I made podcasts because I realized that my commute is an hour long each way to work. So I've got 2 hours a day in the car where I'm basically sat in a lovely warm car with a cup of coffee and no toddler screaming at me. So I just started recording excerpts from the textbooks. Really dull, but the process of speaking it out loud and then hearing it back is really powerful for learning. So I found that really easy, and this Anchor podcast platform is really easy to use. It links in with Spotify. I didn't write down anything about orthodontics in the title because I thought that might be a bit strange with copyright and things for the book. So I gave the podcast my own little name, and I think a few people around the world, you can see the statistics on it, a few people around the world dipped in and probably wondered what the hell was going on. But I did find it really useful, and it meant that really I had 8 hours a week where I was able to just do some work whilst just, heading down the motorway. Depends on your commute. I used to leave the house at about 5:30-ish, get to work for about 6:30. I would start in the department getting through some case notes, or maybe starting writing up my cases before my work day really began. And that was just a habit I was in. It meant that I had time during the week rather than trying to do things at the weekend when I was, meant to be on a play park or something like that. So it worked well for me. It's totally free. It's probably worth having a little play around with, see if it's something useful. Well, okay. Next thing was just this research project that we've all got. I am not a fan of sitting doing all these big academic jobs, but I just decided it was best to get it out of the way as soon as possible. Fortunately, there was a large pandemic and we all got sent home from work, so I managed to literally do my entire research project during my first year. That's pretty lucky, isn't it? I don't think you guys will get all of that. Hopefully, we won't get any more pandemics. But that attitude of just getting it done and finished, I would recommend. I literally had it published in year 2, so there was no bind on me from sitting heavy duty writing, typing out, doing corrections and things. During my 3rd year, I was able just to concentrate completely on MOF work. And it certainly isn't because I enjoyed it. I just wanted it dead. So I just attacked it, killed it off. And I kind of just have this attitude. If you look through books like Bristol Notes, none of the references are people's MSc projects from when they're training. It kind of tells you something. These projects are designed to help you learn and understand how research is done, but you're not going to change the world. So don't let yourself get bogged down by something which will easily eat up hours of your life. If you can, just get it killed off. We're lucky in training. We've got this brilliant NUC, Northern Universities Consortium up north. You've probably got similar things down south. University days, the days where you all meet up and train together. I literally saw them as little holidays. It was great. I could go away, have a little bit of a drink with some friends, meet some new people, have a good night's sleep without being disturbed by this one. And I went to them all and I listened. And again, I didn't really take much in the way of notes. I did take the opportunity to have a wee chat with some of the consultants, not because I'm trying to make a good impression or anything like that, but just if you meet people who you then meet again during your exam, it's a much nicer thing than meeting a stranger in the exam. And I just thought most of these guys who are involved in the lecturing will be your examiners at some point. So it's quite nice if you can take the kind of awkwardness of meeting someone for the first time away. Even just from a candidate perspective, I felt more comfortable sitting there knowing that I'd had like a quick chat to one of these guys at some point. Just try not to make a bad impression if you do head out and have any drinks with them after a teaching day. Next up was this part A. I think for London it's called like part 1, essentially the written exam. An absolutely ridiculous exam from my point of view. Like I had absolutely no idea whether I passed that exam, and a lot of people finish it and feel horrendous. Like you just don't know whether you've got 0 marks or 100%. I felt pretty bad after the exam. We all thought we'd failed it, but in the end we actually all passed it. And I decided to get in and do it as quickly as possible. So I actually sat it in November, which is the first term of year 3. I was able to do that because I just wanted to know that I had the second opportunity in February to sit, and then a third opportunity to sit in May when I sat the rest of them off. And I had a few people say to me, oh, well, why don't you just do it all at once? You can just do one lot of revision that way. But I promise you, the way you'll feel the day after sitting part A, for most people, is not good. You're basically doing a bit of guesswork, and it feels like you've not done well. As I say, everyone I know passed, so it isn't that hard of an exam, but it just doesn't set you up going into the clinical part of MO, having just sat what is quite an awful exam, to be honest with you. And it felt really nice to know that that variable was tucked away. It wasn't something I had to concern myself with, and I could then focus on the clinical aspects of it. All your units will have cases, I'm sure, like a case bank, and I would just try and work through them. It was my colleague who I trained with who basically sent out an email one day to our consultant saying, can we set up once a week practice unseason case? And it was brilliant. We ended up with 12 weeks of every week a real intense grilling. And it worked because we had a different consultant each week, and we basically set like a timetable and a rota for them, and they just sort of went along with it. And it was really, 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 really good training. Getting absolutely ripped to bits by your consultant in your unit is not great, but it's much better than it happening in the exam hall. And I think it set us both up to actually perform quite nicely on the day, because we were used to being really put under pressure and things. If nothing else, it means that you get to practice your little your way of doing things when you're doing the exam. So this was my sheet that I just sort of memorized, and once you've written out a couple of hundred times, it's really easy just to make sure you don't miss anything. The last thing you want to do in an exam is realize that you've sort of forgotten to look for caries, and the examiner mentions that that's a disaster. So just get into the rhythm of it quite early, where you're doing the same thing over and over and over, and then hopefully you won't miss anything. And also you won't have to think, it will just become habit for you. I said I didn't take any notes. These are the only notes I've got from my North training in terms of like textbook notes. And I practiced this spiel over and over. And I wish I'd done it earlier. I only started doing this in about year 3. But essentially, if you can just rattle off these phrases without blinking and without it sounding stunted, you can actually set the examiner up to feel comfortable. They look visibly uncomfortable if you can't even describe how you examine a patient as extra, it's not a good start to the exam if you're stumbling over your words over something as simple as I sit them in the chair and I get them to look straight ahead. So that opening phase of the exam should go incredibly smoothly, because it's the same thing over and over. So again, this was something that went in my little podcast. I listened to it a few times. By the time the exam came around, I could have read that entire sheet here with my eyes blindfolded. And that gave me confidence as well, that the first part of the exam, the first minute or so, was just going to be slick. And then that sets you up ready to go for the exam. Treated cases, I know that Edinburgh are not doing these anymore, but for the London guys, I got in and I did these really, really early. I just made a decision I was going to take cases that I had good records for and that were fairly simple. I think it's a shame that Edinburgh have dropped these. This was one of the areas where I did most of my deep learning process of going through a case and looking at every minute detail. Really helps to consolidate all the things that you've learned on clinic and all the things you've learned from the books. So I basically just pulled all the records, found 4 cases that would be suitable MO if I could get them finished. Started writing them up well before they were finished. I just included like scans of them with the appliances on, and I got them shipped out to all the consultants in the region. It was about 20 consultants that received a bundle of cases from me in term 1 of year 3. And because I was ahead of all the other registrars in the area, I got loads and loads and loads of feedback. I bundled it all up, put it in a folder, went through it all, gathered references, took on feedback. You get all sorts of details from these guys. It's amazing when you get 20 people poring over your records trying to find fault. And it meant that
Richard, sorry to interrupt. Sorry to interrupt. You're still quite muffled, so we were wondering if, I think you sound better when you kind of look up. I know you probably have notes somewhere down, but I think if you look up and talk upwards, I think the sound might be a bit better.
Right. I'm using a work
computer
webcam, and it looks like it was born before I was, so I don't know what's happening. But if I'm heading at you like this, like literally, I'm sorry, you just have to stare at my mouth.
I think that sounds better. Thank you.
Okay, fine. Right, we'll try that then. See how that goes. Okay, so I basically got onto it early, and that worked really well because I got so much feedback before any of my colleagues had even started writing up the cases. It just set me up to know that these cases were going to be fine and I could finish them on time because I know I'm booking short recalls, I know I'm doing my repos, and everything just worked out nice. The feedback that you get is pretty much the questions you're going to get in the exam because a lot of the consultants in the region are going to be examined. So definitely recommend just flying them out to your consultants early on. This is actually a screen grab of the, I think, is it 12 pages of feedback? And you can see, I've put my little references in red, all the bits in blue are the questions that I've got, and that's for one patient. And again, incredibly dull, but record yourself reading that out loud and you'll be able to rattle these off instantly on the exam. Again, it's just being prepared nice and early. These are my actual cases. There's nothing special about them. I didn't try and take anything that's super difficult. 2 Div 1 impacted canine managed with, I think, quad and some extractions. Class 3 impacted canines, extractions. 2 Div 1 again, asymmetric extractions and anchorage reinforcement, and a very simple functional non-extraction. But I think the key was all the records were nice. Everything was completely defensible. There was no weird mechanics. We didn't look anything up. And that's all you really need. I can't imagine that anyone would argue that IOTN 4 or 5 cases are not suitable for MOF. These all were fine. There was no bother with them at all. This is a bit strange, but in terms of exams, I sat both. I sat Edinburgh and London. I knew that we were receiving another baby on the date of the resit for Edinburgh. And so I needed to pass my exam. And so I sat 2 1 week apart, Edinburgh first and London the second week. And for me, that made me feel really loads better. The consultants were worried I was going to stress myself out, I think, by doing too much. But it really worked nicely because I sat Edinburgh, I felt like it went quite well. And then I immediately sat London knowing that the exam had gone well. And I was so relaxed in London, it went fine as well. Equally, if I'd have totally stuffed up Edinburgh, I'm feeling okay because the following week I've got London. It was a total waste of money and time because I passed both. But I think I performed better in both exams because I sat both. So if you're in a situation like me where you know that perhaps the resit is not going to be so straightforward, I would definitely recommend that. There was a lad in the year above us who sat his ISFA exam and he got COVID like 2 days before and had to pull out, and that extended his training by 6 months. So that was in the back of my head as well, that Edinburgh, if I'm sitting in person and there is a COVID issue, then we'll have to pull out. So it's a bit strange, and I don't think maybe consultant exams are a huge fan of people doing it, but you can see that it worked well because I managed to get through both. And in a way, I've been examined, by twice as many people, so I must be doing something right. Okay, I've been asked to talk a bit about KEF tracing. I think there's something in Constance's presentation as well. And maybe
yes, I'm going to be covering it quite extensively, but I'm quite interested to see how you done it.
I think I did it a little bit differently. I went nowhere near hand tracing because I just didn't have time. And I basically made sure they look nice and tidy because the examiners can see if you put in effort, and hopefully you're looking at those KEFs thinking they look nice. I didn't get a single question about my KEFs from any of the 2 lots of exams, and I think that's probably just because I looked at them and thought they look fine. There's no bother with them. So I'm going to show you what I did anyway. I used a program called WebKEF. It's free, but you have to put up with some adverts. So I just paid for something like £8 a month to get rid of the adverts. And basically, it's a program online. It traces the KEF pretty well, but you can alter the points. So you can update your points and move them. But it just means it's nice and quick. And again, you can get in early and get them traced and get them sorted and find any problems with them fairly early on. That's what you get. It's a PDF document. So those lines are infinitely smooth. I've zoomed in. I'm hoping you can see there's no pixelation. That's because it's a vectored image. What that means is when you import it into a program like Inkscape, which again is free, or something like Adobe Photoshop, you get a line which you can alter and you can move around without it becoming pixelated. So this lad's nose is about to go over here, and all I've done is drag the line. It stays infinitely smooth. You can do that with all the points. You can change the colors, you can change the thicknesses, You can do all sorts with it. It's a little bit time consuming to learn how to use, but once you've got the hang of it, you can paste in your images, alter them, save them, send them off, get some feedback, maybe move your incisor apex a little bit. Kef tracing is totally invalid. It's been shown to be full of error. So if you do it by hand or you do it digitally, you're open to the same criticisms. But if you can make it look really neat and tidy, as I said, I didn't get any criticisms. You can underlay your actual X-ray as well, so you can check things, put in extra details, add in, your cellar and all these little details to make them look really neat. And what comes out the other end is this, which is still modifiable. If your consultant goes, oh, hang on, I think that inside is not quite right, you can adjust it. Yeah, we started with notes. I think I've got a little queue development, so I'll try and speed up. Okay, so on to like the actual exam itself. In terms of where I stayed, I was just around the corner from the college. I thought that was sensible because I didn't want to have to be relying on taxis or trains or whatever. So I just stayed in the 10 Hill place. The examiners are there. A lot of the candidates are there. There's no one having a stag do. It's nice and quiet. They do a decent breakfast. There's a gym. The rooms are nice and quiet. Like there's just no better place to sit in your exam. Basically, I'll try and get that booked as soon as possible for the I drove up again. I didn't want to rely on a car, so I drove and I just parked in the driveway and just hired them there. So it just meant I could take books and running shoes and everything I needed. I wasn't trying to bundle it all into a train. In terms of what I did, I'd done all my work by the time I got to exam week, so I didn't really lift a finger during that time. I concentrated on going a bit down the gym, going out for decent food. I went for a run. I met Mr. Scully, I think, on the way up a run, or maybe in the gym. I can't quite remember. And I just tried to have a reasonably nice time. It was a bit like a holiday for me. Again, I'm not doing any Peppa Pig books or commuting up and down the road. So I quite enjoyed that week, in truth. And it sets you up for your exam if you're not going in stressed and exhausted. I think there's a huge benefit in doing things like exercise around the time of exams, so that you're not, wasting away in your mind and just sat eating a load of rubbish in your room. The weather was good, so that helped. But, all these strategies I sort of employed because otherwise I feel like you get a bit nervous sitting in your room waiting for exams. So I just tried to fill that week up with nice things. And it wasn't a bad week, actually. Night before the exam, I went out with one of my mates, not a whole bunch of us, because again, if you hang around with a whole group of people, you get this hysteria effect and everyone gets wound up. So I went out, a decent burger, had a little bit of a chat, and I basically went home and went back to the hotel and had a decent sleep before the exam. I didn't try and read any notes or anything before the night before the exam. During the actual exam, there were some strategies that might help. Unfortunately, there was a bloke outside the window on his mobile phone having a chat, and that was really bad. I wish I brought some headphones or something that could stick in my ears. I'm not totally sure what the rules are, but I think you are allowed like some little phone buds or something, and that might help. You need to concentrate in the exam, and that was the one thing I didn't do that I wish I'd taken, like some little phone things just to block out any noise. The actual unseen exam, I'd practiced so much with consultants, I was quite happy with my spiel and how I did it. And you've just got to remember that if you say you're going to do plan A, the consultant's going to ask you why you're not doing plan B. That's not to say that plan A is wrong, it's just you need to understand, you need to be able to explain why you're not doing something else. If you hesitate and say, oh, maybe I'll do plan B, it doesn't look great if your plan was right. And equally, this advice is a bit dangerous because the consultant might just be trying to guide you. So you need to bear in mind that if you're going off track, they're going to try and pull you back on course. So the only way I can sort of give you any definite advice is just practice loads. And you'll sort of pick up on the signs from the consultant, maybe giving you a little nudge in the right direction, or maybe just trying to just challenge you a little bit. Ultimately, if you've practiced and you know what you're talking about, the unseen exam's absolutely fine. You can't really give that much of a wrong answer, so you can justify it. And if you throw in a few references, you'll be fine with it. The actual scene was carnage. I just finished the consultant sentences before they even answered the question. There was no problem with this bit of the exam. You've practiced it. As I said, I've sent them out to 20 rounds of consultants. I've got loads of feedback. This was the easiest bit of the exam by far. And I got full marks from Edinburgh, full marks from London. So my little technique that I've shown you definitely works. I was very confident, probably bordering on a bit aggressive at this point because I know what they're going to get and I know the answer to it and I'm ready just for the next question. So this bit of the exam, if you prepare like I did, was fine. Between the exams, as I say, I went for a little run up What's that? Arthur's Seat. Lovely day, nice and relaxed. Didn't go back to my room to try and do any more work. Went for a big dinner, had a nice early night, slept. I had colleagues who were trying to sort of read in the rooms and then they look all night because the brains are still working and then they don't sleep all night and you're just not set up well for the next day. So just try and take it easy outside of the exam and do something else. The communication exam, again, if you're all sat in a UK training program, you've got good guidance, you don't need to do any preparation for this. You're not going into detail or mechanics, you're just telling people, reassuring them, you know, making them feel happy if they're sad, making someone who's cross feel like everything's not gone wrong, lots of apologising, empathising. Keep an eye on the examiner. If you can get a smile out of them, you're on the right track and you should be okay. Brent, I think I'm probably going to have to scoot, so I'll rattle through this last little bit as quick as I can. Final thoughts, you're going to be fine. If you're in the programme, you'll be control your nerves, they're the thing that's going to knack you on the day. Loads of people in my course were way better than I was, but just not fall apart, but, you know, didn't perform as well because they didn't control themselves and they didn't put in some of those processes to keep themselves, you know, a bit chilled and things on the day. All the examiners wanted to do well, they did the exact same thing. They know what it feels like. And when you come out the other side, you sort of look back on it and you think it's not too bad at all. And I've rattled through that fairly swift. So if anyone wants to get in touch, that's my email address. Hopefully that's okay.
Brilliant. Thank you, Richard.
Could you hear some of it at least?
Yeah, thank you so much for that talk. That was really informative. So, and especially your idea about doing podcasts. I don't know, are your podcasts still available?
Now, I deleted them fairly swiftly because the sound of my voice, you know, it haunts me. In the dark down the A19, listening to myself talk about overbite, that's just something part of my life I don't want to go back to. But equally, if you were to listen to my voice, you won't get out of it the same as if you do it yourself. So I would just do it yourself. The time it takes to read a chapter, one, you've read it out loud, so you've heard it, and then you can hear it back as many times as you want. I found it really useful, and I only did that because I just didn't have the time to write out notes. But you could all do that and sit on the metro, train, whatever it is, you know, walk into work. It's something that's dead easy. And it's free. So it's worth a go. I think it helps for me.
Yeah, fantastic. Thank you very much, Richard. I know you've got to shoot off, so I'll let you go.
They're desperate for me.
Thank you again.
Okay, cheers. Good luck, everyone.
So we are on to our next section, where we're going to do some practice communication scenarios. So it's going to be myself with two examiners. Did you want to do it separately? I can't remember who I put up first.
We'll just swap over, aren't we?
I've done adults.
That's John's. Yeah.
Is that John's? Yeah. I just thought I'd do a summary slide here just for the delegates. So there are two differences between the Royal College of England and Edinburgh. So England, you get 2 scenarios, whereas Edinburgh, you get 4. You get roughly the same amount of time with the candidate, with the examiner, but a bit longer time preparation time, I believe. I think they're both, you're doing it face-to-face this year, isn't it?
Yeah, the college has made it clear that all their exams should take place face-to-face. It's the safest and fairest ways of examiners to appreciate. And actually, with the cost of the exam, it is expensive to run virtually, but I don't think you see the benefit of that cost. And it almost seems a remote way of becoming a specialist. It doesn't feel real. The college have made it very clear that all exams should take place face-to-face.
Yeah, and I believe England is face-to-face as well. So first scenario, I think I'd sent this out to you guys before. I think the delegates virtually should have had it too, but I'll just say it out loud. You have an adult patient in their late 30s referred in for orthodontic treatment. They have a relatively straightforward class 1 malocclusion with mild crowding and minimal unilateral crossbites. You think there are a range of different supplant systems that you could use to treat this, and although you don't want to extract, you feel that some IPR would be prudent. The only concern you have is that the dentist noticed some ongoing improvements to periodic disease, and today you've found BP scores of 3 in the lower posterior segments that will need resolution before you could consider treating, and a tendency to a thin bar type in the lower labial segment. So your discussion should include an explanation of the type of different appliances that may be suitable, how space may be gained to treat the mild crowding, and the risks of the perio disease that needs to be managed both during and at the start of treatment. Right, okay, good morning.
Good morning.
It's John, isn't it?
It is, yes, yes.
Lovely to
Thanks,
meet
thanks
you,
for seeing
John.
me.
My name is Constance. I'm one of the senior registrar in orthodontics here. I'm an orthodontist.
Thank you.
So we've got you in because you would like to have some orthodontic treatment. Is that right?
Yeah, I've been bothered for a few years about the amount of crowding in my teeth, and particularly since going online, you can see my smile a lot. So I'd like to look at ways to improve things if that's possible.
What's your main concern? I think it was it the lower teeth or the upper teeth?
Sort of both, really. Now I'm a little bit odd. You can see my lower teeth; they seem to have got a little bit more crowded. I never had treatment as a kid at all, so I'm willing to look at all different options. But I'm face to face a lot in my work, so I'd like something, if possible, that was probably more cosmetic. And I've read about various different types of braces, but I don't really know how they might work.
Brilliant. So it's more about the alignment of your teeth as opposed to the colour or the shape of them.
Yeah.
Okay. I know you filled out our medical history sheet, all fit and well, so thank you for filling that. Is kind of the train track braces, what we call kind of the fixer plances, where they're little squares that we stick on the teeth.
Yeah.
There's a wire running through it, and then there's
Are they just for kids?
No, they're definitely for adults as well. So
Okay.
therefore, anyone who basically has teeth.
Okay.
So those are kind of the standard braces that you can see on the outside, top and bottom. You can also get ceramic versions where instead of the metal square, you've got a ceramic coloured square. You still have the metal
Is
wire.
that like a plastic brace? Is
A
it?
type of a ceramic is type like a ceramic or plastic, so it's tooth coloured.
Okay.
And you still have the metal wire going through it, and you've got little elastics going around them as well. So that's
Are there any advantages and disadvantages to those?
so the advantages is that you have really good control over the teeth. You've got a square for each individual tooth. They're glued on, so they don't come out. You don't need to worry about taking it in and out. And they're very common appliances, so we've used them a lot, and we're really happy with them. I guess the disadvantage for you is that you can see them. They can rub against your lips as well and cause some issues. The ceramic ones will obviously have a better appearance, but that's kind of main.
Do they degrade at all while you're wearing them, or do they tend to stay nice throughout the treatment?
So with the metal ones, they stay the same color because it's metal, it doesn't degrade over time. The ceramic ones, sometimes they can discolor a little, or the little elastics around them can discolor a bit as well.
So you have to wear elastics on them?
We put the elastics on, so they're little tiny elastics that we use to secure the wire into the square themselves. So you don't change them, we change them for you. There are other types of elastics that you may have to wear, but that's something else as part of treatment.
Yeah, I know one of my friend's kids had some elastics. It was twanging between the two.
Yeah,
would I need some of those?
We'd have to see how treatment goes during how your treatment goes. Sometimes people use them, sometimes we don't. It all depends on how your teeth move.
Okay.
So that's one type. Another type that you can have is that you can have braces instead on the outside, you can have them on the inside. So they're called lingual appliances. So they are little squares that stick on the inside of your teeth. Benefit of those is that you can't see them. So when you smile, people can't see the squares on your teeth. Disadvantages is that it is a lot more expensive.
Okay.
Because
how come they're more expensive if you can't see them?
They are customized to your teeth. So the other squares that go on the outside of your teeth, they're just kind of standard ones that we take out of a box and we put them on according to what teeth you have. Okay. The lingual ones are customized to yourself. So all the wires are customized to you, the squares are customized to you. So that's what increases the cost. Okay. We do provide them in this hospital.
What braces are
usually if you go out into practice, they would definitely be more expensive.
Okay, does that mean they're quicker because they're more expensive?
No, not necessarily. The cost is going into the production, essentially. The fact that these are customized and made for you.
So if I pay more, I won't necessarily get a faster treatment.
Not necessarily, no. The other options that you have, I forgot to say, if at any point, like you're doing now, just interrupt me if you have any questions.
Yeah, I'm just worried if the things on the inside of my tongue, I can get ulcers and things anyway. Can that be a problem?
Yes, I forgot to mention that can be an issue because obviously everything's on the inside. It will encroach on the space of your tongue, so you are more likely to get ulcers on your tongue.
Okay, and what about, do you wear elastics with those sorts of braces?
You can do, but it's not usual. Okay. It's not common to be wearing elastics with those. So another option as well that we can provide is something but there are other companies as well. So Invisalign is essentially their little plastic mouth guards, and they move your teeth very, very slowly. So you get a whole kind of set of 15, 20 aligners. You change the aligners every 1 to 2 weeks, and it slowly moves the teeth.
So do I get those all up front? And
No, we give you a set each time. So maybe I give you a few at a time, you wear them for a few weeks, you get to the end, and then you get a few more.
Okay.
And we will monitor the movement of the teeth. There's a little program you can get as well, a computer program, where it kind of shows you how the teeth should move. So it gives us a guide. Advantages of that is that once again, it's clear, so you can't see them. So it's quite good. But the disadvantages is that with the fixed braces, we stick them on your teeth and we have really good control because they're always in your mouth. We've got the wire and everything running through. To get the movements with the aligners to help us move the teeth, we have to stick little blobs of filling material on your teeth, what we call attachments.
okay.
They're like different kind of square little blobs in
Can
your
you
teeth.
see that?
They should be tooth coloured, so you can't, they're not obvious, but you can still see them because it is something stuck to your teeth. So they can rub against your lips a bit because with the aligners, you have to take them out for eating.
Okay, so I have to wear them at all times apart from eating them?
Ideally, you have to wear them 23 hours a day.
What would happen if I wore them less? So if I'm struggling and maybe I'm away one weekend and I don't wear them as much?
Or you lose them or something like that.
Yeah.
That can happen. Then the brace won't work as well, essentially.
Okay.
So the brace only works if it's inside your mouth. If it's not in your mouth, it's not working.
Okay.
So it's great for some people because you get that flexibility, but it's a lot more work down to
And
you.
so are they cheaper because they've not got all these fixed bits on them?
Unfortunately not.
Okay.
They're still quite expensive as well because it's a customized appliance. So we would take a mold or we'd do a scan of your teeth. We'd send that information off to a company and then they help us to design the aligners that are fit for you. So that's another reason why lingual and aligners are more expensive because they're customized.
And because is that better for my teeth? Is it more healthy because you're not having to glue big squares on?
It can be because it's something that's not glued to your teeth, so it's less likely to accumulate plaque on the teeth.
Okay.
But it's something that even throughout any of the options that we give you, we need to make sure that we maintain your oral hygiene as best we can because any little bits of plaque can cause more gum.
Yeah, my dentist said there were some issues with my gums.
Yeah.
Does that mean I can't have braces?
I was going to move on to that. So I've had a check of your gums, and especially in the lower teeth, you've got a little bit more inflammation, a little bit more gum disease than I would like for someone who's starting treatments. So you have got a few gaps where the gum is a bit more puffier, and I think there's a bit of bleeding as well. So because orthodontics puts you at risk of having more gum disease, I wouldn't want you to have lovely straight teeth, but then you've got gum disease and kind of the root shrinking away. So,
but even if I get it sorted and it increases the risk again, does that mean you would stop treatment? You wouldn't carry on?
Not necessarily. So if we can get you nice and stable at the start and we can maintain things throughout treatments, it should be fine. So I would actually recommend that we get you back to see your dentist. He or she can go through cleaning, go through toothbrushing, get your gums to a healthier state, and then we can get you back in. I can reassess you, and then we can think about starting.
So my friend had a bit of crowding like me, and he's had 4 teeth out. Will I need teeth out as part of my treatment?
I don't think so. No. Okay. I think you've only got some mild malalignment in the bottom teeth, and I think we can get away with straightening them out. However, it's a bit like getting people on a bus. Your teeth, there's just too many. It's all crowded and it's all bunched up, so there's not enough space to get everyone on the bus. So in order to kind of straighten things out, we need to create a little bit of space between the teeth so we can line it up. Not quite cutting off the arm. It's more with your teeth. We'd get a little file board, it's like a little nail file, especially for the teeth, and we file that between the teeth. Just to create a little bit more space. It doesn't hurt. It is a bit like filing your nails, so you kind of hear that scratchy kind of sound. Teeth may be a bit sensitive for a couple of days afterwards, but it doesn't damage the teeth in any way, and it's something completely safe to do.
We've done 10 minutes. It was, and most of the time, if the flow is coming well from the candidate, the actor only has to interject occasionally because they'll have a list of questions that they want to bring up. Be careful with your analogies. Because, the only way you're going to get extra people on the bus is either getting somebody off the bus or cutting off a few arms and legs. So your analogy for interproximal reduction, I would just stick with, there isn't quite enough room. If we took out a whole tooth, that would give us way too much room. You're only crowded 2 or 3 millimeters. If we take out one tooth, that's a minimum of 6 millimeters. And actually, normally we would take one from both sides, which is 14. You only need 2 or 3. And actually, it's really safe to just take a small amount of enamel off between the teeth in adults. And we use a very fine strip. It's a bit like an emery board that fits between the teeth. We can do that gradually. And it takes even 1/4 of a millimeter added up over several teeth will be just enough that we need without moving the teeth into a damaging position. If we did it without taking the teeth out, because you've got quite thin gums at the bottom, again, pick up on the information you were given, there's a chance that we could push your lower teeth outside the bone, maybe damage the roots further. So I wouldn't be happy carrying out your treatment without that interproximal reduction. If you were unhappy with that, it may be better that you perhaps saw somebody else. You know, you're going to get this situation in your own practice where somebody says, well, you're not doing that to my teeth. And if you just go ahead and whack the teeth out the bone, doing all sorts of treatment.
So I didn't actually pick up I didn't have time to talk about the thin bar type.
So I would start, remember we said pathology. Start with your pathology up front, because actually you're building up the patient. It wouldn't have been an issue. You'd pass that perfectly fine. But actually, I would start with the pathology because that sets the tone for everything else. To say, right, before we chat about this, I just want to talk about the fact that you've got these issues with your gums, because actually, until they're resolved, we won't be able to move on to the braces. It's not a particularly significant problem, and if you see your dentist, settle down with gums first, we'll be fine to move on to treatment. Let's talk about the different sorts of braces. So I would just order it in that way, because otherwise you may miss out being able to talk about that. And you wouldn't fail for it. But it just, I think, logically in your own clinical practice, let alone in the exam, I would talk about the pathology first and deal with that. Okay. We'll move on because of time. So, thank you very much indeed. That was most helpful.
So now we're on to scenario 2 with Colin. So a patient in their late 20s attends as a new patient. Their primary complaint is of prominent upper teeth. They have a 12 millimeter overjet and severe class 2 noticeable mandibular retrognathia confirmed on the lateral cleft. So after looking at the internet, they feel that extraction of 2 upper teeth and fixed braces will help, but I feel that the skeletal pattern is too severe for orthodontic camouflage and he will require an orthodontic approach. So this will involve alignments of the upper and lower arches, non-extraction, and a mandibular advancement osteotomy. So the discussion with the patient should include an explanation of what caused the increased overjet. And emphasize it's not the prominent incisors, but retrognathic mandible, an explanation of why a camouflage approach would be appropriate, inappropriate in this case, and the potential negative effects, an explanation of what the joint orthodontic orthognathic surgery clinic is, and a discussion of the risks and benefits of such a treatment approach. Okay, so good morning. It's Colin, isn't it?
Yes, that's
Hello,
right.
Colin. My name is Constance. I'm one of the senior orthodontic registrars here. So I'm an orthodontist.
Pleased to meet you.
Pleased to meet you too. So we've got you in because you had some concerns with your teeth. Is that right?
Yes.
Would you mind telling me a bit about your concerns?
Yeah, I've just been out on the office Christmas party and there's loads of photos taken and posted on social media. And whenever I see a photo of myself, I really hate it because my front teeth look really, really prominent to the extent that it affects my self-confidence. I had to go at orthodontics when I was a kid and they gave me a block brace, but I didn't really get on with it. And it wasn't the orthodontist's fault, it was just the wrong time for me. But I regret not sort of sticking in with that treatment because it's created some real issues for me now.
Okay, that's good. So we'll try and rectify or kind of find a solution to your issues. Just checking, I know that you fill out all the forms, the medical history forms, so those are all sorted too. Have you had a look at, you said you'd had a brace before, so
Yeah.
you didn't have any teeth out at that point.
No.
Have you kind of had a thought about or heard about any other treatments that?
Yeah, I looked at some animations on the video and they look similar to my sticky out teeth. And there was a video where they took a side tooth out on either side and then that they held the back teeth back while they pulled the upper teeth back and tucked them in. And that just seemed exactly what I need and it looked very similar to my appearance.
Okay, no, that's good to know what your background knowledge is. So I've had a look at your models, I've had a look at your x-ray and things as well. With the treatment plan that you had mentioned, so yes, for some patients, it's quite valid that they can have some teeth out. And if they think that the teeth are really sticking out really far forward, you can take some teeth out and use that space to pull everything backwards. And that
Okay.
can work very well in some cases. For you, I feel that your top teeth are actually in a great position. With the rest of your face, it's quite in a good harmonious
Really?
position. Yes. What it is actually your bottom jaw is too far back, and that makes the top teeth look really sticky out.
Okay,
That makes sense.
how can you tell that it's the lower teeth rather than the upper teeth?
Teeth. So if I show you, this is the x-ray that we took
Okay.
earlier, so you can see that's the side profile of your face.
Okay,
You can see that your teeth at the top here, they should be in line kind of with the front of your face and with your nose. That's actually in a good position.
okay.
But can you see how far your jaw is back here? So your bottom teeth are down here, and there's a 12 millimeter gap between your top teeth and your bottom teeth.
Okay,
There should be a 2 millimeter gap.
all right.
So you can see that actually the gap between your top and bottom teeth is very, very large. All right, so
What you're saying is
Yeah.
that the position of my lower teeth is incorrect,
yes,
and the upper teeth are
are
fine.
actually in a good position. So in order for us to correct that, so the reason your teeth are in the wrong position is because actually the jaws aren't quite in the right position. So your top jaw, how we get the kind of top teeth and the bottom teeth together, your bottom teeth, because they're far behind, because your lower jaw hasn't quite grown forwards enough to match the top teeth.
Can you give me a brace that will correct that?
Unfortunately, that's something that we won't be able to correct with just braces alone. So braces can move the teeth, but we actually need to move your jaws to get them to the right position.
But in the past, I've been offered a treatment, and I think the block braces. I remember they said something about making the lower jaw grow forward. Why is that no longer possible?
So that what you had is called a functional appliance, a functional removable appliance. And that appliance is really good for growing children. So when the bones are still growing, we can try and manipulate the jaws into a better position so they function in a better position. They don't necessarily grow jaws, but at least they get them to a better position. Unfortunately, you're past your age of growth, and so we won't be able to utilize that functional appliance. And plus, the gap is a very, very big gap. It's a 12 millimeters, it's a centimeter gap.
Okay.
So the only way, the best solution I think for you is that if it really concerns you, is actually we get you seen by an orthodontist and a surgeon on something called a joint orthognathic clinic. So that is where
So it's not going to be just a brace. It's going to involve an
not.
operation.
Yes, so I think the best thing for you would be to actually have an operation where we bring the lower jaw forward so it matches your top teeth, so that everything would then be in harmony.
Where would the surgery be done? In the lower jaw?
Yes, so it'd be done in the lower jaw. I want to tell you a bit more about the surgery, but I think it's best you actually hear it from the surgeon themselves.
Okay.
So that's why I want to get you on this joint clinic where we can get you talking to you still need braces. I should have said at the start, so they would involve top and bottom braces, usually kind of the train track braces.
So do you straighten the teeth and then take the braces off and then I'll have an operation, or how does it work?
So we put the braces on first. It usually takes about 18 months for us to straighten the teeth and get them in the right position. You would then have the surgery to bring the lower jaw forward, but you'll still have the braces on. We actually utilize the braces for the surgery.
If you do some brace treatment and it makes it a bit better and I decide not to have the surgery, can we see how the orthodontics goes and then I can make a decision about the surgery?
It would be difficult because there are two different ways to move the teeth according to whether we make you ready for surgery or we try to camouflage and mask where your jaws
What's
are.
camouflage?
That's when we're masking. So we kind of accept that we're not going to move your jaws and we're just going to try and move the teeth into a better position. If we are going down the surgery, we actually sometimes make your bite worse or try and maintain the bite before we correct it with the surgery. So your main concern is that your top teeth are sticking out. And I'm saying that your top teeth are fine. It's actually the bottom teeth that are too far back. And that's what's making the top teeth look as if they're sticking out. So
will it change my facial appearance?
it may do. So any kind of jaw surgery, because we're moving your jaw, it can change your overall appearance, but it will make will never make anyone look worse. It will always make your patients look better.
Okay.
And I think by bringing your lower jaw forward, it would make your face more in harmony and more balanced as well.
Is this something that's done a lot in your hospital, or is this very unusual?
No, this is a very common procedure for our hospital and for any hospital as well. We see a lot of cases where the jaws aren't quite in the right position, and so we move the jaws into the correct position.
And patients who do get a change in the facial appearance, how do they react to that? Is it something that causes some problems?
No, we can, with you actually, we can actually get you, if you postured your jaw forward, so you're trying to bite with your teeth together, that's a ballpark figure of how he looks. If I get you a mirror, this is kind of what you would generally look like. So you can see that your face is a lot more in proportion. You can get your lips together as well. So that's kind of a ballpark figure of what you would look like. So you would look better. Yeah.
And is there any risks to having the surgery?
There's always risks to any procedure that you have. So it is under general anaesthetic. It will be potentially an overnight stay in hospital as well.
Gosh.
So there are
quite a big undertaking.
Yes, it is. There is quite a lot to it. So you will have to have time off work or university, whatever you're doing, for at least 4 weeks. You will be on a very soft diet with no chewing for 6 weeks. So yes, it is a lot for some people. Some people decided that surgery is not for them.
Does it always go according to plan?
Yes, so majority of cases, it always goes to plan and everything comes out well. The main risks to surgery would be the general anaesthetic the risks of the general anaesthetic, things like pain, bleeding, a lot of swelling afterwards. So that's why we say take 4 weeks off, at least off work or uni, and also numbness too. So there's a nerve that supplies sensation to your teeth, lip, chin, and gums. That will be not damaged. That will be they will have to move that and manipulate that nerve whilst they're moving the jaw forwards, because the nerve sits within the bone. So you will have some numbness of your teeth, chin, and gums, and chin after surgery. It doesn't affect how you look, so you can still move, you can still eat and things.
So the face won't droop down on one side?
It won't droop down, no. It just feels a little bit numb where you touch it. So for some patients, the numbness goes away completely and they're back to full function after a few months. Some people find they might still be a little bit numb in certain areas after the surgery.
Okay.
And that can be permanent.
Okay. So it's quite a big deal, quite a lot to think about. Is there any websites you can suggest or any resources I can look at?
Yeah, definitely. I can get you a leaflet in a second. We've got something called the British Orthodontic Society, so they're our national society, and they've actually created a website called My Jaw Surgery, Your Jaw Surgery. And for you, there's actually a case where someone's got a similar case to you, where they've got a jaw that's set back and they were complaining of sticking out top teeth. And they actually talk about their experience of surgery, so you can get a patient's point of view. And there's also some videos as well to show you what the surgery actually looks like and what the braces look like and things as well. So I'll give you that, and we'll give you our local leaflet as well, which has more information about the risks of surgery too. But I think going forwards, it might be best that we get you on that joint clinic with all the records, and we can further discuss your plan. And you can decide to take up the treatment, or if you don't, an option is to not go ahead with the treatment.
So going to see the surgeon doesn't commit me to having the surgery. Won't think I've wasted his time if I decide it's not for me.
Not at all. I think it's best that we get all the risks, that you get all the information, and then you can make an informed decision.
Okay. Well, thank you very much for your time this morning. You've explained it very clearly, and I do appreciate it.
You're welcome. I think that is it. Right.
So I thought Constance did very well there. A number of things came out of that. I think she was quite empathetic because obviously the patient had come in with a very fixed idea from the internet that was erroneous about the management, and she was quite tactful and explained why that wasn't appropriate for me. If you are discussing abstract concepts, it's really good to pretend you're in front of the X-ray viewer with the lateral keph or in front of the computer with some tracings and point various landmarks out. And I think that's a really good device in the communications session to help your communication. Try and make it as real to your patient interaction chair side as you can, so you can pretend to have study models and measure an overjet or show them the occlusal arch in the study model and say, you can see the overcrowding and we'd like to take out that tooth and that tooth and create some space here and here, and then we can move the teeth sequentially around. Whatever you're trying to explain, try and make that real to your own clinical environment, and pretending you have props or you're looking at something on a computer screen. I think that's very useful. In this case, it was about the patient having an idea that their upper teeth were prominent, but that wasn't the case. It was the lower teeth in the wrong position. And pretending you have a keph and pointing out the landmarks, it really does help the communication. So I thought that was really good. Just having a logical approach, being reassuring about the surgery, particularly the patient hadn't considered surgery as a plan and they're hearing about it for the first time, and reassuring them that they have a chance to meet the surgeon and it's not committing them to definitely go ahead with treatment. So I think a number of things came out there. You would have a comfortable rest of that performance, and I thought that went well. Have you got any comments from your point of view?
I guess for me, I hadn't really prepared this. I kind of read it before, was like, oh yeah, that's fine. Colin had asked me if I wanted to go through it beforehand this morning. I was like, we don't have time. So it was literally me ad-libbing. But it is something that we see patients all the time like this, where they're sticking out teeth and it's like they're going for surgery. I felt that there were times where you were kind of offering me a chance to say something. So things like the BOS leaflets, it's like, I know about it. Would the actor prompt, if there's something that we need to ask, I guess they will prompt to say like, oh, is there something?
They may or may not. It's safe to assume that they won't.
Okay.
But it's always better to offer information, particularly about complicated things like orthodontic surgery, not only verbally, but back that up with the offers of either a link to a website with some animations or some written leaflets. But the reason why I prompted you is I wanted you to say that so I could make the point in the feedback that give the check that the patient's understanding the information that you're giving them, and maybe wrap up the interview by saying, I hope you've or checking sequentially to the interview, are you understanding what I'm saying? Is it clear enough? Do you want to ask anything? And at the end saying, I'm available if you want to come back for any information, and we've got some written information and some web links that you can link to for additional reflection.
Brilliant. Well, thank you very much, Colin. Thank you very much for that.
Thank you.
I think now we are on to our lunch break. So I need to have a look at our timetable. That was me fine. Brilliant. All right, it's all yours.
Right, thank you very much. And thank you very much to the CGG for inviting me to talk this afternoon. So what are we going to talk about? So today we're going to talk a little bit about the design of temporary anchorage devices, some of their indications, some of their the sites that we place them. We'll talk about the planning phases for placing them, as well as some of the mechanics that we use. And we'll talk you through step by step. So you've already had a talk this morning from Mr. Melrose around anchorage. So you'll all be aware that there's lots of different mechanisms that we can use to reinforce our anchorage. And from an exam point of view, I think it's really important to remember that you don't have to use TADs for everything. So in my recent experiences of examining MOF, it seems that everyone wants to use TADs for everything all of the time. And that's fine if they're indicated, but you don't have to use them all the time. Now, these are mechanisms of anchorage that we can utilize. So you'll be familiar with headgear and the TPAs with or without the nance button. Elastics, some would argue that certain systems are more anchorage or less anchorage demanding than others, for example, tip edge. And functional appliances can be used for anchorage reinforcement as well as overshare reduction. Temporary anchorage devices or orthodontic mini implants is kind of an umbrella term. There's lots of different types, there's lots of different shapes and sizes, and temporary anchorage devices and orthodontic mini implants, as phrases, can be interchanged. So if you're reading around the literature, especially in the international literature, a lot of papers refer to orthodontic mini implants or orthodontic mini screws, whereas in the UK, the majority term used is temporary anchorage device. As you can see, lots of different shapes, sizes, designs, but the vast majority of them have the same components. And it's important that you understand what they are for, what they're used for, and what the different varieties can be used for. So the head's really important because that's the way in which we're going to attach the mini implant or the TAD to our appliance. And there's lots of different ways of doing that, but you've got to make sure that the type of temporary anchorage device you're using is compatible with the mechanism that you want to attach it to the device. For example, if you are wanting to use some direct power chain over one that doesn't have something that you can hook it over, and you're going to have to use a lig to tie it through the hole we've got here, for example, then you need to just know about it. So it's just important to know what the type of temporary anchorage device you're using, how you're going to attach it to the appliance. From a profile point of view, that has two impacts. So if you've got a really tall mini implant head, then that's going to irritate the patient more than a low profile head, for example. But also, if you're attaching the vector of force, so if you're attaching, for example, a nickel titanium coil to the TAD, but it's a long way away from the mucosa, then that's going to have a rotational effect and change the vector of the force, and might lead to rotations or tipping of the teeth that's unwanted. So it's important just to be aware of that. The neck is the part of the temporary anchorage device that goes through the mucosa. It's also generally the part of the temporary anchorage device that connects to the screwdriver. So it's usually either pentagonal or hexagonal, so that you can engage the screwdriver purely round and the screwdriver just spin around and insert it. They usually have a tapered section, so that when you're placing it into the mucosa, if you're doing it at different angles, you'll still be able to get the neck into the mucosa. And some have short and long neck versions. So for example, the Infinitas system, which is the one that I'm most familiar with, has two neck types. It has a short neck and a long neck, and it depends on where you're placing it. So if you're placing into a site that's got thicker mucosa, so for example into the palate, you might want to use a longer neck, whereas if you're placing it somewhere where you've got relatively thin mucosa, for example in the posterior buccal segment, then you're more likely to want to use a shorter necked version. Body, so the different temporary anchorage devices have different lengths of thread. So some of them, like this one, see, I've got something here. So you've got it going all the way up to the top. So you've got the whole length here, goes up. Some of them sort of stop about there, and that bit would then be flat. They've generally got self-drilling tips and self-drilling threads, so you don't need to, in many circumstances, do any pilot drilling beforehand. There are certain circumstances where you might want to do a little pilot hole, and we'll talk about that later on. As I alluded to, there's different types, so there's different designs, and so there's different lengths and diameters of temporary anchorage devices. What's important from an exam point of view is that you have some idea of what variety there is out there, what you would tend to use in different areas, and also from a length and diameter point of view. So, as I alluded to before, the Infinitas system is the system with which I am most familiar. And these are the different types of mini implants that you can use through the Infinitas system. So we can see on the left, we've got one that's 1.5 millimeter diameter. It's 6 millimeter in length and it's got a short neck. Whereas we move to the next one, you've got a 1.5 diameter. It's a longer one at 9 millimeters, but it's still got a short neck. And you can follow those through. The final one at the end is slightly different. That's a new one, and we'll talk about that right towards the end of our or throughout our discussions. But it's a 2 millimeter, 6 millimeter with a long neck, which is identical to the yellow one, but it's got a different head because it's used for a different thing. So what's really handy is that there are charts out there, and this is online. But for whatever system you're using, it's useful to have an idea of which one you'd use where. So, for example, if I'm placing one in the posterior buccal segment, then as a general rule, unless there are mitigating circumstances, I'm using a blue one, so I can go down here and go, that's going to be a 1.5 diameter, 9 millimeter length with a short neck. So these are really useful when you're planning and preparing for your exams. It's really useful to have this information in your head so that when somebody says to you, you say, I'm going to place a TAD in the palate between the 6 and 7, then my next question is going to be, okay, that's great. What size of temporary anchorage device are you going to use? And you're not going to say a really long, really short-necked, whatever. You just have some idea of what you're using where. So this sort of table is really useful in preparation for exam, because if you're going to use a temporary anchorage device, you need to know which size you're going to be using, because I'm going to ask you that question. So why do we like temporary anchorage devices? Well, we're less dependent on patient compliance. So with things like headgear and twin blocks, you are very dependent on patient compliance because they've got to wear them. And these are not completely independent of patient compliance because, first of all, the patient's got to sit in the chair to have it put in the first place, and then they've got to keep it clean, otherwise we know there's an increased chance of it failing. So you would never say that it is completely non-compliant, or you don't need compliance. You do. It's just probably less so than something like headgear or use of a twin block. If used correctly, you've got increased predictability with respect to the mechanics and the outcome. You can use them in lots of different places in lots of different ways. And so you can get 3D anchorage. So you can use it for intrusion of teeth, for extrusion of teeth. You can use it for AP. You can use it for transverse reasons. So it does give you control in 3 dimensions. It's ideal for adults because you're not going to find many adults keen on wearing either functional appliances or headgear. So it's good for them. And if you know what you're doing, then it's relatively easy to insert and remove them. It's not something I'm going to necessarily cover today because it's not easily done in a practical way, but they're easy to put in and remove if you have the correct training. You can put them in lots of different places, as I alluded to, and the research would suggest that as a general rule, when compared with other types of anchorage control, they are usually preferred by patients. So how do they work? So initially, we using mechanical stability. So we pop them in, the threads engage with the bone, and especially with the cortex. Then we get a resorptive phase of bony remodeling as the temporary anchorage device goes in. So a good analogy is if we think about if we're putting a screw into a block of wood. Put a screw into a block of wood, the wood doesn't react to that. So the screw will stay as firm as it does when it first goes in because wood is inert. Bone is not inert, bone reacts. So you get initially a resorptive phase around the temporary anchorage device. So therefore it will reduce instability over the first little period. Then we get bony deposition, which is then occurring at a rate faster than resorption, and that's when we get our secondary stability. So graphically, let's do this. So if we look at this graph here, this is quite good. So the thick black line is overall stability, and this is an implant stability quotient. So it's from a patient, it's not from a patient, from a author called Yuri, and this is an angle. And they came up with a quotient, which is a bit interesting if you look into it, if you look into the paper, but they've come up with a figure. And the way they've measured it is they've measured the overall stability. And what we can see is they can look at the primary stability, which drops off, and then the secondary stability, which is done from bony fill-in, improves as time goes by. So what this means, and this has implications for when we're utilising the temporary anchorage device, because we know that it's going to get less stable before it gets more stable again. So what you don't want to do is put loads of pressure on it around week 3, 4, because that's going to be when your stability is at its weakest. So different people have different opinions as to whether we should be immediately loading our temporary anchorage device. And this is something you'll see throughout the literature, is you will read something telling you that immediate loading will increase its stability, and then you'll read something else saying it won't. And the evidence is really poor around this because there's conflicting evidence. The theory behind why, if we load it immediately, it will improve in stability, is that there's an argument that by putting pressure on the temporary anchorage device, you're increasing cellular turnover, which will in turn improve stability. And also there's an argument that by putting some pressure on the temporary anchorage device, it sort of digs into the bone with sort of a tent peg approach. What we can see from this systematic review is that some papers have shown that it favours delaying loading. Some papers say it favours early loading, but overall it seems to find that there's no real difference. So if in the exam somebody says, are you going to be loading it immediately or not, there isn't a right or wrong answer. Just understand the various principles behind why it may be a good idea to immediately load it, or why it might be a good idea to leave it for 8 weeks before you're going to load it. So it doesn't necessarily matter what your answer is in the exam as to whether you're loading it immediately or not, just as long as you understand the arguments for and against. The only area in which there is evidence, and again, this isn't a great trial or a great piece of evidence, is that we can see that if we look at the success rates of adolescents here, when they're immediately loaded, it's significantly less than in the adolescents where it's loaded late. They're not big, it's not great, not a great piece of research. However, it does show that late loading in adolescents in this paper was more successful than early loading. And in my clinical practice, because I haven't got any other evidence to say otherwise, I delay loading in adolescents. Okay, so let's look at factors affecting the success of our orthodontic mini implants. So there's patient factors, we've got factors associated with the design of the temporary anchorage device, and then we've got some clinical factors. So age. We know there's reasonably comprehensive evidence that the failure rate is higher in adults and higher in adolescents than it is in adults. So we get more success in adults because of the way in which the cortex is made up. So as we get older, our cortex gets thicker and more dense, and therefore we get better primary stability. We know that if our patients don't keep them clean, they fail and get peri-implantitis, and then the implant fails. So it's really important that we teach our patients to keep them clean. We tend not to advise that they use an oscillating head electric toothbrush because that might irritate the temporary anchorage device, certainly when we've initially put it in. So I usually advise my patients to use a manual toothbrush around the mini implant. As would be expected, smoking is going to have an adverse effect on success, and there is reasonable evidence that they get higher failure rates in high-angle patients, and again, that's thought to be due to the bony cortex. Success rates differ depending on the jaw. We know that we get higher failure rates in the mandible than we do in the maxilla, and that's thought to be due to the thicker cortex in the mandible, especially in the posterior mandible. And then these are the cases where you might want to consider doing a cortical punch before you place the mini implant. So in cases where you're worried that the cortex is going to be too thick, we'll come back to this in a moment, but then you might want to do a little cortical punch first prior to placing the temporary anchorage device. We know that they do poorly in unattached mucosa, partly because they're difficult to keep clean. They get irritated just by the mucosa rubbing around them, and also actually it's quite difficult if you try to put them into patients when you're putting them into unattached mucosa. It's not to say they will definitely fail, but it's definitely more difficult to place them. And there's reasonable evidence to say that the left side has a higher success rate, the theory being that most people are right-handed and most people brush better on their left side when they are right-handed, and that's why you get a higher success. It's not massive differences, but there's reasonable evidence to support that. when we're placing temporary anchorage devices, we want to keep them away from the roots. And this isn't really so much because we're worried about damaging the roots. It's more because if we place it next to a root, then we are going to get a higher failure rate. And there's a good amount of evidence to say that if we place the mini implants next to the periodontal ligaments or in the periodontal ligaments, then we will have higher failure rates. And so Kuroda did a little diagrams here to show, and the category A did better than the category B, and the category C's all failed ultimately. So, well, they didn't all fail. It's not true, it's an exaggeration. But they did, their failure rate was much higher. And it's thought to be likely that because when we're chewing and putting our teeth together, that then leads to jiggling forces around the temporary anchorage device if it's next to the periodontal ligament, which then causes the temporary anchorage device to fail. We're not really concerned about putting them, first of all, when you're putting them in, if you put them into a root, you know about it, because it just stops. So you're going in very nicely, and then if you hit a root, then it just stops going in. And I guess you could really ram it in there, but you sort of clock that it's not going in. And you might cause a little bit of a divot into the roots, but there's plenty of evidence to show that it doesn't cause any problems with the teeth long term. In fact, there's studies where they have intentionally moved teeth into temporary anchorage device. So there were teeth that were planned for extraction. They placed temporary anchorage device, then they intentionally tipped the tooth that was going to be extracted anyway into the temporary anchorage device to see what happened. And then they either took it out straight away or they left some to see what would happen, took them out, and there was good evidence of healing. So we're not worried about hitting roots from that point of view, but we want to avoid hitting roots because then our temporary anchorage device will fail. So I talked a little bit about the cortex and cortical bone and why it's so important. And it's really because most of our stability comes from the cortex. So when we get into cancellous bone, we're not getting much stability. So when we're placing a temporary anchorage device, we want the right level of cortical stability. And there seems to be there's sort of a sweet spot or a sort of window of opportunity. And the ideal pressure that we should be putting on the torque that we should be placing when placing a temporary anchorage device has been found to be in the region of 5 to 15 Newton centimeters. If we put it in the torques too low, then we won't get the primary stability that we want, and it'll fail really quickly. If it's too high, then we cause bony necrosis, which will cause it to fail due to secondary stability. So obviously, if we're using a cordless handpiece, which some of you may or may not have seen, they've got on them, you can set them to do a certain amount of torque. So you know you can set it to 15 Newton centimeters, and when you're putting it in, you know that you're not going over 15 Newton centimeters because the cordless handpiece won't let you. What you don't have is when you're using a manual screwdriver to pop them in, is that you don't have something telling you what is 10 Newton centimeters. So it's just something you'll gain from experience, is getting a feel for how much pressure you're putting on. But from an exam point of view, you want to be putting them in between 5 and 15 Newton centimeters. In a real world situation, then you'll get a feel for that as you do it clinically. But the idea is you don't put them in really, really quickly, because you're likely to cause bony necrosis, and that will then lead to their failure. From a success rate point of view, thinking about the size of the implant, we know that diameter is more important than length, and that's to do with how much engagement we're getting with the bony cortex. So that's the important bit, really. So we want the diameter. It's been shown that once you get below 1.1 millimeters, you get much higher failure rates. There's no real evidence that 1.5 gives you or more than 1.2 or anything like that. But we know that if it drops beneath 1.1, then the failure rate significantly increases, and therefore you won't really find any on the market that are smaller than 1.2. Well, not in my experience. Again, length has not been found a huge factor in stability as long as it's 5 millimeters longer or longer. So you'll find the shortest ones generally out there are about 6 millimeters. So the argument then, and some of my colleagues do stand by this, is that why bother putting one? If length isn't making any difference, why would you put in a 9 millimeter? Why don't you just put 6 millimeters in for all of them? Because if it's the cortex, you're going to be engaging with that cortex with a 6 millimeter one just as much as you are with a 9 millimeter one. And it's a valid argument, and there is no evidence to say otherwise. My argument for why using a 9 as opposed to a 6 is that it can't do you any harm to get those extra threads in there into the cancellous bone. but there's no evidence to support it. But it's useful in your exam. It's probably useful to be using the recommended length in the recommended places, because then it saves you having to answer all the questions. What we know is that clinical training, as with everything that we do in life, the more we do, the better we get at it. So there's good evidence to say that those that are experienced get a higher success rate than those that are inexperienced. So how many in this room, I'm not going to go online, but how many in this room, how many of you have placed temporary anchorage devices? And how many of you got 100% success records? Oh, we've got a few. That's probably because you only put 2 in and 2 succeeded. But yeah, so it's generally when we're popping them in, you're going to get failures at first, and it's don't be disheartened if you do. For those of you who haven't placed any thus far, if you do go back to units or you in future pop some in and they fail, don't worry about it, because it happens to all of us. It's not, you're going to get better the more you do. When do they fail? If they're going to fail, they nearly always fail within the first couple of visits. So then when looking at when they fail, 80% fail within the first 4 months. The mean failure time is 1.8 months. And that fits in with my clinical experience. Generally, if I plop a temporary anchorage device in and it comes back and it's solid next time, I think that's probably going to stay there. If it comes back next time and it's mobile, then you just take it out and have another go. Or you take it out, give it a bit of time to either put it in a different site or give it some time to heal and then pop it back in again. But generally, if they're in there after the first visit and they're solid, they rarely fail after that, unless the patient's toothbrushing drops off or something like that. What are our concerns? Well, I alluded to earlier the damage to roots. We're not really that concerned by that. Infection and peri-implantitis are rare. I think I've seen 1 temporary anchorage device that's got some infection around it, and I've got quite a lot in. Fractures, yes, they do fracture every now and again, generally in less experienced people, because they'll either be putting too much force on, or they put it in, take it back a little bit, put it in, take it back a little bit, put it in, and then overall it just they get worn and they fracture. Theoretically, we're concerned about perforating the nasal sinus or floor. We'll take a PA to check they've not got a really low sinus before taking the transpacific temporary anchorage device. You're not going to want to put one into the mental foramen or into the incisive foramen, so you just got to be aware that we could cause damage to nerves should we put them in a place where there is nerves. Instability, yeah, nobody's going to get 100% success rate. At some point they're going to fail, so you just have to accept that and explain to patients that when you're starting off, I would say you probably estimate that maybe 1 in every 3 that you put in might fail. So you just say, look, you might fail 1 in every 5, something like that. As you get more experience, generally, once you pop quite a lot in, you're generally talking about a success rate in the region of 85–90%. So I usually say to my patients that 1 in every 10 of these that I'll pop in will not take, and in which case we'll just take it out and either put it somewhere else or put it in a new one in. Osseointegration, there are case reports in them osseointegrating and therefore needing to be drilled out. I've not had any experience in that, and there's really low numbers of case reports out there on it, so it's not something that I really talk about to patients, but it's something to be aware of. And then obviously if they've got bleeding disorders or something like that, there's a risk of problems with that. Okay, so in your exam, you're going to identify a case and you're going to decide that you want to use a temporary anchorage device or a mini implant. That's fine. So you've worked out what you're using it for. You then have to think about where am I going to put it and how am I going to use it? And those are the key questions. If you're thinking in your exam that I want to be using a mini implant, you need to be able to answer these questions. You need to be able to answer why do you want it, where are you going to put it, and how are you going to use it? And there's lots of different reasons why we might use temporary anchorage devices. So I've listed them on the left, but I'm just going to give these are just some examples of a handful of cases that we've got. So for example here, I think Mr. Melrose might have talked a bit about intrusion earlier. This is using a temporary anchorage device for intrusion, which I'll cover again a bit later on. In this one, we're using it, so this person's got, those aren't real teeth. Well, they are real teeth, they're teeth that have been extracted and sectioned because they were macrodont, and so we're using it because we want to protract the buccal segment. We can't afford the overjet to go down, so we've used it indirectly here. This was a police officer who didn't want to have appliances on her front teeth, but we needed to rotate her premolars in order to facilitate for our restorative colleagues. So we used a TPA with some hooks on here to help rotate it that way, and then I popped some temporary anchorage devices in just anteriorly to help rotate the teeth, and therefore we didn't need to put anything on a upper anterior segment. What we're using for here, we've got patient missing lateral, and so we are retracting a canine directly using the temporary anchorage device later for a prosthetic lateral to go in here. I'll talk a bit more about this again in a bit. Here we're retracting the entire upper labial segment, and down here we're using this for meso because we're missing laterals. We've got threes where the lateral should be. We've got deciduous canines which ultimately will be extracted, and then we're using this to mesialize the buccal segment. Drink. So we'll concentrate on some of these a bit more. I can't run through everything today because I've got 45 minutes. But we will cover some of these in a bit more detail. But this is the key in the exam is how am I going to use it and where I'm going to place it, and they affect each other. So if you're going to want to use it for if you're going to want to use it in a certain way, you need to make sure it's placed in the place that you can utilize it for. One of the key things that seem to confuse people in the exam is this concept of direct versus indirect anchorage. It's not rocket science, but some people, it just seems to confuse people in the exam. So if you're using it directly, that means you are directly attaching the temporary anchorage device to the device and using it for it to be used for that purpose. So for here, for example, we are directly attaching the temporary anchorage device to this power arm to retract the upper labial segment. So that is directly using this. That is direct anchorage. Here, we have used the temporary anchorage device to lock in this central incisor so it can't go anywhere. So there's composite there, so this can't go anywhere. And then we're using normal mechanics to protract the buccal segment. So here we are using it indirectly. Similarly, here, we are doing not dissimilar to what we were doing in the direct case. We are indirectly tying the TAD to the 3 and then using normal mechanics to retract that. If we wanted to use it in this case directly, we would then put a power arm on here and then use it directly back to the temporary anchorage device. Here we're using it indirectly again because we are locking in the lateral so they can't move through the temporary anchorage devices and then protracting the buccal segment. The direct and indirect thing does seem to be something that seems to perpetually confuse people. I'm hoping that's sort of clarified. Does that make sense? So what are the advantages and disadvantages of direct versus indirect? Because if you say you're going to use it directly, someone in the exam might ask you, well, why have you chosen to use it directly? But it's straightforward to use it directly. You can use power arms, which I'll come back to in a moment, directly for bodily tooth movements. There's less need to involve lab work usually. If the big one, or one of the big ones, is that if the temporary anchorage device fails, it's not going to cause any problems. Because if we look at this example we've got here, we're retracting the upper labial segment. Well, if the temporary anchorage device fails, all that's going to happen is you're not going to get the retraction that you wanted. Whereas if we go back to the previous one here, you've locked in the temporary anchorage device to the canine. If the temporary anchorage device now fails, well, instead of the 2 coming back to the 3 and the 2 will come together. So you'll get anchorage loss. So that's one of the main disadvantages of using temporary anchorage devices indirectly, is that if the TAD fails and you don't notice it, you might lose anchorage. Disadvantages of using them directly is that in certain patients in certain sites, we know, for example, that in the upper buccal, posterior buccal segment, maybe in a high angle adolescent, you're going to have a higher failure rate than we would if we were using something in the palate. And you're limited, if you're trying to use things directly, there's limited mechanics, there's so much you can do. So indirect anchorage has more predictable success rate because you can choose the site that's going to be predictable for that patient. So there are some people who talk on temporary anchorage device courses who say that they will just use them indirectly because they feel that they know if they put the temporary anchorage device, and they generally talk about putting it in the palate, they know that if they put it into the palate in a certain site, they know that it will be successful in the vast majority of cases, and they then work their mechanics around that. and that's a reasonable argument for that. You can do more complex tooth movements when using things indirectly, but often you will require some kind of appliance or auxiliary bent up or some kind of lab made thing for it to work. Some would argue that you get less efficient tooth movement if we're directly retracting the upper labor segment using a power arm, then you're directing the forces through the centre of rotation of the teeth, which might lead to more efficient bodily movement of the tooth. And like I said before, anchorage loss can be masked if failure is undetected. Come back to that. So here's just some indications for maxillary buccal sites, because most people who start off with temporary anchorage devices do probably put them in the maxillary buccal sites. So we'll just talk about that a little bit. So if you're wanting to do incisor canine retraction, you often put them into approximately between the 5 and 6. For molar mesialization, you often put them distal to either the canine or the lateral incisor. If you're using it for sense line correction, you'd often again put it buccally between the 5 and 6. And then if you're using it for intrusion, which we'll talk about before, I don't tend to place them buccally for that, but there are some people who place them buccally for intrusion mechanics. So as I alluded to, this is the most common site to place it. It's between the 5 and 6, and you can use it for central line correction or for incisor and canine retraction. And it's usually you'll want to have a PA beforehand to check that you're going to put it in this area, that you've got plenty of space to do it. So you'd want to take that pre-implant radiograph, and that shows one or two things. It shows, yeah, loads of room, not concerned, that should be straightforward. Or no, there's no way I'm going to get a temporary anchorage device into that gap there without hitting one of the two teeth. So what happens if you do that? We need to plan for root divergence. So what does that involve? You intentionally place the bracket in the wrong place to tip the tooth so you create space. And that's something I do reasonably regularly. At the end of treatment, you then need to, once it's been used for whatever you used it for, and then you've taken it out, you would then reposition the brackets into the correct place and tip that tooth back upright again. Here's just a little example. So you can see there's not much space here. So you can see that we've intentionally put the brackets in the wrong place. We've got sort of a bend in the arch wire, the Nite arch wire, and then that's led to loads of room there. So that's just a little clinical tip. So as I alluded to before, you've decided you're going to use one buccally. You're going to get asked by the examiner which one you're going to use, and you're going to think back and you're right, buccal, posterior, maxilla. We're going to use the blue one. What's the blue one? It's the 1.5 by 9 short neck. That's just that. Then we need to work out how we're going to attach the temporary anchorage device to the appliance. So you can use lots of different ways. You can use long ways. What we've got here, we've got some power chain there, we've got an E-link there, we've got a Nite closing coil there. We're using it indirectly using a leg here, as we alluded to before. So it's just thinking about what we're going to attach to it and how it's going to work for us. Just a little, the little Neil Hilliard thing's getting in the way there. Move that a little bit. There we go. Okay. Just a little clinical tip if you place them, because sometimes, so in an ideal world, you'd place it so that you are directly attaching the Nite closing coil to the nearest wing. Well, that's only if you've got it at exactly 90 degrees. So if your wing was up here, this was rotated to the left, you'd either have a choice of putting it here or down here. You always want to put it so that the force will be turning the temporary anchorage device in a clockwise rotation, because that's the insertion, otherwise you'd be loosening up. Just a little clinical tip. I'll tell you how that looks. Let's move you back over here. Yeah, let's try that. You don't want to be using your buccal temporary anchorage device on a nickel titanium arch wire. Otherwise, what's going to happen is you're going to overpower the arch wire. And when the temporary anchorage device is quite a long way away from the occlusal plane, then you're going to lead to tipping of that tooth, which will lead to a sort of roller coaster effect. So certainly for just in general, you want to be using them stainless steel arch wires, but you definitely in the exam don't want to start talking about using temporary anchorage devices too early. If you're using it on a steel arch wire and you're attaching it directly to a normal ball hook, then you need to be aware that you've got different vectors of forces because you're not using it as long if you're using it directly, it's not acting in the same way as you're used to using the straight wire plans. And because of the position of the center of rotation of the maxilla, if you are placing it from between the 5 and 6 directly onto the archway, then you're going to lead to a rotational effect of the whole arch, which can lead to deepening of the overbite. It's just something you need to monitor, something to be aware of. So how do you get around that? That's why we use power arms so regularly. It's because the center of rotation's up here and you're parallel to the archway, your force vector is going to lead to bodily contraction of the labial segment. Just a sort of couple of things on the power arms, so different types you can get. So this is one that's directly attached to the upper arch wire, and that'll lead to bodily retraction of the upper labial segment. This is one that we just had made by our lab, so they've laser welded a power arm onto a bracket, and then we can use it directly to the canine just to retract that tooth to make space for that lateral incisor. So it's just different types of power arms. There's loads on the market, but they are very useful when using buccal tads. So why do we like buccal tads? No contraangle handpiece required, so it's a relatively straightforward kit. You can see what you're doing dead easily. You use simple direct mechanics, and it'll provide you with some good anchorage control. Why do we dislike buccal tads? You're limited by the interradicular space, so sometimes you have to do the pre-implant divergence. Sometimes you can have some adverse biomechanical effects if you're not aware of the center of rotations. Sometimes you've got anatomy that'll stop you putting it in the place that you want to put it in. So you might have a short sulcal depth, a limited amount of attached gingiva. There might be frenal attachments getting in the way. It's just something that you need to be aware of. They can be less predictable. They're certainly less predictable than palatal mini implants, especially in adolescents. So you get a higher failure rate compared to palatal tads. Okay, so palatal tads, what can we use those for? So we can use them for intrusion, we can use them for AP anchorage, use them anteriorly for anterior anchorage, and you can use them for molar protraction and mesialization. I'm really going to lightly talk about protraction and distalization, just because in the scope of how long we've got to stay, I can't cover it in too much detail. So why do we like the palate? There's less risk of root proximity. So we think about between the 5 and the 6. Buccally, we've got 2 buccal roots on the 6. Palatally, we've only got 1, so you've got more rooms, less chance of hitting the root. We don't have to worry about unattached mucosa. We know that the evidence shows us you get more predictable stability. There's probably more versatility in the way we can use them. And I don't think stetics is a huge one, but you can't see them if they're in the palates. You can see them if they're in buccally. I say there's less concern about movement divergence. You do still have the roots if you place them interproximally. It's just less of a concern. You need to think about the vessels, so we don't want to put it into the greater palatine artery. The mucosa is thicker, so we need to think about that. So we might want to use a mucosal punch before placing it, and we want to be using a longer necked mini implant. The bony density we've got to think about, and I'll come back to that in a moment. And access is more difficult. If you're trying to put one palatally with a normal straight screwdriver, it's really difficult. So you want to be, ideally, you'd want to have a contraangle handpiece, although that depends on you owning it. So we're thinking about the posterior palate. Then again, we go back to thinking, what am I going to be using? Well, we want to use the long one again. We want to using a long necked one and 1.5 diameter, because we're still worried a little bit about interradicular space. So we don't want to use one's too wide. So this is just an example of case you might get. So here, what have we got? We've got some crowding, we've got quite a narrow arch, crowded out lateral. We've also got AOV tendency, or not AOV tendency, we've got AOV, and crowding. So there's lots of different things we could use. So this is just to make you sort of aware of different things that are out there. So we could use something like this. So this is a old version of the palatal system that DB ran, and it had a press stud sort of system where you popped the temporary anchorage device, then you popped your TPO, and then it literally clicked on to the temporary anchorage device, and then when you wanted to take it off, you just popped it off again. It was really fiddly. To take the impression for it was really, really fiddly. So I won't go into too much detail, but they sort of abandoned that. but there are similar things out there on the market. I think Frestodem does something similar still. This is what sort of updates that a little bit, and we can see here that it's got something where you wrap it around the mini implants and then you squeeze the fine guards to engage to it. So it works in a similar way, but it's a bit less fiddling. This is what we did do. So we pasted 2 mini implants later. We've attached it using a long leg to the TPA, which obviously has a risk of fracture, risk of failure, so some risk, but you just keep an eye on that. And because of the AOB, we've also put some arms on here so that we can use it for intrusion as well as using it for AP. You can see we've lined things up and we're going to be losing these 4s to make room for the lateral. So 4s are gone. And we can see that we've retracted the canine, our AOB is improving, we're carrying out some intrusion mechanics as well as carrying out some AP mechanics. And at the end, we've got a reasonable bit of recession, unfortunately, down here, but we've got quite a nice result. We've corrected the AOB, and we've got a nice result. Canines are a little bit 2-ish, but it's not too bad. That was left in there because we sometimes leave them in just in case we need to get a little bit of tucking in of the platal cusps later on. I'll show it again in a moment. Just going to move. Should be right. So, as Mr. Norris, I think, spoke to you a little bit about this earlier, but you want to get things set up right. So, if you are going to decide to do some intrusion mechanics, you just need to know what you're doing. So, you'd want to have a low TPA to allow for the intrusion. Otherwise, you're going to be pushing the TPA into the mucosa. You want your arms to be as occlusal as possible to give you some leverage. You want to extend to the posterior teeth, 7s, 8s if they're indicated. You want to be in 1925 steel, and then you run some power chain from the plated tab up to the TPA, and that'll lead to your intrusion. You need to have something in the lower arch to stop them erupting, be it either a lower appliance or a lower vacuum form retainer. And that'll just stop the over eruption of the lower T. This is just a quick example. Another one. This is an adult patient who has had some previous orthodontics, missing lateral, and a premolar stretch on that side. Got an AOB, bothers them. They've got a nice incisal show. So we want to leave the incisors where they are, so we won't bond those straight up. We'll have a quad helix for a bit of expansion, and then we'll just intrude the upper buccal segments. Once we're happy that we've done that, and we're not going to extrude the incisors unnecessarily, we then put the rest of the appliance on. And then we can see from a KEF that we've got some nice intrusion of the buccal segment and closure of the AOB. And just looking at the tracings here, we can see if we go from red to green, we've got intrusion of the buccal segment and then auto rotation of the mandible, which has closed up the AOB. So yeah, so as you can see again here, we've got the platal tab allowed to some to intrude platal cusp. Had minimal facial change. One may argue that it's had a little bit of a reduction in the lower anterior face height, but it's not significant. And this is her 6 years after the implants came up, because she came back for some more retainers. So we were stable in her. What does the research say? Research would suggest that in general it is reasonably stable, and what relapse you do get generally happens within the first year. So if the stage hasn't opened up within a year, generally, it's not going to. So just quickly go through the anterior palate. So here, anterior palate, we're going to be popping it in this area here. So once we're using either the yellow or the orange, that'll be either we use 2mm diameter ones here because we're not worried about the roots of the teeth. We don't want to use a long one because we don't want to go putting it into the into the sinus or into the upper incisor roots. So this is sort of another this diagram. So ideally, you'd put probably into the green area. The yellow areas are okay. The red areas are where we want to avoid, and that's because we want to avoid vessels as well as avoiding the nerves. But we also don't want to put in areas where the cortex is too dense and too thick. Otherwise, will lead to secondary failure. So it's suggested that you put them at the third palatal rugo, just inside of the palatal midline. So just another quick clinical example. So this is Millie, and she had impacted canines that were reasonably unfavourable, and she wasn't that I wasn't keen on aligning them, and I said, well, we'll take them out, and it'll be difficult to close all the spaces, so we'll leave you with the baby teeth, and then you can have those built up. And she didn't like the idea, so I agreed that we try and protract the buccal segments. So here we've placed a couple of tabs in that area and third platal rugae. We've attached it to the front 4 teeth using something that lab bent up for me, and then we've just used that to protract, initially using some power chain and then ultimately using some magnetic closing coils to protract the upper buccal segment. And that's her at the end. She didn't want a lower appliance. I'm just looking at these. We can see we had a class 1 molar there, and we've protracted that to, if anything, just over, slightly over the class 2 molar. So it's worked nicely. I'm not going to talk too much about this because it's not really in the scope of what we've got to cover today, but it's just so you're aware of things like this. Is what I was talking into before with the platal clip system, where we clip it onto the anterior tabs, and then you can use it for multiple things. So you've got these 2 6 by 2 millimeter mini implants, and then you've got a nice thick frame, which you can either use as a TPA, as we have done in this case, which is having the 4s out. Then there's 4 out on the side and 6 out on the side as well. You can see the 7. And then you can use it for mesializing, where we've attached it to the 6 tubes, and so it's going to run mesialize along this wire. And similarly, you can use it in the opposite direction, whereby you are pushing the 6s back, so you're distalizing. Yeah, they're more complex ideas, and probably not something you want to go rushing into at MORPH, unless you're really confident you know what you're talking about. So just in summary, you need to think about what it is you're trying to achieve. Where are you going to place the tab? Where are you going to put it? Or how are you going to use it? The logistics of when you're going to place it and how you're going to place it. For example, don't be saying you're going to place an anterior palatal tab when you've got an in-standing lateral incisor that would mean that you're going to plough the tab into the lateral incisor. And that's happened a number of times. So just think about, is it going to work? Think about the logistics of it. Think about what order I'm going to do things in. And if it's going to involve the lab, think about, the same way that you would be able to talk me through how you're going to be, have a TPA made. I'm going to pop the steps in, I'm going to take impression with the bands and get the lab to make it. Just think about that with TADS. So it's just a matter of thinking about it before you walk into the Viva. And you don't have to use TADS in every case. In fact, in the vast majority of cases, they're probably not indicated. If you're going to use them, just think about it before you walk into the exam. You don't get caught out. Just acknowledge DB because they have provided some of the content today. Sarah and Charlie, who I'll continue in a second, who I do a course with. Richard Kelsley, who provided some of the material today, and obviously to the patients. And if you want to know more, I'm shamelessly plugging this course, which covers in far more detail and lots of hands-on experience. Of course, I do with that's Charlie and Sarah. They're there, and it's, of course, it was originally run by Richard Kelsley, but it gives you good hands-on experience and goes into much more detail about everything that I've spoken about in the last 45 minutes or so. So if any of you going on Friday, there you go. So you'll get more of it on Friday. It's not me doing this one, it's Charlie and Sarah. So you won't get more of me, fortunately for you, on Friday, but you'll get this in much more detail with Charlie and Sarah. Any questions? Yeah.
Huge question.
Yeah.
So you know how you said direct and indirect methods later tabs specifically. So say for example you have a manipulated tab and you created a TPA using bending parts wires into the tab and attaching it into the, let's say, the molars to retract the leading segment. Would that be direct or indirect?
What do you think?
So based on what you said, it would be direct.
No, because you're indirect, because you're linking the tab to the 6. So the TPA, and then no, because there's not going to be active on the tabs there. So the tabs locking in the 6, and then you're using the 6 to carry out whatever mechanics it is. So the only way it's direct is if the thing that's making the change, so be it space closure, for example, is directly into the temporary device. So, exactly. Yeah.
Okay, got it.
Next question.
The next question is, you know, one of the cases that you were showing within the Ruga area where you have 2 tabs. Why did you put 2 tabs and not 1? And would that affect your stability and also why not just 1?
Why do you think? How do we put tabs in?
Sorry.
How do you put a TAD, temporary English device in?
So I haven't placed it in that
No,
area.
no, no, no. But how, as a general rule, how do you place a temporary English device? What do you do?
Regulation wise.
No, just what are you doing?
So twisting it.
Screw.
Yeah.
Yeah. So you're screwing it in. So if you've got a force that's coming from one direction, you've got one TAD, then you're going to either unscrew it or tighten it inversely. If you've got two, there can't be any rotational movement. So there are cases, and there are orthodontists out there who use a single palatal TAD, but it's theoretically you can get a rotational force on that TAD which may loosen it or tighten it. Either way, you don't want it because you want it where you've left it. So when I'm doing anything palatal, I always place two because then you're not worried about any rotations.
Thank you.
No problems. Anything else?
Two questions from online as well.
Oh yeah.
You're going to put a TAD back in after healing. How long?
8 weeks.
Wait, 8 weeks.
Just to give plenty of time for it to definitely to have healed up.
How much space would you need between the 5-6 roots for a TAD to be placed?
That's a really good question. So if we're thinking about, we've got a 1.5 millimeter temporary anchorage device. You want as much space as you've got, especially when you're starting off. You would certainly need to have at least sort of two. You want to have at least sort of 2.5 mils really, so you've got 0.5 mil either side leeway. But the answer is as much as you can get, because then you're making your predictability much higher.
And how do you deal with a fractured TAD?
Depends on whether you can get to it or not. So if it's fractured quite high up and it's relatively easy for you to get hold of it, then you could just use a vine guards or something like that just to unscrew it. If it's beneath the gingival level, you'd have to raise a flap to get to it. You leave it there. They're inert. They don't tend to cause any problems. So I have fractured two, and they have both been left in situ, and neither of them caused any problems that I'm aware of, and it was a number of years ago. So generally, if you can get to it, you take it out if you can, but it's going to involve raising a flap and all that sort of stuff. You just leave it there because it's probably not going to cause problems. If it was going to get in the way of your mechanics at some point, you might have to take it out. But on the condition that it wasn't going to cause any problems with that, just leave it.
Brilliant, thank you.
Okay, so thank you for the TGD committee for the kind invitation to come and speak to you guys today. I'm going to give you an overview of the intercollegiate or bicollegiate MORPH examination. I know you've obviously been given an overview of the Edinburgh College this morning, and there's been some changes. But the purpose of this presentation really, and for myself here today, is to really give you an overview, and I'm happy to take questions probably at the end of the presentation, I guess, and I'll be here all afternoon, and I can answer any further questions that you might have. So I'm going to give you an overview of the intercollegiate examination, the formats that we run, and also inform you of the 2023 assessment dates as well. So the bicollegiate or intercollegiate examination is called that because it represents two colleges. So that's the Royal College of Surgeons of England and the Royal College of Physicians of Surgeons of Glasgow. So we are in combination together and we offer the intercollegiate examination. Now, there's two parts to this examination. So part one is a written paper which consists of short answer questions and MCQs. Usually there is 10 SAQs and 50 MCQs. And usually candidates who take that exam are newly qualified from their dental degree, or possibly within 1 or 2 years of qualification or post-qualifications. And so this is the first part of the examination that you have to take to be eligible to sit part two. However, before you panic, I've clearly stated there that candidates who successfully completed the MFDS or MJDF or MFD have an exemption. So you don't have to do the part one MORPH if you've got those qualifications. Now, part two, now this is clearly, I guess, applies to everyone in the room who are planning to take this exam at some point today or in the future. Now, before COVID, the format of our examination consisted of written paper, which is short answer questions and MCQs again, an OSCE circuit, the presentation of 3 submitted cases. So you have a submission and then you have a viva on these cases. And then structured clinical reasoning cases, which are typically 4 cases. Now, clearly, as we all have been affected for the last few years, COVID had an impact on training and, in particular, assessments being delivered on a face-to-face environment, purely driven by national restrictions, lockdown measures, etc., etc. So the higher education stakeholders within the UK charged the colleges to provide an assessment online. So trainees who were coming up to do their exams won't be hindered in any way, so you can progress with your training. So we reverted to an online assessment, and you'll see the format slightly changed. So there's an SAQ paper, or just a written paper consisting of SAQs. We have communication scenarios, presented cases, and the structured clinical reasoning cases. So what you notice is the OSCE has been removed. OSCEs can be delivered online, but we felt it would be challenging, and we actually reformatted it into the other components of the assessment. So written paper and communication scenarios cover aspects of the OSCE. So what does that mean now? I mean, we're safely sort of post-COVID. We no longer have any national restrictions or any limitations. So the English College, or the bi-collegiate examination, we've got the capacity to deliver the assessment either face-to-face or remotely. But there is now a strong drive to return to face-to-face, and I'm supporting that as well. So we aim to deliver our assessments on a face-to-face basis. Now, for you guys, reassuringly, the format will be the same either when we deliver it face-to-face or remotely. So the confirmed format, whether it be remotely or face-to-face, is a written paper consisting of short answer questions, communication stations, presented cases, and the structured clinical reasoning of unseen cases. So there's no OSCE component anymore. So the written paper of part 2, what it aims to do is essentially is a knowledge assessment of orthodontic theory, understanding, processes of reasoning of power, and intellectual ability. Now, there are 12 questions, and you get 2 hours to complete that paper. Each question is worth 20 marks, and usually we deliver that online because we find that actually works well. So you will, probably about a week before, if you're doing this part of the assessment, we'll do this online. Now, with online assessment, with the English College or bi-collegiate examination, we have the ability to monitor your activity as well. So there's some proctoring software, which sort of assesses and makes sure that you're not referring to any textbooks, any literature, etc., because that will give you an unfair advantage when it comes to the assessment. So when it's delivered online, we have those quality assurances process in place to ensure fair play has been undertaken. Important information. So if you've successfully passed the Royal College of Surgeons of Edinburgh Part 2 MOF written paper, which is called the Part A paper, you'll be then exempt from doing the written paper if you come and sit the examination at New England College or the bi-collegiate assessment. This is not the same as Part 1. This is commonly what the confusion leads to. So this is specifically the Part A assessment of the Edinburgh College, which I think is next week or soon. So if you do pass that, then you'll be exempt from the written component of Part 2 MOF for the intercollegiate examination. The treated cases. So we'll touch on this a little bit as well with the wider picture, but for the bi-collegiate examination, we're still accepting case presentations as a section of our assessment. So you need to submit 3 cases, and the majority of the treatment should be undertaken by yourself. Now, out of those 3, because you'll submit those about 3 weeks ahead of the diet, the you can submit that online as a PDF and send it to the examinations team. And as part of that, we're not asking you to submit physical models anymore. So you can include photographs of start and finish or mid-treatment, etc., scans of digital models, etc., all in PDF document. There's no physical submission of the cases. So what the examiners will do, will assess those 3 cases, and you'll get a mark for the submission of your cases based on the 3 cases. But then 2 of those cases will be selected for your Viva, which is a face-to-face Viva with 2 examiners. So the case presentation is a Viva of 30 minutes. So that's, think of it, two sections of 15 minutes. And then you get 2 marks allocated, and that'll be for your submission and then also your defense, the Viva. Now, a little bit of background. So during COVID, because of the impact on services and on training, it was apparent that candidates were not completing their cases. So we had a provision put in that we would accept incomplete or near-end completed cases. Now, for those of you who are sitting at the MAuth this year, you would have started your training 2020, but I'm aware that some of you guys had a 3 months delay. So, and essentially that probably manifested as a 6 months delay before you actually went up and running with your clinical training. So for this year only, we're carrying on with the incomplete case submission. But for 2024, we're going back to debonded and finished cases, okay? So this is the difficult question. What does it mean by a near end or incomplete case? Now, ideally, you should have full records for the case. So that's your pre-treatment records, study models, photos, whatever, X-rays. And it's always difficult for yourself to gauge how this case is progressing. So you need to ask your supervisors. And as a rough guide, it should be roughly 2 to 3 visits from debonding. Should be in stainless steel archwise. Not much space to close. But the important thing that you need to consider is that the case is progressing in accordance with the planned treatment aims and objectives. And we all experience with our cases that we have loss of anchorage occurring, etc., etc. My advice would be to try and avoid those type of cases. You need the ones which we know which are progressing with what was planned from the outset. And again, you don't need to submit incomplete cases. If you've debonded the cases, that's great. You can submit those. And out of the 3 cases, there's not a cap on how many incomplete cases you need to submit. You can submit 3, 2, and one completed, or whatever combination. There's no limitation on that. But if you've got a presented case, whether it be debonded, so say for instance debonded, you usually in your Viva will be asked your sort of assessment of understanding of etiology, diagnosis, case complexity, anchorage management, treatment mechanics you've employed, retention procedures. If the case is incomplete, then you may be asked about, looking at your records, what are the potential finishing procedures to sort of finish the case? Sort of approaches to analysis of the outcomes, capnometric superpositions, having your understanding, where do you think the lower incisors are going to move, upper incisors, what potential retention regime have you planned from the outset, and alternative treatment options. And another word of advice, when it comes to selecting your presented cases, especially if they're incomplete, try and steer away from very complex cases where you've probably not done that much, or then there are a bit more than 2 to 3 visits from finishing. Because, okay, fair enough, you might score okay on complexity, but we're trying to tease out your understanding of the overall management of this case. And if you don't have that understanding, then you won't perform well. Now, trainees that I'm involved with have started to show me their cases, and even a routine 4-unit extraction case in a 2-1 case can be a potential MORPH case, as long as it's heading towards the planned treatment aims and objectives. Now, for your case presentations, I'm sure you'll be all busy doing your superpositions shortly, but you can do this either hand tracing or you can use software such as Dolphin. We don't have any limitations on that. As I've highlighted, we're not expecting you to submit physical study models. And like I said, include photos of models or digital scans. The case template is available from the Royal College of Surgeons website. You must obtain consent from your patients, and there's a specific consent form, again available on the RCS website. Now, it's unfortunate that you guys are now sitting there part 2 exam and being caught in a bit of a quandary about the change in formats of the assessment. And I'm sure you've probably heard earlier this morning the virtues of the Royal College of Surgeons Edinburgh's decision. And that's fair enough. You know, I'm not here to sway you one way or the other. Ultimately, it's your decision about what assessment you want to take. Clearly, I would favour the England College, but it's your decision. Now, my experience of trainees who sit at England College and present cases is the case presentation is actually a section of the assessment which is in your favour because you got full control of that case. You should have the overriding knowledge of every aspect of that case. And actually, candidates do very well in that section. So, and again, from my own opinion, in an assessment process, you know, orthodontic treatment is summative over 3 years, 2.5 to 3 years. And submitting cases gives us an idea of your overall management of this case during that time. And you can argue the virtues and benefits of, you know, mechanics during cases or particular times, and I understand that as well. That's possible. But I think this, you know, submitting your own cases gives you an overall, or examiners, an overall insight into your management of the cases. So I would always support, you know, case presentations in an assessment for MORPH. It may change in the future, but at the moment it's not changing. And if we were going to make a change, we'd give you at least 12 months notice about what we're doing, okay? So it's not going to be sprung on you, but at the moment, we're keeping the case presentations going forward. Communication stations are designed there to explore the candidate's ability to communicate information, so in a simulated sort of patient or parent scenario, their knowledge and the application of their knowledge. So you'll be given or charged with sort of answering 2 stations. Usually you'll have some information given to you, 10 minutes for preparation and 10 minutes for the assessment. Now online, examiners used to play the role of the actors. Some of them played those roles really well and could have a change of career sometimes. But having actors is quite expensive. They charge a lot of money. And so even in the face-to-face, we're probably going to have examiners acting as the role in that scenario. But again, don't let that faze you, okay? Now, there's a certain amount of marks sort of allocated to each communication scenario, and then that's then converted to the marking criteria scale, which we'll talk about in a moment. Now, the question is, I guess, what could you be asked in a communication scenario? Now, my advice is they reflect everyday clinical practice. You know, we're not going to give you something, you know, in any assessment for MORPH, we cannot ask you anything which is not in the curriculum. So if you want to make sure you've covered everything, then you need to cover the curriculum. But what are examiners looking for? They're looking at for your non-verbal and verbal communication skills, use of lay language, clarity of language. And think of it as what you do on a daily basis on your clinics, whether it be on new patient clinics, your own treatment clinics, whatever. It's, that those type of scenarios. Now, it could be, managing a patient complaint, managing a complication during treatment, issues with discontinuation of treatment due to poor hygiene, poor compliance, or management of a multidisciplinary type case. Again, all these are the areas which you should all be acquainted with within your training. So the unseen cases or diagnostic cases and structured clinical reasoning section. This is the section that I guess which worries candidates the most in terms of, this is where you're actually really teasing down your sort of ability and what separates you from, say, for instance, a therapist or a GDP with specialist interest is the ability to treatment plan a case and then ultimately make a decision of being an extract or not. And that's the role of the specialist, I would say. So what you'll be given a template or a folder which contains clinical photographs. Again, we're not going to give you physical study models. There may be representations of study models like photographs or digital scans within the template. There'll be radiographs and provided with cephalometric tracings and a very basic sort of Eastman analysis, giving you sort of key sort of information. And because you don't have the models and you can't physically, say, for instance, measure the overjet, you'll be provided that information. So if the overjet is increased at 7 millimeters, that will be contained within the template, okay? If there's a debate with center lines, again, we'll say center lines to the right-hand side or to the left. If there's a crossbite with displacement, you'll be given that information. So the purpose of this section is to have specific learning outcomes, such as an assessment of etiology, diagnosis, treatment planning. Now, prior to the diet, the 4 cases that we're going to use are reviewed by examiners. So we have a peer review session. And what we do is we look at each case and we look at what we're going to ask about the case. And then ultimately is what do we think are the suitable treatment plans for that case. Now, a good M-Orth case, there'll be more than one treatment option. That's the nature of orthodontics. Sometimes it's bond or functional, non-extraction, whatever. But for an M-Orth, they're going to be a little bit more testing to, again, assess your ability to diagnose the case and plan appropriately and essentially make a decision. So, and like I said, there can be more than one treatment option. And it doesn't mean that one is better than the other. As part of the peer review process, we've listed the ones which we feel are all reasonable. And sometimes, even in the assessment, you may come across another plan, which we didn't even come across, and think, well, that's reasonable. So you'll be assessed fairly on that. So you're not going to be disadvantaged if you discuss with your colleagues afterwards, well, I didn't say exactly that. That's not the purpose. The purpose is about testing your overall ability. So usually, rather than doing the 4 cases in one session, which we think is a bit unfair, and I think that doesn't help candidates to perform well, we split up into 2 sessions. And so you'll have 2 sessions with 2 cases. You'll have the records for 15 minutes, and then you go straight into the Viva. Now, in your preparation case, and this applies to your presented cases, if you've made notes, you can take those notes into the Viva, okay? You don't have to leave them behind. Take them in. What you will be asked is the notes will be removed removed from you after the assessment, okay? And the marking criteria that we employ for the bicollegiate examination is a 1 to 4 criteria. And if, a good candidate would be scoring 3s and 4s. And currently there is compensation within the sections. Now, if you score very badly in one section, you have to really, really do well in the other sections to compensate for it, okay? So, we're looking at, and what you see in the trend of the marks is when I look at them, is a candidate who's not done their best on that diet would usually come down on more than one section. Because it's almost like a consistent trend. A good candidate would probably pass all the sections. Now, to reassure you, if you submit incomplete cases, you can still score the full range of marks. And that will be applied to your submission and also for the Viva. If we did have to do a remote assessment, and I'm not saying that's going to happen this year, but I'll talk about that a little bit later, we use Microsoft Teams. And you'll be given lots of support and guidance by the exams team in terms of navigating it, etc. The Surpass software is used for the written paper. Again, you'll be given lots of training beforehand. If there's an issue with your connectivity, any lost time will be added on to the Viva at the end, okay? Just to make sure, again, you're not disadvantaged. Just sort of covered that there for you. Now, for the remote assessments, so prior to COVID, we used to have the exam results ready by the end of the third day, and then we would be able to give you your results straight away. Because of COVID and the restrictions, that's changed because we're relying on remote assessment. So they involved more checking process to make sure everything was above board, quality assurance was in place, etc., etc. So there is a little bit more of a delay when it comes to releasing your results. And the same applies for face-to-face. And again, it's not because we're trying to delay things. We're trying to make sure everything is checked, no candidate's been disadvantaged in any way. If there's any issues raised, we want to double check that before we release the results. So the slight delay is there for a specific reason, okay? But we always try to get the results out as soon as possible. And sometimes it's been within 2 weeks of the diet as well. But we usually give you a warning that it could be up to 4 weeks. So some tips and advice. So probably the first statement is probably difficult when you're sitting the exam. It is honestly to try and remain calm. Now, examiners will know that you're nervous. They know that the assessment it's a high stakes assessment. It means a lot to the candidates. And the England College examiners and those who examine for the Glasgow College, I've got to say, we have got a very nice examiner panel. They will do their best to. We don't really want to fail you. Our aim is to make sure you're safe, you're competent, and you're going to be competent as a specialist working on the public. So, but ultimately, for whatever reason, sometimes it may not be your day. For whatever reason, something happens, and if there's a question about your standard, then unfortunately, candidates do fail. But try and remain. Try and be systematic in your approach. What we're looking for that is like a logical thought process regarding, your diagnosis, treatment planning, etc. I know it's difficult, but speak clearly and confidently. Now, orthodontics is a very small world, and when it comes to allocating the examiner pairs, we try and make sure that you have not had any previous contact with the examiner. However, it sometimes happens. And for whatever reason, sometimes I have to step in because there's illness or whatever, and it may be a candidate that I know. But in that scenario, what will happen is the other examiner will take the lead in the assessment. And say, for instance, I will probably step back, I'll declare, I know this candidate, such and such. My colleague will then take the majority of the questioning. I may ask a few, but my colleague will take the lead, okay? Again, we're trying to make sure that there's no bias, no favoritism, things like that. We're trying to maintain parity for all the candidates. Try and provide specific responses to questions. The examiners are well versed in delaying tactics, I would say. So, say if I say the IOTM, what's the IOTM in this case? And then you start to say, well, the IOTM was developed by such and such and such. We already know, and what you're actually doing is you are limiting your potential to score highly. Because actually, the more questions you get asked, the better the performance could be. So try and keep it specific, clear, try and support your answers with evidence base. Sometimes there's not enough time to cite particular evidence. If you can, that's great. But try and keep it specific and clear. Like I said, you can take your notes into both the treated cases and the SCR sections. Again, just to highlight, there's more than one treatment option for SCRs. Now, it's quite an emotional 3 days for the exam, and for the SCRs, this happens commonly as well. And it's human nature just to dwell on something that you think, well, it hasn't gone quite well, etc. But my advice is you need to forget that. Forget what you've done in that, despite what you think how you've done, and focus on to the next case, okay? And even if you don't know the answer to the question, just say you don't know. And the examiners will then maybe rephrase the question or may ask you another question. You're not penalised just because you don't know the answer to the question. Now, the future examination dates, the Part 1 ML, which if it applies to you, I think it's the first week of February, but it's on the exam site website. Now, we're holding our first face-to-face diet will be in end of March, and that'll be an international diet. The May diet is scheduled for the 8th to the 11th of May. And before you say it, the 8th I know is a bank holiday because of the King's coronation. But the exam is usually held on 3 days, so it'll be held on the 9th, the 10th, and the 11th. And then we also have a planned assessment for later in the year in September. And the reason I'm emphasizing that is because if you are unsure about your cases and you think you need a bit more time to finish them, then you've got another date that you can aim for. Again, the website should be up to date, fingers crossed, and all the information should be there. But if you do have any questions or any queries, you're more than happy to email me or contact me by any other method, and I'll try and help you if I can. Is that okay? Thank you for your attention.
Thank you, Jad. We do have a couple of online questions which are quite pertinent. The first one, I'm not sure if you would know, but someone is sitting the Part A Edinburgh exam. Would they find out the results of that before being able to apply for the EML England exam?
Good question. I don't know when you'll get the Part A results. But if you want to sit the England College or Bicollegiate exam, still apply. Okay, yeah. And the exam team will ask you if you've passed on the application form. It says, have you passed Part A? And then you just say, result to be determined. And then you contact the exams team to tell them what the results are going to be.
Brilliant.
Like this.
And then also with START's records, you're saying having all the records beforehand. What if you don't have START models? Could you just submit START photos? Or also, if you had a skeletal 1 case, for example, and didn't have a lateral KEF, could you still use that case? I know what your answer is, but I'm putting it out, obviously.
It's tricky. And I can sympathise with candidates if you've got that case, because the guidelines from BOS suggest they don't need a KEF for a Class 1 case. But then on the other side of that debate is, well, for instance, if you're treating a case of non-extraction and you've got crowding, then I'm sure you've all been taught about stability, lower incisor position, into canine width, etc., etc. Then how do you know where you move the teeth? So I think personally you should try and aim for cases which have got the full set of records, and that includes a start cap.
Thank you. And then one more question: will unseen case CAFs only use the Eastman analysis over other analyses, or can you use your own analyses in your write-ups?
You can use your own analyses in your presented cases if it's appropriate. For instance, say if there's an ethnic issue with your, not ethnic issue, that's the wrong word, you're tracing your norms for a specific ethnicity, then you can, but you also put what reference you use that for, okay? In the SCR cases, we would just provide you with a basic set of, say, SNA, SNB, AMB, upper incisor, lower incisor, inter-incisor angle. You know, we're not really there to tease out the finer details of the CAF assessment. The information is provided there is for a specific reason, for you to plan the case, and we can ask you questions.
And will there be a England process practice course similar to the Edinburgh one?
Unfortunately, we don't currently do that. Now, again, I know the Edinburgh College choose to do that, and I think you can submit potential cases and get advice on that, which is fine. But without saying too much, there's a school of thought that says actually you shouldn't be doing that so close to a diet. Okay, and at the moment, for the bicollegiate exam, we don't do that as well. And there's also a rule for examiners that they shouldn't really be providing you strictly, you know, educational support, doing cases at least 3 months before the diet, because you're an examiner. Yeah, but the best of them, well, we all try to remain unbiased. But no, we don't do the preparation course. If we did do that, it'll probably be a little bit further away from the diet date, I think. But we've got no plans to do that this year.
All right, guys, can we make a start with the next presentation, which is me, if you haven't seen enough of me already. So I'll be talking about tackling superimpositions and giving you some other ML tips as well. I think Richard has covered a lot in his presentation, so I'm going to concentrate more on treated cases and the super imps. So at the end of this talk, hopefully I'm going to teach you 2 different ways of tracing a CAF and some other tips as well. So rough timeline. For treated cases, I started shortlisting my cases in January. So I was kind of looking at all my cases, my overall logbook, 100, 120 cases, and seeing what would be good to kind of pick up. So for example, I'd look at a twin block case and think, oh, that one's progressing nicely. Then I look at my next twin block and think, right, is that better or is that not? If it's better, right, I'll go for this one and compare it to the next one. So I was looking at different types of malocclusions and picking things up. And also hunting down Mr. Sira on clinic saying which one is better. And he did give me some good advice, actually. So February, make sure you get your application in. I think the deadline is the 23rd of February this year. I only sat England. I didn't do Part A Edinburgh because I didn't want to spend my Christmas revising. I was going to revise all in one go in May. So you don't have to sit Part A. Don't be forced that if other people are sitting it, you don't have to. I was a minority in my year. By March, finalise your cases. And as Mr. Sira said, there is a consent form that needs to be signed on the website. So make sure you get that signed. I submitted my cases, as Mr. Sira said, as a PDF. And my exams are all virtual. So I did them all at home. So that may be different for you guys. And the results, as Mr. Sira said, came out in June. So choosing your cases. I don't know if this is showing my age, but hopefully you'll recognise that film is Clueless and she's choosing her outfit. So yeah, your case is a bit like choosing your outfit. So it is check all of your records at the start. I personally wouldn't take a case if I didn't have start photos, start records and things. If you're missing your models, I wouldn't recommend it, but that's just my personal opinion. I also wouldn't recommend taking something that doesn't have a start lateral care, because otherwise, how can you do your superimpositions if you don't have your start? So you wouldn't be able to score any points in that section of the exam. So making sure you have start and a near end CAF. Having a variety, so don't choose all class 2 cases, all class 1 cases.
It's not that you have to choose a class 1, 2, 3 case. You don't have to take a functional, but it's all about having a variety. The more stuff you have, the more stuff you can talk about, the more points you can score. That's basically it. So maybe have some interesting mechanics, but nothing too crazy where you're like, I'm not quite sure this is the right thing. So have something kind of sound. I narrowed it down to about 10 cases in about January, February time. And that's when I started going around to select supervisors who I work well with and asking them for their opinion. At the end of the day, everyone's going to give you a different opinion. So it's all about what you think, what you're happy with to take to an exam. So this is a summary of my final cases. For the people here, I was handing round my ML cases for you guys to have a look at. So I had a class, I happen to have class 1, class 2, class 3. My class 1 was quite interesting because there was a compound odontome impacting a lower 3. My second case was a 2-div-1 twin block non-extraction case, and class 3 was just severe crowding for unit extraction. So I had a good summary. Number 3 is grayed out because I defended number 1 and number 2. As you can see, there's just more stuff to talk about. I could talk about canines, I could talk about odontomes, the crowding, and then the class 2. I finished 1 and 3. I didn't finish 2. So I was in stainless steels and space closure for number 2. So as Jad said, the template is online. So you can see it's kind of down there. I should use the pointer actually, sorry. But that's what it looks like when you download it. I personally just did not like the format at all. It was just really difficult to type. I didn't like the writing. So I literally just typed it all out again in my own format, in my own writing. Some people put a nice border around it. Some people put like the headings in the middle and things. So do what you want. Just make sure you have the same content. So you don't have to have the box and things. So yeah, personalize your write-up. And also be consistent. So some people like to put class 1 with a capital C or skeletal 1 with a capital S. If you're going to do that, be consistent throughout your write-up. I know it sounds really picky, but orthodontists, we are picky. So if someone's reading through it, they're not going to mark you down if you've written class 1 with a capital and class 1 without a capital, but it just looks nicer. Or just making sure you have the same size font and the same size, the same type of writing and things. It's quite easy to hit Control A and select everything as Calibri or Times New Roman. So preparation, making sure you understand your case. So this is just some of the lateral kefts that I drew. I hand drew mine for my exams. So I want to try and stop you guys from having to trace it thousands of times as I did. So just the more you understand your case, the easier it will be. I think when I started, I was just willingly kind of drawing lines and not understanding my cases truly. So by the end of it, I was like, right, I know that this is an extraction case. I'm going to be retracting my incisors, or my molars are going to be coming forwards. Or it's a twin block case, knowing what movements you get with a twin block. If you know what's happening, then you can anticipate it when you come to your drawings, basically. So my structures, you can choose what structures you want to superimpose on. These are the 3 that I use, but you don't have to use those. It's just, that's what I prefer to use. And so I could go through it in pictures, but I thought it's just a lot easier if I just show you. So over the weekend, I actually did a little video for you guys. So I'm going to stop sharing and see if I can share this. I did 2 videos actually, but let's start off with this one. You'll hear my lovely voice, hopefully. All right, let's see if this works. In this video, I'm going to explain how I've drawn my lateral kefts. So how I've done the overall, the superimposition, the overall face, and also for the maxilla and the mandible. So this is what you'll need to draw them manually. I bought a light pad off Amazon. It was about £10–15. It's completely flat. It's at different settings. I also got some tracing paper, which was £1 from a shop. You need your printed lateral test, which I'll explain how to print this later. Mechanical pencil is better than a normal pencil. People recommend using Edding pens. I use Muji pen for the thinnest ones, 0.38mm, black, green, and red. A rubber. To secure it, you can either use tape. I run out of tape here from Christmas tape. And I've got some bulldog clips you can use either. We've also got a ruler and a protractor. You can get specialised orthodontic protractors. I just happened to get this massive one off a course that I went on to, but a small one does the same job as well. So when you get the JPEG of your Lactotech, before you print it out, I would actually recommend going around and outlining all the structures of this dot. So you can use paint. I've got Photoshop, and all you essentially do is that you click on the pencil button and then you just add dots going around. You'll find that when you print it out and you put it on an iPad, these dots are a lot easier to see than the actual structures themselves. So just to explain some of the structures that I've outlined, it all depends on where you want to do your superincisions on. In this patient, I have outlined cellar, cranial base, and I've also done lobe structures as well. I've done hard tissue, nasion, orbitale, maxilla, and mandible and symphysis. Outlines the incisors. Here I should have outlined the molars as well, first molars. I've outlined the third molar, the IV canal, and the condyle, and I've also done the soft tissue structure as well. Once I'm happy with that outline, I then input this into Word. And so this is the part where you need to make sure that your printout, the physical printout, actually matches up with a ruler. So if I was to get my ruler here and take this ruler, it should actually match up. So it should be the same dimensions. In order to make sure you're doing that, I checked on here. So I zoomed in to this ruler here. I also made sure that I've actually got my ruler highlighted as well. So you can see the ruler on the sides. And then I did zoom in. I basically looked at point 1 and 2, which is a centimetre. I measured this, so this is about 20, about 3.2 centimetres. I then made sure that the centimetre on here was about 3.2 millimetres, and I know that when I print this out, it will print on the correct scale. If not, you need to make sure you go up to the picture, make sure that's clicked so that when you change the height, it will change the width as well. And we essentially just do little changes, like 1.5, until you get the correct width. And then you print it out, and it should come out like that. And just to say as well, it can take you several attempts for you to actually get it right. So by observe printer paper. So now we take your printed Lactotech, take a sheet of tracing paper, put them together, and then stick them on top of your iPad. Make sure that the two sheets are lined up. That helps. And then you can either secure it in with a bulldog clip. If the iPad is so nice and thin, you can actually just hold it in place. Or you can use a clip as well. It doesn't matter. But I try to secure it in at least 2 places. When you switch it on now, you can see that now if you've done the dots, it's a lot easier to see your outlines. If you don't have the outline, it can sometimes be quite difficult to pick up what you're trying to draw. And then now you draw them with a pencil. So I've now drawn these out in pencil, and it's at this stage you really critique the shape of your incisors and molars. Are you happy with them? If you're happy, great. If not, go back, rub them out, and do them again, because you will hopefully duplicate these shapes throughout your tracing. So your end tracing and things should have the same shaped molars. You shouldn't have a change in your molars during your superimposition. You should also, at this point, critique your molar and incisor relationship. I know that this patient is a class 3, so I'm happy with the class 3 incisor relationship. However, my molars, they should be class 1, and he looks slightly quarter 2. So I know that's wrong. I need to sort that out now, because otherwise any mistakes now will just be replicated further down the line. So I'm going to change that now. So if you are happy with the teeth, you then take another sheet of tracing paper and trace those out. Get into the gap between them. So these are the teeth that you're going to be using. So keep that to one side.
So now that you have your outline, you now take another sheet of tracing paper. On top of that, we're now going to draw out your angles, so doing S and A, S and B, and all the facial heights and things. So now that I've drawn up all my lines, so this is having the value on the side here. So I have done S and A, S and B, worked out A and B is 1, which I know B is marks 2 to 3, and did the even analysis on it as well. I've done my width where I've got my accusal plane, found the tangents to A point, tangent of B point, B is plus, B is mark 3, is the distance. Now that I know that this distance, my ruler is correct in real life, with my actual ruler, will measure from A, the next up 4 millimeters, minus 4 width. With my FN, ANS, TMS angle, it's quite difficult to try to measure this line with SN. So what I've done is that I've basically taken this line and moved it upwards. So I got my protractor and I took 90 degrees, so that with 90 degrees going up, and I measured some arbitrary value. So here I took 4, and then on this side I did exactly the same 4, so I've got the same distance, drew a line, and then that is my SN maxillary plane angle. That worked out to be 6, so that's within norms. And then I did MMPA, which is there. What else I did? Lower facial height, so I took my maxillary plane, measured 90 degrees, measured the distance here, measured the distance there to get, and then the percentage for lower facial height. Up incisors, I've done lower incisors, so up incisors maxillary plane, lower incisors mandibular plane. I've done my incisor angle, and then here I've also done the nasolabial angle, and I've done rickets EY. You can also do lower incisor to apical as well. At this point, I look at all these values and make sure, do these make sense to me? So is he kind of like a mild skeletal 3, skeletal 1? Yes, that's what I know. Width, I think he's also slightly class 3 because the incisor of class 3. Things like his low facial height, that's kind of almost within, slightly increased but within normal values. His upper incisors, did they look at normal clinically? Low incisors were listed at protons. You always have to look at these values and make sure they match up with the clinical picture before you proceed. So if you're now happy with your initial drawing, you're happy with the measurements, and you're all good, you can now copy this out into black. So you've got your, you can get rid of your F9, you don't need that anymore. You just now need the tracing paper and then a blank sheet of paper on top. And now you're going to outline all of this in black. This is where it's really tricky to make sure that when you do the lines, you try and have a continuous line. So you're not kind of doing the lines, stopping, and then continuing on. You can get little dots. So it's all about making sure that you do, I try to do light strokes. And then when you try to continue on, that's not a very good one, but can you see it's always try and have continuous lines if possible. If you're going to stop somewhere on a point as opposed to on like or on a straight line as opposed to going on the curve. The good thing about a light pad is that you can, as you're going around, you can move the light pad in the direction of your hand. So it's just a lot easier. And you trying to turn your body, you can actually just turn the light pad around as you're doing it. So good luck with that. So now you've got your completed outline. You now need to duplicate this by either redrawing it or finding a photocopier and printing out an extra copy. So now I've got 2 copies. Probably best to have more than 1 copy, but that's the minimum that you need. And then also having the maxilla and mandible also drawn out individually as well. And then you essentially do all of this and replicate it with your other lateral caps. So now we're going to do exactly the same, but now with your near-end cap. So I've got my near-end cap with the braces on, sheet of tracing paper on top, and I've got my dots, and you just outline everything again. The only difference I have here is that I've already got my molars and incisors from the last lateral curve. So when it comes to tracing them, I put this underneath, line them up, and then I know that I can then trace the outline and have the same size tooth as I would from my previous lateral curve. So you know that your tooth shape aren't going to move. You can also do this with things like your condyle or with your third molar as well. Yes, the patient will be growing, but you shouldn't have like massive changes in the shape of your condyle unless you know that there's some sort of pathology going on. So now I have completed my lateral cleft tracing for my final superposition. I forgot to say, try and label everything with numbers, otherwise you can get confused as to which tracing is which. So I tried to label all my initials as 1 and then as 2. I then have my tracing here. I took my printed final initial cleft drawing and I lay it on top. And I'm going to superimpose into Costa's line because I feel like I like using De Costa's line. I think it's more accurate than SM and it's just a bit easier to draw than build structure. So when I overlay this on top and then check the patient's growth, everything should grow in a downwards and forwards direction. So kind of things like nasion should go in that direction, the nose, everything should go there. If you find that then the nose is actually tipped backwards, or like the face is shrunk upwards, then you know that there's something wrong, you need to go back and retrace. So now I'm going to take my red pen and outline everything. This is what the final outline should look like. So you have black, which is initial, and red, which is final, and that is your final overall superposition. Just a word note here, I said at the start to use thin 0.38mm pens. I've actually used 0.5 because I didn't have 0.38s on me, and my black ink was running out, and I can't find my red pen, so it's a brown red that I'm using. So that's when you can see the discrepancy between the colours, why the browny red one looks thicker. So hopefully you shouldn't have that discrepancy. So now we need to come on to your individual maxilla and mandibular superposition. So I've got my sheet of my individual maxilla and mandible, and I've got my tracing, my final tracing on the light board. So I now take my maxilla and I'm going to superimpose it onto. So I am superimposing on the maxillary, on the platal aspect. So that looks roughly right. Before I trace anything now, I have a look at how my teeth have moved. So I know in my patient, he was a class of extraction or force. He had severe crowding in the upper, so I've utilised a lot of my premolar space in order to be able to correct his, to align everything. So my molars I would expect to come forward a little bit. So that's acceptable in my opinion. If, for example, he was like that, and my molar had moved in a complete premolars width, then I know that that can't be right because I've utilised the space for crowding, not for molar mesialization. So if I move that back to roughly where we are, and then I know that my incisors, I've pretty much maintained them. I haven't bowtined them or rectified them. I've maintained them, so I shouldn't get as much movement in my maxilla. Same with my mandible, I'll just show you now. I like to superimpose on the symphysis and on the ID canal. So I've kind of roughly got that lined up. And then have a look and see at my molar movement. So I did extractions in the lower mainly to correct my incisor inclination. There wasn't crowding, but not so much in the top. So I have got some molar mesialization. I've also really retroclined and pulled my incisors back. Also got some extrusion as well. So this looks like it's quite a big difference. So if I think that's a bit too much, it doesn't seem right, it doesn't fit with my clinical presentation, I'd have to go back and redraw the this tracing paper if this doesn't seem right. But no, I'm generally happy with that, so I'm going to outline those in red now. And this is what you should end up with. So you should have your overall superimposition. your maxilla and your mandible, as well as copies of your initial lateral calf and your final lateral calf, which I may have forgot to mention earlier that you can just trace that out as well. So that is it. I hope you found that useful. This is just one way of drawing lateral calf. You can do it digitally as well. But I hope you found this video useful and thank you for watching.
Right. There are definitely, now looking back at my, there's definitely lots of mistakes in those. So don't look at my drawings. It's just, this is how to do the concept of how to trace if you were doing it by hand. I will stop sharing that one and we'll go back to my presentation. So that's on YouTube as well. So feel free to use that. As I said, we were always taught to use, we were always told to use Edding pens. But I just find that as long as you get a nice smooth line, I don't think it really matters what type of pen you use. Check your scaling, as I said, making sure that you print it out to scale because measuring things makes things a lot easier. I've talked about drawing dots and getting your tracings, making sure you always triple check. So the reason that I kept having to redraw things was like, oh, my incisors look stupid. Oh, I've done something wrong. Oh, this angle doesn't seem right. So by triple checking everything beforehand, you'll save yourselves a lot of time. So this is what I was just saying, making sure you're happy with everything. And copying the tooth shapes I've talked about as well. So as I showed you, those are my start is black, final is red. If you have post-functional, you add that in green as well. Things that can go wrong, I kind of touched about it in that video. So things like, would your molars move forward a whole unit if you've utilized all that space for an extraction case? No. So go back and check it. Making sure you don't add molars into your upper tracing, which is something that I did. Or if you've got funny looking incisors, just make sure that your incisors were right at the start. So, as I said, here's one I made earlier. On Monday, I learned another way. So it meant making another video for you guys because this actually almost blew my mind. So with how simple it can possibly be. This video is not 16 minutes long, it's about 2 minutes long. There's no talking, so I'm going to have to talk over it. So someone told me you can do it in PowerPoint. So you open, oh, hang on, am I sharing this? Am I sharing this now?
You showed it in the presentation.
So it's not the video, hang on. Presentation, video. This one. Am I sharing? Oh, it's starting.
Yep, this one.
So in this one, you actually open up the KEF in PowerPoint. And then this is slightly touching on what Richard was talking about in his presentation. So you go to insert shapes and you get curve. And then you basically, like he said, dot it out and draw out your outline, making sure it's blank, drawing it in black. And then if you've messed up a bit, you just use the squares to nudge it back in. And then making sure it's a nice thin line. And hey, presto, you've got a nice thin line of no blobs where you've stopped on your pen. Do all your outlines. And then check your scaling by getting your new KEF, making it transparent, and then you overlay it on your first. You can see I've overlaid it there. Zoom in, make sure it's the same size. And if it is the same size, great, you've got your scaling right from your start to your near end. Then copy and paste that onto a new and retrace the outlines. And so in my incisors, you can actually copy and paste your incisors. So you just copy that outline and you paste it into your new one. And you just change the angles depending, but at least you then know that your start and your end incisors are going to stay the same size because you wouldn't have changed those sizes. All right. And now this is my near end. So you just select everything, turn it red because it's near end. You put it all into one picture. So you group it as one picture, copy and paste it. Copy and hey presto, we have copy and paste there. You essentially have the superimposition. move it about a bit. Don't change the size of it, obviously, because you've got your scaling, right? But there you have it in 1 minute 55 seconds. So that is also another way that you can do it. I personally do like technology a lot, and I think that way is a lot easier than having to draw it out by hand. So I hope you don't mind that I gave you 2 videos, but I think that that was really helpful to me. So that's also on YouTube as well. So I don't have much left to say. Okay, so if you look at my presentation now, can you tell the difference between which one was hand-drawn and which one wasn't? Left is hand-drawn, yeah, hopefully because it's got more detail in it. The only problem when you do it on PowerPoint, I like to draw out my crown and my roots, but it's more difficult to do that on PowerPoint. I think you can do it, but you probably have to draw it out twice. When you draw a line, you need to start from one end to the start. So if you're doing like the maxilla, you've got to go round like in a certain way. You can't add points on one end or the other. And I think for the molars, you'd have to like draw out the outline and then draw another extra line to get the shape of it. But it's, as you see, it is possible. So I'll just quickly talk about my exam experience. So mine will be different to yours in the sense that mine was all online in 2021. It was spread over 4 days. And you can see treated cases and communication was on the first, then it was split up AM, and I did my written exam because I didn't do part A. I also had my MSc exam, which was treated and unseen cases 1 week prior to that. So I took a whole 2 weeks of annual leave prior to the exams, and I felt like I needed that. Most people in my year did take at least a week or 2 weeks off before the exam because you just need to don't worry about clinical stuff and just focus on the exam. Preparation advice, hopefully not too old to understand. Don't freak out, stay calm. And as Jad said, examiners are human and they want you to pass. So for me, I was a bit worried about it. When I sat down and did my exam, I had 2 really lovely examiners, and actually it was more like a conversation about my treated cases rather than an examination. Because you know your cases inside out. You would have traced the case 1,000 times. You would have had to rewrite your write-up 1,000 times. You would know that inside out. So that's why I think the treated cases are good, because it's one thing you can control in your exam. You should know what question should come up in your exam for the treated cases. And then for the unseen, so going back to your treated cases, what questions are going to come up? So I actually went through my case. We have Prof. MacDonald, and he does Wednesday evening seminars with us where one person presents their PDF or their write-up, and then he critiques literally every single line. My first page, I had a summary. So for example, that patient, I might just go back to this just to show. So my patients that I had, so let's go for this skeletal 2, for example. So 13-year-old, 2 div 1 skeletal 2. First question would be, why would the age be relevant? What's like timing of growth? How would that affect your treatment? 2 div 1, what's the classification, BSI classification? Say it out loud. Or what is a class 3? What is a class 1? Skeletal 2, how do you decide if it's mild, moderate, severe? If it's a reduced vertical proportions, why is that relevant? How can you tell if someone's got reduced vertical proportions? Talk about the structures. 9mm overjets, what's the IOTN for high or low overjets? What are other things you talk about? Twin block, why is it classed twin block? Give the original design of a twin block. What designs do you use now? Did you use a labial bow? Did you not use a labial bow? Why did you go non-extraction? Fixed appliances, what prescription did you use? Why did you use MBT? Retention regime, why did you use that retention regime? So even just from your summary, you can come up with at least 10, 15 questions that they could potentially ask you. And so that's what I did with mine. I went through the whole of my write-up thinking, what things could they possibly ask? And then that's essentially all the questions they can ask you in your exam. And the other things I was just saying, just stay positive. And even if you have one bit that goes wrong, don't focus on it, because you will do one unseen case and then go straight on to the next one. So if you bombed the first one, don't worry about it. Just keep calm and carry on and just focus on the present. When Richard was talking about he went for walks and runs and stuff, I'm a runner, fellow runner as well, so I can empathize with saying like, oh, if you want to go for a run afterwards, go for it. I wasn't the type of person to be frantically, right, I've just finished the exam. Right, let's go and revise some more. I was more like, let's go and eat some chocolate and go for a walk and watch some TV, things like that. So make sure you do have your downtime to chill. Talk. Yeah. I love Richard's idea of putting everything into a podcast and listening to yourself if you have a long commute. Your exam at the end of the day is all about talking. So you need to practice talking out loud. Practice with your friends, practice to your mum and dad or anyone else at home. Practice just sitting there thinking, right, I'm going to assess this patient in all three planes of space. I'm going to start with the profile view. I'm going to assess them using Kettle's method and with zero meridian. So you can see, even I'm saying it out loud, I can practically say it in my sleep now. You will get used to it saying that pattern. So keep practicing out loud. And that is essentially it. So if you have any questions, that's my links. I think my videos should be linked as well in the handouts too. Does anyone have any questions? I've stunned you all to silence. Right. Are there any questions online?
2 seconds. One of the people online said, I've got the impression, hopefully incorrect, there's a lot more details required for the superimposition tracing. Is the level of detail in the PowerPoint tracing sufficient?
I know someone who sat MAuth using the PowerPoint style. When she says detail, it's because I did this video on Monday night, so I didn't have time to be tracing out all the synthesis and stuff. I thought I'm just going to trace out the detail just to give you guys an idea of how easy it can be. Of course, definitely, you can sit there for longer and trace out the synthesis, trace out your coronoid process, trace out Bayesian or whatever you want to do. So yeah, that's not, the video isn't to say this is how you do MAuth Edinburgh. This is like, this is a technique that you can use to help you with your exam.
A question for the examiners, actually. What's the proportion of hand tracings to computer tracings? Do they see many hand tracings, and do you have a preference?
Can you tell? That's the question.
I don't have enough time to work out the percentage. Unhand trace, digital trace. Yeah, you should be very careful with the tracings in terms of smooth contours, etc. Fundamentally, got to be, it's going to be consistent with what you've done. Mechanics, and in the background, growth changes. And, I think Constance did a great example, but I would say, some of the growth changes were a bit extreme. I would say. But you need to balance that all up, and I think we need to get it checked by your supervisors and make sure everything fits together. It doesn't matter if it's hand traced or digital traced. Be consistent. That's the takeaway message.
Yeah, definitely getting people to check as well, because there's certain things that you won't pick up that your supervisors will pick up. Brilliant. So we're going to move on now to the clinical pearls. Give me a moment. Right, George, do you want to try presenting?
Yeah.
And make sure.
Can you see my presentation there?
We can, and we can hear you, George. So George will be presenting, as you can see, on enhancing night-eye wires and using step bends to extrude teeth. He'll have 8 minutes to present, and then we've got about 2 minutes for questions. So if you want to start, that would be great.
Yeah, so hi everyone, my name's George. I'm a trainee in Newcastle, and my clinical pearl is based on placing step bends in night-eye wires to cause extrusion of teeth when required. So as we're aware, there are multiple techniques which can be used to both align and extrude impacted canines. And this was excellently documented by Professor Fleming in a paper in 2010. Alignment can start early in treatment through the use of auxiliary appliances, so using things such as TPA with stainless steel auxiliaries, TMA fish rod technique, removable appliances with the use of elastics, magnets, and temporary anchorage devices. More traditionally, canines are aligned early in early to mid treatment through various mechanics, and this is in conjunction with fixed appliances. So again, these can include things like elastic traction, such as elastomeric thread like Zing String, or power chain using both the catapult and slingshot techniques. And this was documented in the Journal of Orthodontics in 2015. You can also use piggyback night-eye arch wires, which can further be enhanced by incorporating buttons incisally and adjacent teeth to increase the degree of arch wire deflection. And again, this was demonstrated in a paper in Orthodontic Update in 2018. You can also use stainless steel arch wire auxiliaries, such as ballista springs or other night-eye customized auxiliaries. However, when sometimes aligning palatal canines, there can be issues with just applying a buccal force, which is usually easier to apply than extrusive forces. So as you can see in this case, this was a case that I treated where I was aligning the upper left 3 with Zing String from an eyelet, and this has resulted in bunching of the mucosa and limited canine extrusion. So once tooth was in the line of the arch, there was minimal tooth available to place a bracket. One way of trying to extrude this tooth, where it's in the line of the arch, is by placing a bend in a night-eye arch wire to promote further extrusion, which I'll demonstrate now. So I've got a series of photos on this slide, and I've got a video on the next slide to try and demonstrate how this bend is placed. So like we said, one way of extruding the tooth with this presentation is by placing a vertical step bend in a continuous night-eye arch wire. So we would recommend the use of an 014 continuous night-eye arch wire. A bend is placed in the night-eye arch wire using light wire pliers, and ideally the bend that you place wants to be greater than 120 degrees, as you can see in figure 2. Once this bend has been placed, you then want to swipe out the bend so you can assess the amount of permanent deformation that you've achieved and adjust the arch wire as necessary. You're ideally wanting to aim for a bend of 90 degrees of permanent deformation once the wire has been swept out. Once you've completed this initial bend, you can then repeat the cycle again for other parts of the standard step bend, making sure that you overbend the arch wire and sweep it out again. Once the bends have been placed, as you can see on the bottom image, figure 4, you want to check the orientation of the bends, you want to check that the heights of the bends are kept the same, and you want to ensure that the arch wire is flat. You can then feed the arch wire through the eyelet placed on the tooth requiring extrusion, and the wire will resume the bent form as the tooth extrudes. When I've tried this technique before, I've just used light wire pliers, but when I was thinking about it, it may be feasible to potentially use something like hammerheads to help it be a little bit easier to create those bends in the wire. So this is the video, so I'll see if that looks like it's working. So you can see initially I'm placing a bend in the arch wire, and I've bent that greater than 120 degrees. Once this has been bent, you then want to just sweep out the arch wire so you can see the true amount of permanent deformation of the arch wire. In this case, it was less than 90 degrees. So again, I'm bending the wire further and then also sweeping it out again. And that should result in a 90-degree bend. Once you've done this initial bend and once it's been completed, you can then complete the remaining parts of the bend to form a standard step bend. So the type of bend is very similar to a step bend that you would use in a stainless steel arch wire, for example. Again, you want to ensure that once the bends have been swept out, that these are 90 degrees to each other. Due to the superelastic nature of the material, you have to overbend the night eye to achieve permanent deformation of the arch wire. You can then complete the last part of the bend, overbending it again, and then swiping out the bend to see what permanent deformation that you've got, adjust as necessary, and ensuring that everything's at 90 degrees to each other. Once this has been completed, you then just need to check that the bends in the wire are in the correct position and that the arch wire is flat before engaging it into the tooth. So this was the clinical example of the tooth requiring extrusion that I showed before. So as you can see, the upper left 3 tooth requires further extrusion. So in this case, we've used an 014 night eye arch wire, place a vertical step as I showed in the last video, and this has been fed through the eyelet. And you can see that as the wire has been fed through the eyelet, the arch wire has been deflected in this region. Within an appointment, you can see that the upper left 3 has been extruded sufficiently, and now there's enough aspect to the buccal crown to allow placement of a bracket. Now, there are various benefits and limitations of this technique. So the benefits are it's a fairly simple wire bending technique, which you can use to utilize the properties of night-eye arch wires, such as continuous forces, versus the issues of elastomerics, such as force decay. The night-eye step that you place can also maintain or increase the space that you previously created. So if you have steps which are wider than the interbracket span, that could potentially open up a bit more space. There's no requirement to bond extra attachments onto the contralateral teeth, and it has the potential of increasing treatment efficiency. For example, if you have canines at different stages, or if you need a night-eye wire for another reason, but you want an extrusive force to a canine, you can address alignment of one tooth and extrusion of another tooth at the same appointment. And there's also no lab step involved as well. Some of the limitations, so probably the main limitation is there is a potential risk of arch distortion or potential intrusion of adjacent teeth. Therefore, if you're using this wire, you might want to consider the use of a base arch wire with it. And also you need to make sure that the attachment on the tooth has a lumen orientated at the correct angle. So if the eyelet slot is vertical, you won't be able to thread the arch wire through the slot. So I'd just like to finally say thank you to Dr. Tara Mittel, who's a consultant in Middlesbrough, for his supervision and teaching of this technique. And then also thanks to Mr. Germain and Mrs. Walker for providing some of the photographs used in this presentation.
Brilliant. Thank you very much, George, for keeping our time. Brilliant. Does anyone have any questions at all? And anyone virtually? Brilliant. Well, thank you very much for that presentation, George.
Thank you. You're welcome.
Oh, there we go. Yeah, brilliant. Okay, so Krishna, I'm ready for you to start whenever you are.
Okay, perfect. Thank you, Constance. Hello, everyone. Welcome to my presentation. My name is Krishna Patel. I'm an ST3 at Guy's Hospital and Queen Mary's Hospital at Sidcup. And today I'll be speaking to you about what my clinical PAL is on increasing your accuracy in measuring spaces. So as orthodontists, we tend to do a lot of measuring, whether that's measuring tooth size, overjet, centerline discrepancy, overbite, crowding, arch width, or Bolton's analysis. And if you look through the literature with respect to measuring, it's all mainly done with either plaster models or digital models. A systematic review and meta-analysis by Ferreira 2017 found that digital models was the most accurate and reproducible way of carrying out measurements. So usually when we're on clinic chairside, the instruments that we'll tend to grab to carry out measurements are either a plastic ruler or a metal ruler and calipers. So my clinical PAL is something that pretty much everybody can implement quite instantly. It's quick, easy, and it sort of avoids a lot of guesstimation when carrying out measurements. And it's something very simple. It's modifying a plastic ruler to increase your accuracy. So this clinical PAL, I found it super handy for when I've carried out measuring spaces for hypodontia cases, for monitoring space closure and assessing my progress. And I found it really handy when measuring an overjet in a deep overbite cases, where I'll find that the ruler will often hit the lower appliance, and I'm usually guesstimating what the overjet actually is. So it's a very simple technique. All you need is a plastic ruler and some sort of appliance to be able to cut the ruler with, so whether that's ligature cutters or a pair of scissors. In this case, we've been measuring up to the wanted space for our hypodontia case was 7 millimeters, which was prescribed by the restorative team. So we measured 7 millimeters across the ruler, you cut it halfway, and then you bend it 90 degrees. And then you form yourself a space guide, which if it fits, that's brilliant. And you can now refer this patient for the prosthetic replacement. If it doesn't, then you either need to carry out further orthodontics to either to open or close the space. And it makes sort of the decision making a lot more binary, so you know where you're going with it. Again, similar concept with helping you measure the accuracy and monitoring your progress when closing space. And then secondly, as mentioned before, in deep overbite cases, you want to measure the overjet. Again, it's a similar concept. You use the ruler, but you cut along it, so you're reducing the width of the ruler. And then very similar, so either you can cut the small section off completely or bend it as you did previously, and then that will allow you to get into the very narrow space and measure your overjet. So I'd like to thank you all for listening. I'd like to thank Dr. Farah Padani for this clinical PAL and for Constance Wong for the clinical photos. And I'm happy to take any questions.
We did clap for you, Krishna. Sorry, I had the microphone off. Does anyone have any questions at all? Do we have any questions from the online panelists? No. Thank you for keeping on time as well, Krishna. So that's appreciated. All right. So if we have no further questions, thank you, Krishna. We shall move on to Afnan. Brilliant. Hello, Afnan. So Afnan will be presenting her clinical PAL on the retention of removable appliances.
Hi everyone, my name is Afnan Tahir. I'm an orthodontics trainee at the Eastman Dental Hospital. And today I'll be presenting my clinical PAL, which is titled Retaining Removable Appliances. This is supervised by one of our consultants, Ms. Acharya, and Dr. Damien Pierce, who I'll be talking about later in my slides. So just some background on the retention of appliances. A removable appliance that is well retentive ensures patient comfort and therefore this improves compliance. This provides us with a treatment outcome that is both effective and efficient. To gain retention, we usually place or clasps on certain teeth. For older patients, these teeth are usually the 4s and 6s. However, for younger patients, we are sometimes forced to clasp the Ds or Es. And these teeth often shed during treatment, and this compromises the retention and treatment success. Therefore, we have to be especially creative in our retention design for patients undergoing early interceptive treatment to avoid any disruptions during the treatment journey. With removable appliances, we often incorporate active components such as recurve springs, C-springs, or Z-springs to help us achieve our treatment objectives. For an active use of these active components, the URA needs to be seated properly with adequate retention. Appliances with double recurve springs sometimes become less stable anteriorly, especially with further activation. And as you might have seen in some of your cases, this results in the appliance and springs bouncing at the front. This decreases patient comfort and sometimes affects their speech, which may compromise wear compliance and eventually the treatment success. This is Clement. He's one of my patients. He presented with class 2 div 2 malocclusion with retroclined upper incisors and a retrusive profile with a deep overbite. He was in his late mixed dentition stage. We decided to start correcting his malocclusion with a URA with double recurve springs, and we were lucky to have the 4s and 6s to grip. So one day he comes to the clinic with this blue blob on his upper right one. And when I asked him about it, he said it was placed by his dentist, who is Dr. Damien Pierce, the person I mentioned in my first slide. And what you don't know is that Dr. Pierce is Clement's dad. So this is also a family-based clinical term. So when this was placed, Clement reported improved comfort and improved speech. And when we placed in the URA, it had good retention anteriorly. So here you can see the URA in position with the recurved springs activated, and they were not bouncing in the front. The appliance was retentive, patient was comfortable, and he was happy. And as we all know firsthand, that a happy patient makes a happy orthodontist. So thank you, Dr. Pierce. So our clinical pearl is creating physical retention stops to prevent any vertical dislodgement of the anterior recurved springs. This can be done with a flowable resin material, or as in this case, blue glue was used. So the advantages of this technique, it's quick, it's very easy to place and simple to remove. For me, I used a D-Bond burr on a slow hand piece, but you can use whatever available in the kit. It's cost effective because it doesn't need any special equipment. You can use whatever you have in your kit. It's adaptable because you can place it on one tooth or multiple teeth depending on what you need. It improves appliance retention anteriorly, enhances the patient comfort, and therefore improves treatment success. So thank you for listening, and I'm happy to answer any questions.
Do we have any questions? Do we?
One online.
Oh, we have one online. Brilliant, Neil.
The recurved spring, what dimension and what type of wire is the recurved spring on URA?
So for us, we use 0.8 millimeter for the double recurved springs.
0.8 millimeters. Thank you. Any other questions? No, brilliant. All right. Thank you, Afnan, for your presentation.
Thank you.
And now we'll be moving on to Kishan, who's actually presenting face-to-face. Ready to start whenever you are.
Good afternoon all. Thank you to the TGG committee for allowing me to present my clinical pearl. My name's Kish. I'm one of the ST3s based at King's College Hospital and St. George's. So this is a clinical pearl that I've used many a time on clinic to great success, and something that Liz O'Higgins, who's a consultant at King's, has showed me of how to improve retention of vacuum filling retainers. So VFRs are commonly prescribed following active orthodontic treatment for retention. It's commonly fabricated from 1.5 millimeter PVC of polyvinyl chloride sheets, which are closely adapted to plaster models. There's numerous advantages of an Essex retainer or a VFR. It's cheap, it's quick to fabricate, and it's got minimal chairside time. And its compliances was quite well tolerated in patients, and it's based on the fact that it's got improved aesthetics, and it has to also be retentive for compliance. So this is the conventional way of fabricating a VFR. We also use 3D printed models as well, which we make VFRs from, but commonly it's alginate impressions which are poured up in gypsum. Then any air blows are removed from the teeth, especially around the gingival margins, using a Lacron carver, and the model is trimmed. The undercuts are then blocked out with wax material. These are the undercuts on the labial surfaces of the teeth, and this makes removing the appliance off the plaster model and easier, as well as for the patient to insert it and remove it easier as well. The PVC sheet is heated and the vacuum is created to closely adapt the PVC to the plaster model, engaging the undercuts, and the VFR is removed and trimmed. So there are some chairside issues associated with fitting the VFR. It might be distorted and it might not fully fit. It might be inadequately trimmed, so it's sharp to the soft tissues, and it might apply undue pressure to the gingival margin, and that's when we see the blanching of the tissues. And finally, and this is where this clinical pearl comes into play, the VFR retainer might be unretentive, and that might be due to excess of undercuts being blocked out by the lab, so it just doesn't grip onto the teeth as well as we like it to do. So this is a VFR. Where it commonly gets its retention from is from the embrasure spaces. So the red arrows here point to the embrasure spaces on the labial and buccal faces of the teeth, but there's also some embrasure spaces that can be engaged on the palatal surface. So this is where the clinical pearl comes into play. So what we are proposing here is that we use this as a molar band remover, the sharp edge of the molar band remover to engage the undercut and to place a divot in the embrasure spaces to improve the retention between the teeth. So the sharp edge is placed in the space and a slight twist motion is placed to create a little indentation into the VFR. And then this is then checked clinically in the patient to see if there is an improved retention and if further embrasure spaces need to be engaged. As many or as few embrasure spaces can be engaged in this respect, depending on the clinical situation. So we've got a little video here, hopefully it works. And what we can see here is that we've got the molar band removers, which are engaged in the embrasure spaces, and slowly a twist motion is made to create a little divot, which then engages the undercut further, making the appliance more retentive. So there are alternative instruments. These are aligner dimpling pliers made by Invisalign, and dimpling pliers are commonly used to aid rotation of teeth or hold rotation in teeth in aligner therapy. And these can also be used to engage the spaces to improve the retention of VFRs. And the other appliance that we can use very judiciously is the spring forming plier, because it's got quite a sharp end and you can perforate the retainer. So there are cautions, like I said, excessive pressure placed with either molar band remover or the spring form plier can perforate the VFR, which compromises its longevity. And especially in weather like this, in the midst of winter, clinic can be quite cold, and that can make the VFR quite brittle. So when you are manually manipulating it, it can fracture. So running it under a stream of warm water, not hot water, we don't want to distort it, but warm water may aid its pliability. And finally, if we are causing excessive deformation in the embrasure spaces, the area covering the gingiva may come away from it, and some adaptation of the VFR might need to be made with digital pressure. So this is a really simple method of improving the retention of the VFR that can be done chairside. It's saved me from a remake many a time. Patients really appreciate it as they don't have to come back. And if it doesn't work, which it has worked in my cases quite well, if it doesn't work, then you've always got the plan to go back and remake the retainer if needed. Thank you. And
I have one question, I guess. Have you ever had to redo it? So you've done it once on a patient, and they've come back again and you've redone it?
Not necessarily. So when I've done it, do it in one or two embrasure spaces. Generally speaking, the retention is poor on one side of the retainer, so that's the area that you manipulate, and then you check it clinically. But at 3-month reviews, patients are really happy. And if at that point it's still unretentive, then we've made the clinical judgment ourselves. I've not had a patient come in to say that it's falling out.
Anything online?
One question online as well. You mentioned VFR has been made from PVC. Are you aware of any other polymers which may be used? And would any of these alternatives be less effective with this chairside technique?
Unfortunately not, but I don't know any more materials, but I am aware that the retainers can be 3D printed, and there are other materials. I mean, it's a clinical judgment at the end of the day. You know the material that you're using day in, day out. If you believe that that material can be used with this technique to improve the outcomes, then that's something that clinical judgment should say.
Brilliant. Thank you very much. And for sticking to time as well. It's always appreciated. So, last but not least, got Kelly. Yes, we do. So Kelly's presenting on mandibular bite turbos for the correction of anterior crossbars. So are you able to present? Yes, we have.
Yeah, just checking you can see it all okay.
Yes, we can.
Cool. So my name's Kelly. I'm one of the third years at Leeds and Chesterfield, and this clinical PAL is just looking at something really, really simple, lingual bite blocks for the correction of anterior crossbites. And my supervisor at Chesterfield is Professor Sandler. So just a little bit about the background. We often use removable appliances to correct anterior crossbites, but these obviously require a fair amount of patient compliance. They incur lab costs and frequent visits to the orthodontist for adjustment. We also now need to think about sustainability and the resources that go into our lab and making URAs time-wise and materials-wise. So the lingual mini molds are sort of a fixed approach and an alternative to using the removable appliances. Really simple, very predictable, and using fixed appliances allows for more controlled movement of teeth. So as illustrated by the photographs, composite is placed up to the incisal edge of lower incisors. You can use 2 to 4 incisors. And you want to ensure there's even contact on both sides, depending on the position of the upper incisor. Well, in this case, it doesn't even matter. Basically, they just need to be equal so that the bite can fit nicely. They're very simple to place, normal composite bonding, which we use all the time, and they're easy to remove with a tungsten carbide handpiece. It completely eliminates the need for a technician and provides permanent disclusion in comparison to a removable appliance, which young kids can take out. So the summary of the case that I'm going to show you now is an 11-year-old male. He's in the mixed dentition. He presented with class 3 incisors on a class 3 skeletal base. In this case, we opted for some interceptive orthodontics using a 2x4 appliance and use of the lingual bite blocks on his lower incisors. So we saw him back in, how do I not remember months? October this year, and he presented like this on clinic with his dad. His name's Jude, actually. So as you can see, he's sort of a pseudo class 3 incisor relationship with the retroclined upper incisors and the mixed dentition. In RCP, he was able to achieve edge to edge, which was helpful in this case. So we placed a 2x4 appliance and lower bite turbos lingual to the lower incisors. And in one visit from October to November, we managed to achieve a positive overjet and overbite, of course tenuous, but was still achieved relatively quickly, quicker than it would take for you to take an imp, send it to lab, have it fitted, and let things happen. So it's a very quick alternative. You can see the mini molds on the lower incisors. They are only placed for a temporary period of time. So on this visit, we were able to debond him, and that's where he finished at debond. So we still allow for monitoring of the developing dentition, with the understanding to dad that he can obviously outgrow this treatment that we've provided, but at least he has an improvement in his malocclusion. So that was Jude in October and Jude in November. So quite a lot of facial difference just from one very simple procedure that I thought worked really well for him. So contraindications for the lingual mini molds would be previous trauma to the lower incisors, previous root resorption for any reason, and immature incisors that may not have continued root development. If you do find that you're not wanting to use the lower incisors, you can, in some cases, use other teeth, but for him, it's obviously in mixed dentition. But you could try and use lower canines instead, which have a longer root and potentially less issues in relation to force. So in summary, for Jude, we were able to achieve elimination of the displacement, elimination of his crossbite, and achieve a positive overjet and overbite in just one visit. In this case, it was favourable due to his pseudo class 3 malocclusion and his retroclined upper incisors. And thank you for listening.
Thank you very much, Kelly, for your presentation and for keeping to time, because everyone's kept to time. Do we have any questions in the audience at all? No? Do we have any questions online?
Do the bite turbos place excessive forces on the smaller incisors, causing root absorption?
I think in this case, they do exert a significant force to the lower incisors. but it's on a temporary basis. And the aim in interceptive orthodontics is limited just to achieve the correction of the displacement. It's an alternative to using a removable appliance or any other way of using your mechanics, but I think they are only used for a short term. They're not intended to be on the teeth for long durations.
Brilliant. Thank you very much, Kelly. Thank you. So now we're just going to have a break for a few minutes whilst we deliberate. So if we get you to stop sharing something, thank you. Right, so we are back, guys. So I'm going to announce the winner and the runner-up. And basically the prize for getting chosen is that they get to present the clinical pearl at the BOC in September in London. So I'll say the runner-up first. So it was close, but there were actually some clear winners. No, it can't be close and clear winners at the same time. I'm just saying. So runner-up, I'll say first is Kish. So his was on improving retention of the VFRs. And then our winner is actually George. So on enhancing night high wires for K9. So well done. Well done, George. So you guys get to present your clinical pearls at the VOC. And that is essentially the whole of our day. So thank you everyone for coming face to face, and thank you for people for coming virtually as well. The CPD link will get sent out. It's really important you fill this out because this was our first hybrid event, okay? And we really want to know whether we want to continue this hybrid or face-to-face or virtual. So I think there's a section in the CPD saying, what improvements would you make to future courses? Can you write in that specifically saying, I would prefer this face-to-face, virtual or hybrids? And then we can take it from there, okay? Otherwise, I think that is all right. Can I also say a massive thank you to Neil. Neil has been helping us with the IT. Come and say hi. Thank you to Neil Hilliard. I don't think I could have ran this course without you. The whole oh, you're showing stuff, you're not showing stuff. It's oh, okay. So thank you very much for your help. And thank you very much to our speakers as well. I hope you all found lots of useful knowledge in all of it. And otherwise, we will wrap it up. So I hope you all have a safe journey home. And thank you to people virtually too.